Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. I hope you enjoyed the yesterday topics, and today we have very important topics. There is some just minor change in the schedule. We will start today with Dr. Saleh al-Shihri, but instead of starting with approach to febrile child, he will do it tomorrow at 8 o'clock, and he will talk today now at 8 about common mistakes in emergency department. Dr. Saleh al-Shihri, he is a pediatric emergency consultant, and he is the chairman of Department of Emergency Medicine at Prince Sultan Military Medical City in Riyadh. Just few announcements till Dr. Saleh Ridi, Saleh Ridi. Please, you don't have to write your name again on the chat. Don't write your name, please, because we notice few of you keep writing their names. This is one thing. The second thing, as I told you before, that you have to attend 70% of the lectures, so you will be eligible to get the CME hours, which is 24 hours. Dr. Saleh, is he around? Start now. And if you have any question, his lecture will be for 30 minutes. 10 minutes will be for questions and answers. And then I will do my lecture about head injury. Then Dr. Al-Madi will start. Okay. And if you have, he will talk also about orthopedic injuries. It will be 2 parts. Later this morning, we will have cardiac emergency again by Dr. Saleh al-Shihri. And I will talk about respiratory emergency in 2 parts. We'll highlight on most common respiratory disease we used to see in the emergency or in our primary care centers. Then afternoon, late afternoon, Mr. Hussein Al-Hababa will do the nursing station, and you can attend with him. As you can see, yesterday it was very beneficial, actually, station with Hussein. This afternoon he will talk about pediatric pain assessment and management, which is very important. And then he will talk about new things, subcutaneous hydration in pediatric patient. Dr. Saleh al-Shihri, he just called me. I think he will enter soon. Sorry for the delay. You know, this is the problem of technical issues that sometimes you may face. If you have any questions or anything from our last talks in the last from yesterday, I'm more than happy to answer you. Khulud, is Dr. Saleh ready? I can see the participant. Okay, Dr. Saleh, you have time. No problem. You can start in 3 minutes. We are waiting to have more people. Okay. Once you are ready, you can start, please.
Dr. Mohammed, can you see my slides now?
Yes, I can see your slide, but please make it in the big window. Yeah.
It's a big window now.
I don't know. I see it still the rest of the slide on the left side. Yes, now excellent. Go ahead, start.
Okay.
Recording in progress.
Saleh, you are entering the system from two
Can we start now, Dr. Mohammed?
Yes, you can start, please.
Yeah, it's okay, it's okay. Just I want to. Yeah. طيب بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه ومن والاه إلى يوم الدين. I just talk shortly about the common malpractice that can happen in pediatric emergency, and some cases it will be really can be missed, and it's really scary for us. And we, in this next few slides, we try to avoid the common issues there. Actually, the pediatrics common mistakes or malpractice, it's in America, it's considered to be number 4 mistakes because, because the pediatric emergency, you have hurry parents, angry parents, many kids, they are crying there. Sometimes you cannot organize your team and your shift, and you will be confused with so many cases there. Number 1 is neurosurgery, and number 2 is neurology, and number 3 is gynae cases. So malpractice lawsuits here, so it's 1/3 of American Academy of Pediatrics members had their name in the lawsuits, either to be they clear their names or they're progressing there or being solved before reach to the jury there. Emergency department, of course, here one of the highest risk area here, and keep in your mind that's 85%, 85% if suits been involved in the night shift, not in the morning, not in the evening, it's in the night shift. And this is maybe because of the, because sleep rhythms, you don't take enough sleeps. Sometimes it's crowded during the night. Sometimes there is no bed in the night. You don't have enough subspecialty. You can communicate them for that. There's so many reasons for that. Most of the cases had been solved outside the court. You see, most of the cases had been solved outside the court, and 10% reached to the jury there. Like, what's the commonest cases that can be missed in the emergency? Keep in your minds meningitis, especially in the young age. Appendicitis also, it's one of the commonest misdiagnoses in the pediatric. Fractures, hidden fractures, maltreatment or abuse a child can also be missed. Small fracture in the ankle that we think it's maybe sprain and later on being discovered as clear fractures. Testicular torsions, also ovarian torsions can be also one of that can be missed in the emergency. Also cases can be after treated in the emergency and discharged, like wound complications, develop infections, bleeding, oozing, compartment syndromes after discharge from emergency. Medication errors, either through low dose, high dose, wrong medications instead to write it for this patient, to write it for another patient, because you're not keeping attention enough to this patient, or because of the crowdness, or sometimes because we are depending on the trainees or the residents. So please write this medication, so I will make my mistakes. Myocarditis, especially cases of like gastroenteritis, simple gastroenteritis. That's patient who present to the emergency, like looks dehydrated, and we give him some fluid and discharge him. Dehydrations, why dehydration? Because there are so many studies there that many child who present to the emergency, they didn't receive enough hydration in emergency that they need. I'm not talking about mild or moderate dehydration. We are talking about patients who's having moderate dehydration that develop later on as severe dehydrations. One also thinks diabetic patients. Diabetic patients also can be missed, treated like a gastroenteritis, treated as dehydrations, and when we low carbs and present as decay to the emergency. Why people suits here? Why the people complained against us? Because either to have bad outcome, I discharged the patient, but he didn't improve. Actually, he's been deteriorated at home. Because of the emergency being crowded, so neglect care there. Poor communication between the physicians and the families, and family, they think they are not receiving enough information about my child. I came to emergency and he meet us with 2, 3, 5 minutes, and we don't know what's going on. Just take the medication and go to the primary care, go ask your physician, specialty, whatever. So many family they complaining about because the poor communication between the family and the physician. Also, many family they complaining against physician because they believe the physician they didn't listen to them well, or the physician looks under strain of the time. And my child is the most valuable between all the kids here. Why the people here sue here or asking for reimbursements, or I need you to what happened to my child to improve the care. So they're asking for money. Family, they're angry from the healthcare system, so they will be complaining. They're feeling guilty because they missed the child at home, didn't treat them well, so they want to displace that blame to the physician, to the healthcare, to the hospital. Some of the family, they believe that they need to save the next patient. If I complain against them, I'm going to improve the system and I will save other patients. Other significant also, they found that some of the relatives, especially if he's physicians or nurses, they will ask them to go complain against this doctor because he didn't discharge you on antibiotic, he didn't discharge you on proper medication, he didn't admit you, didn't refer, for example, for cardiology or endocrines for follow-up. Greed, one of the reasons, but don't think here. If they go to other clinic and that physician, they ask them to complain, so they receive advice from another physician there. So that's what happened in emergency here, why the people is complaining here. So there is a new system here of triage. It's depending on your sound. It's our new methods to determine who should be treated first. إذا كان الصوت حقك أعلى فأنت حتدخل أول. هذا دائما اللي people they think go to the crowd, the emergency. Once they shout, complain, they're going to be seen first. Now they don't know how to work with the triage. Also, this is because people, they're waiting for long hours in emergency here. So they are angry from waiting here. So the doctor will be with you in just few more 5 minutes and looks at the patient is getting older and still nobody sees it till now. This is one of our commonest problems here because of we have crowd in emergency there. So expect to see tons of people there in the emergency. So be careful, organize yourself, organize your teams. And this is why us in emergency, we are the most complaining against us. People, they're waiting for a long time. Impersonal registrations here, sometimes it's improper registrations or just take their name blindly and put their name, so the people, they will ask, is I'm going to be seen or not here in emergency? Also in emergency, because of the strain of the time, crowdy, there's brief contact with the physicians here. احيانا برضو كمان الكونكشن بيننا وبين الفاميلي برضو ما هي بجيده، فبنسمع منهم بسرعه مثلا، we will listen to them quickly. احيانا حتى بقول لهم بسرعه، اختصر الموضوع مثلا بريف. الفاميلي بي feeling shock sometimes انه انا جاي للامرجنسي اطلب العلاج واتفاجئ انه الدكتور بيطلب مني بس اعطني معلومات بسيطه and they will start the treatment. يعني ممكن هذه برضه تحصل كثير مع الهايلي educated families برضه. الفيزيشن سترينز برضه هي، وعشان كذا في ادفايس انك لا تبين للفاميلي انك انت تحت ضغط الوقت. هذه will not help the people, they will not give you an excuse. بالعكس هتكون ضدك. Here is the emergency and what it looks everywhere in the world. Patients everywhere, so everyone they think when I'm going to see him, how long I'm going to see him there. Here looks to very crowded emergency. The patient, you will see many residents here. They're reading textbook. Where's the bathroom here? Hot pizza is coming from the restaurants here. And here's the paramedics pushing this new patient and tell him good luck. And he's so scary from that view he's seen here. So we'll give some strategy of how to minimizing the risk. How to minimizing the risk of errors in emergency here. Always practice good medicine. Feel confident when you talk to the people. Don't feel rush. Communicate well with the parents and patient. Not only the parents, even the patient. Try to talk to him or her. And communicate well also with other specialties. When we talk to the pediatric, tell the family we already communicate with the pediatric like specialty. We already communicate with immunology subspecialty to need to fix this problem now. Document is very important. Document everything in your chart. It's the best lawyer for you. Next, document also. Third, document. Don't forget the documentations. It's a very, very important point in the emergency when you see any patient. Act reasonably. Don't act like scary or unprofessionals in front of the patients or the family. Consider the mother is concerned. Also, there is something called consider the mother concerns and believe what's going on inside your gut, inside your tummy. If there is something wrong with the patient, don't leave it alone and let the patient go. There is something there. Try to sort it out. Always look for red flag in the history and exam. Focus on the persisting vomiting, lethargy. Sleep a child here, be careful, especially in the night. It's the same like very sick child, especially the infants. You cannot differentiate well between them. Either to ask them to wake up or wait till they wake up and for next feeding. You need to assess them well, the child, before discharging. This is a strong advice when you have some concerns and the child looks well and you need to discharge him home. You can arrange follow-up. At least you can feel comfortable with the families and avoid some mistakes can happen with them later on. Look for the improvement and document it in your chart. Don't make a lot of excuses, and that's common in emergency. Oh, I'm sorry for that. We are crowded today. We are cannot see on the times. Don't make a lot of excuses. I call phone is busy there. The technical issues, we have problems now here like that. Don't make a lot of excuses. That's not exactly happened في أرض الواقع. Just comfort the parents and tell them everything is going smoothly. Inshallah, we're going to sort it out. Follow up the policies and protocols that you have in the area. If you don't have it, create it with your team. Supervise the trainees, and this is one of the most important points in the emergency. Don't allow the trainees to work alone, because if they lack of supervisions and they make errors, it will be reflecting in you. So that's the reason. Don't allow them to work free. You need to focus on that. We'll go to some cases here. This is a 13-year-old boy, and this is common in emergency. A 13-year-old boy present to the emergency department with abdominal pain He took paracetamol to relieve the pain. No history of trauma, allergy, or food. Their past medical history is normal or clear. They're having right lower quadrant pain since the last morning, and they're having nausea and vomiting, and no bowel motion since 2 days. Fever reached up to 39.3. Next, the pain was mostly in the right lower quadrant pain. And when the child moved, he's feeling better. And history of burning when he passed urine, but urine analysis was clear. Temperature was 39, pulse is okay, respiratory rate is okay, weight is okay for the age. Examination is normal, head and neck, chest, and abdominal, there's positive bowel sound, and tender right and left lower quadrant, and no rebound or no mass. Rectal exams was normal. Of course, most of us will think about appendicitis. That's clear for us, but look, this has happened in the United States. This is a real case, happened in the United States. How can they could visit? So the X-ray, the seen here, there is a small calcified mass in the pelvic. Do you know where is it? It could be appendicular mass, it can be renal stone. The contact radiology, he said it can be both renal or appendicular mass. I cannot rule it out. CBC done was normal. Electrolyte was done, was normal. Urine analysis was normal. الصوت يتطير. طيب let me see what's going on there. إذا في مشكلة في الصوت أعطوني خبر.
صالح، المشكلة في الصوت الظاهر يمكن عشانك مشغل الجهازين تو سبيكر.
لا الصوت الثاني مقطوع، ما بس هل الصوت واضح ولا مقطع؟
الصوت واضح بس بعض المرات يكون فيه شوي تقطيع.
طيب ممكن بس أغير المودم بس، اسمحوا لي بس دقيقة واحدة.
تفضل.
So my screen is okay there. Okay. It's clear now, the slide. دكتور محمد.
السلايد واضحة اللي فيها question mark.
اوكي الصوت واضح الآن؟
والصوت واضح ما شاء الله.
طيب أنا بس غيرت المود بس.
طيب.
So here is what do we think about this case now? Most of us, of course, will think about this could be appendicitis. Yes, but what's the progressive happened in this case? Do you think also in the renal dialysis, they repeat the urine analysis, given acetaminophen, IV fluid, and child was improving actually, and the pain is gone. There is no more pain, and he's taken orally well, and there is almost no abdominal tenderness there, and the impression was renal colic versus acute gastroenteritis. So what the scary things here happened here? He'd been discharged on oral fluids, and being discharged on ibuprofen, then steroidal. So this is one of the advice in the so many literatures and textbook. If you think about the patient having like appendicitis, try to avoid non-steroidal because ibuprofen is going to mask the symptoms and the signs of appendicitis to mask all the inflammatory process there. So what do you think here? So this patient ended up by perforated appendix and written back to the emergency, and unfortunately there was a problems with the team who discharged the patient. So review X-ray carefully because what you see in the X-ray, previous X-ray, there was appendicular mass clearly. If the ultrasound is not clear for this patient, go to the CT scan for that. Re-examine the patient frequently, document it carefully. Never discharge the patient and still having pain there, and you need to sort it out. Admit the patient if there is classical history of appendicitis for the exams, or there's abnormal lab, just refer it and call the surgeon for that. Case number 2 is a 14-year-old girl having complaining of shortness of breath for last hour, past medical history for asthma. She's having fever, 39.2, pulse rate 112. Respiratory, she's a little bit tachypnic, 40. She's feeling dyspnea, numbness hands and feet, and lung clear. Left shoulder and left lower quadrant having pain, numbness, tingling, fingers everywhere, difficult breathing. Later on, after 1 hour in emergency, had been resolved. Most of the symptoms have been improved. Now the complaint is only having pain everywhere, Malaysia. She have history of psychiatric visits in the past. And this is point had been confusing the team here. She looks alert, anxious, skin looks warm, dry, neck is normal, chest and heart clear, abdominal soft. She having left upper quadrant tenderness and extremities pulses. There is a full range of movement. So after 1.5 hours in emergency, the child feeling fine, want to go home. Abdomen was soft, joint was normal, no swelling, X-ray was negative. So the assessment was upper respiratory tract infections or viral infections. And here's the point. Don't easily using viral infections or upper respiratory tract infections, and there is no source for the viral infections. Don't make it easily diagnosed here. So the plan to recheck in the primary health care after 3 to 4 days. So what happened to the child? Later on, at 11 p.m., the child is unable to walk. The parents were unhappy. In the morning, she's unable to stand at all. And they went to the emergency and they found his blood pressure is down, is going to be hypotensive. Pulse rate was high, 120. There looks berberic rash here. So they think about maybe Henneschlein berbera, and that's been the final diagnosis and discharge home again. Later on, the diagnosis was meningococcemia, and this is one of the rare cases, can be present to the emergency and can be missed there. And unfortunately, we end up by bilateral below knee amputations for this case. So this was CBC was implicated here, and how to be helpful in our diagnosis here. Was diagnosis here reasonable to discharge home, viral infection, then Henneschlein berbera, 2 written visit to the emergency, and the patient is unable to walk. Was discharge being appropriately here, and what's outcome can be changes if the patient came to your emergency. The meningococcemia here, it's there in the world, it's there in the earth, but still not totally disappear. And difficult, very difficult to diagnose it. It can happen to any patient, even here in Saudi Arabia or anywhere in the world. It may be present without rash also. Also without meningeal signs sometimes. 16% present with the bone and back pain. So here the trick point here, what happened, try to avoid diagnosis of flu or upper respiratory tract infections, and there is no strong flu, this patient having viral infection. Don't discharge patient if still having pain or still cannot walking normally, or there is a big concerns, or he's still dizzy or confused from emergency. Case number 3 is a 23-month-old boy with no past medical history present to the emergency department with altered mental status. His mother reported that الشاهد كان موجود في المطبخ وكان بيلعب كثير في المطبخ و running out there. كان normal قبل ساعتين من ما يجي للطوارئ تقريبا. She said that he felt very warm and dry and he was unable to ambulate. She also mentioned he was very irritable. Suddenly, all of a sudden, she found the child is very irritable, couldn't focus on her as he was reaching out for things. So, يعني شكل الولد كأنه blind. He doesn't know where he is going there. And he looks hallucinated. She mentions she found a cup of household cleaners near to him alongside his older brother. فمتوقع إنه شرب حاجة منها. She suspects the older brother may give him what was in the cup. So this is a vital signs. the child having temperature high, 38, heart rate high, 140. He looks irritable, staring. He cannot focus on you or any person, and just cry. The pupils is extremely dilated, reactive pupils. The pharynx looks dry, and the bowel looks absent bowel sound. So, what do you think about this one? What you could think? So, given, because we think about effect of organophosphate or anticholinergic effect or whatever, so they're giving physostigmine, a dose of 0.2 milligrams per kg. It was administered over 5 minutes, but first dose was no change. So he given another dose of physostigmine, and after that he been improved. The pupils had been improved, the mydriasis improved, well, encephalopathic behavior, well, irritability had been improved. So what do we think? اللاب طبعا احنا ارسلت التوكسيك سكرين salicylic acid ethyl alcohol levels were negative, but here's the issues here. So we think about he's taking some intoxications or some medications like organophosphate or antihistamine or whatever, but still we don't have a big flow there. But here's the paracetamol level came to be high, 421. So given immediately an acetylcysteine loading dose and being admitted to the PICU, and this is what actually the child getting at home. He's taking double medications, which is considering about paracetamol and diphenhydramine, and he having toxic both. But he presented the emergency with the first with the diphenhydramine intoxications. If we consider that having double medications, we will end up by disaster later on. Like, for example, if we miss the child having given the paracetamol, that will be having liver failure later on. So the issues here, there is a big recommendations. If we do a screening for toxic, we'll ask also for salicylic acids and for the paracetamol levels also for any patient who presents to the emergency, because we don't know what's going on there. Always think about aspirin and paracetamol ingestions of suspected accidental and intentional drug toxicity. Case number 4 let's talk about the communication here. It's a 15-year-old feeling terrible, is having 3 times visit to the emergency, and be careful about the revisiting patient to the emergency في خلال أسبوع تقريبا أقل من أسبوع تقريبا. أيضا كان الديagnosis حق الemergency is flu, viral infections, then later on simple atypical pneumonia, and can be stress, whatever. The mother asked for admission. The physician replied to her that there is no beds available here, and the child looks well, and you can go home with this medication. That's fine. Mother was unhappy طبعا وراح مستشفى ثاني. She's been admitted there with bad pneumonia, and there is a big effusions also in the right line here. So here is one of the communications, failure to communications. 70% of the malpractice because of the communication issue here. We didn't consider the mother concern here. The communication style, clinical attitude, inadequate explained diagnosis and treatment. ممكن تحصل مشاكل الطفل بعد ما يطلع من الطوارئ. We need to explain to the parents. He having yes pneumonia now, but later on he maybe have like this. He may be distressed, desatting, changing the color of the lips, cyanosis. When the signs need to return back to the emergency. Fail to understand the patient and the family concerns, and the patient feel rushed here. Family who complain because about dissatisfaction with the patient-doctor communications, 13%, 13% of them, they couldn't listen, the doctor wouldn't listen to the family. 32%, the doctor doesn't talk openly, they feel something hidden there, أو الدكتور يعني بيخفي شيء. لذلك لما تسمع الأهل لما بيتكلموا معك دكتور في شيء علمنا، في شيء تخفي عنا، فحاول to be open، وحتى لو تفتح الإكس رايز وتوريهم اللابs and what's the working diagnosis with them now. 48% of the doctor attempt to mislead the family. They think the doctor tried to mislead about something. 70% doctor didn't warn about the outcome. طيب, the communication skills here, most of us we need to training for that. في courses can be done in many centers in the world. اليوتيوب برضه فيه a good opportunity to watch many people how to communicate with the patients and communication skills there. Because the patient satisfaction is the key here at the golden standard in emergency. Consider professional training, role training, patient advocate helps, and triage and registration is very important here because the patient, he will know his map and the time from starting point till being the disposition from emergency. Communication skills مع ED physicians يعني don't look unhurried appearance يعني لازم تكون شكلك professionals. الدريس، البوستشرز، المانرز، ما تقوم الصباح مثلا الشعر مو مشط، اللاب كوت مثلا اوبنز، الدريسنج از نوت لوكس كلير، يعني احيانا حتى الشكل مو فيزيشنز فيها الشوز برضو. many of the family they comment about the shoes of the physicians, why he's wearing the shoes either clear or dirty or not proper. Demonstrate your compassion. Apologize for waiting time. This is allowed. You can excuse from the families. Excuse me for waiting long time. I'm sorry for that. And you need to work with your patient now. This is your set now, and we're going to work with him now. Listen well to the family. Let them in the comfort zone. Speak clearly and simply and brief. And here also simple advice: if the family or the mother speak with you openly, try to guide her to be talking in the concern or the main complaint for this patient. إذا كنت زعلان, hide your own anger. Definitely, you need to anger it. Try to use tummy breathing to relieve your stress there. Tell the family what to expect. Keep the family informed. Don't blame the others. والله الدكتور هذا ما جاء كلمنا, التليفون ما يرد, الكمبيوتر عطلان اليوم, عندنا مشاكل اليوم. لا, هذا to be against you. Avoid joking, stray comments. خصوصا احيانا مع بعض التيم ليدرز مع ريزيدنت يبدا يعني زي ما يقولون في تنكيت او شيء زي كذا ما له داعي في الراوند. لا, focus in your work and how to manage the patient and how to explain the treatment for the parents. ما تحاول انك تستهزئ بكلام الام, والله انت الحريم خوفكم زايد, انتم والله بتتشكوا كثير, انتم والله عندكم كذا وكذا, ولا الابو مثلا والله انت شكلك تبغى تجيب الحرمه هنا ولا كذا. التنكيت هذا ما له داعي في الطوارئ. الكيم انجري فاميليز, على فكره انه احيانا الفاميلي they will not express anything for you now, but after 1 or 2 hours you will be surprised by the big complaints from the CEO or from the medical admin of the malpractice about that. يقول لك عندنا شهود على الكلام اللي صار. Discharge instruction. When you see the primary care physician, you need to instruct to the family. متى راح يشوفوا primary care physicians? متى يرجعوا للطوارئ? It's very important to instruct the family when they return back to the emergency, which is red flag or alarming signs. We need to be worried about it. خصوصا مع الفيفر. Review written instructions. Obtain the signature of the family about the consent and about everything. Medical records here. It's the best defense here. Be careful about it. It's very, very important here. Careful about documentation, history of illness, injury, physical exams, vital signs, time of the exams, order, and the procedures here. Patient exchange or improvement, reassessment. Always tell the chart about everything. Don't go to the court alone. Don't stay there alone. Try to write everything. You contact with this specialty, write it. You inform the family about this labs, write it. Be careful documentation, conversation with the consultant, with the parents. Report all the procedures and the test, diagnostic impression through the process, discharge instruction, dispositions. I like what of the seniors consultant said. When I saw the patient in 7 minutes, I'm writing my documentation in 15 minutes. So it's very important and careful about the documentation. This is one of the types of the documentation. So don't engage in the bottle. لا تتضارب مع الورقة حقتك. Don't engage in the bottle with your papers. Don't make a lot of blackout and race. Don't use a lot of abbreviations. Don't use unnecessary terms. انتبه من موضوع انك تغير الشارت later on, لانه اكيد راح تكون في نسخه اصليه في الموضوع هذا and will be totally against you. Telephone management here. It's ايضا سلاح ذو حدين انتبه منه. الريسك حقه more than the benefit. So many patients, they love to call the physicians, and many complaints because of inappropriate conversations. Some for the officer practitioners, but none for ED physician. Your job most of the time, tell the family how to come to the emergency or how to go to the primary health care. This is a case, it's a mother, 13-month-old boy, having 3 history of days of chickenpox. Now fever, bruise, ED physician didn't bring in for visit. They told him just give him paracetamol, prophylines, and he will be sorted out. This is clear because of the chickenpox, having fever, don't worry about it. But unfortunately, the child had been died because of the having group A streptococcal sepsis following the varicella. When you talk to the family, you cannot see them or you cannot see anything there. So your judgment will be, most of the time is wrong. So be careful about it. And most of the time there is no record for phone call. بس الفاميلي يقول والله كلمنا الدكتور قال لنا كذا، أعطيك في مشكلة في برا. Case number 2 here is about mother called, teenager son had scrotal pain. The nurse ردت and she said, doctor, would you call you back? الأم اعتمدت على الشيء ذا. Nobody called them back. Testicular was being lost from torsion because the mother, she's not aware about what's going on with the child. Shall I bring him to the emergency or not, or wait for the next day? So this advantage of phone management, that complete history is difficult. Physical exams, no way. Many distract in emergency. So you're talking to the mothers and you have many works you need to complete it before your end of your shifts, or you many patients, or you may have one very sick patient with you. You need to keep an attention on that. And instruction may be misunderstood. Documentation is difficult and follow-up is difficult also. What's the indication for phone management? Most of the time, how to tell the family how to go to the emergency. هذا يمكن أكبر job number 1. في حالات برضو indication poisoning, what you can give at home, how to start this ABC, make sure about the airway, breathing, suppression of the child, a life-threatening emergency, how to call the Red Crescent الأحمر, how to call the police, help the patient to get access to the care, patient who just left the emergency and you need to make some short follow-up with them. Telephone call here, try not to be a Superman here. كثير من الأطباء لما كانوا بالتليفون you like that, so don't be a superhero. آخر نقطة يمكن نتكلم عن الدامة, try to avoid it, لأنه ممكن he can go to another clinic they will found a different diagnosis than you and will be in trouble. So listen well and re-examine the patient well. Damas that allow in child abuse, life-threatening, parent disorientations. Tips here, be careful about using chest pain, abdominal aim, vague, ما في دقص واضح, fever, try to not use it, upper respiratory tract infections. انتبه من المرضى اللي cannot be amputated and discharge them home without clear diagnosis here or reason for that. Shift change, الهاند اوفر بين الساعة 11 بين الساعة 7 الصباح أو الساعة 8 whatever الهاند اوفر مهم. A lot of mortality and morbidity can happen at this time. If the consultant need, insist on help. Vomit انتبه منها دائما. Vomiting is not always GI pathology. It can be from the brain, it can be from the heart, it can be from something else. It can be bowel obstructions. Ask for help for complex wound. Don't be superhero and manage it alone. Read the notes of the other and describe the patient improvement in the discharge note. Listen well and talk openly to the patient and the parents. Provide high quality care and document carefully. And don't be like this guy here in this picture. Thank you very much. Any question?
Thank you very much, Dr. Saleh. I think now, because we are a shortage of time and there is no many questions, to be honest with you, I didn't find that much. So we will see if there is any question. We will discuss it later. We will start now with our presentation. The next presentation. Let me just make sure it is the right slide. Okay, yes. I'm going to talk about head injury in children. And this is, as you know, it is a very common presentation in the emergency department. And if you just give me 1 second. Okay. I'm sure most of you have seen these cases coming to the emergency like on a daily basis. And was it there? And this, yes. Is it in the, I don't think, I cannot see it in the screen. Yes. Sure. Okay. I think it's in the screen now, isn't it? Okay. So I will start now. First of all, I have nothing to declare. I will start with the epidemiology. As you know, falls are the leading cause of head injury in children, especially younger age group. And also, motor vehicle crash considered one of the major causes also of head injuries in children among all age groups. Male, obviously more than female, the ratio usually 2 to 1 across all ages. Also, we should look for shaken baby syndrome, and this is very important. We will talk briefly about it if we have time. And I think usually head injuries account for almost 3,000 deaths. This is in the United States. We don't have data here in Saudi Arabia, but it accounts for 3,000 deaths in USA. As we know that the population of USA is around like 300 million. And I think the number in our country is more in relation to our population, which is around 30 million. 29,000 hospitalization and almost 500,000 ED visit in the United States for children 14 years and younger with head injury. And most of those had significant head injury, as we mentioned, 3,000 deaths, and a good percentage of them, they will end by permanent neurological damage. That's why it is very important to know why we are concerned, why we took it seriously in the emergency department to manage and to approach these cases very quickly. The idea behind it is to prevent secondary injury, like hypoxia, bleeding, and that may lead to increased intracranial pressure and then herniation and then arrest. So it is very important to look for these signs and symptoms with the patient presenting to the emergency department with head injury. As according to the CDC, the severity of traumatic brain injury is typically defined by the initial Glasgow Coma Scale. Like we know that Glasgow Coma Scale 13 to 15 considered mild head injury. And luckily, most of the cases coming to the emergency department, they are in this group. It is about 80% of head injury, it is mild. This is luckily for children, but it is difficult for us as an emergency physician to manage these cases. It is easy for me actually to see moderate and severe head injury because we know what is the approach. But mild head injury, it is tricky. Sometimes some of the mild head injury will go into moderate and severe head injury if we didn't pay attention to these cases. Okay, this just to give you an idea about classification also, as I mentioned earlier, it could be based on the Glasgow Coma Scale, or it is based on the CT imaging, or sometimes either external or internal injury, if they are open or closed fracture, closed head injury. This, as you can, this CT, it is showed as you can see here very clearly. This is one of the most common types of severe traumatic brain injury. Okay, and this may result in death in children, and it's usually produced by significant impact, acceleration, deceleration forces. So, and this is what we call it diffuse axonal injury, and it is swelling, diffuse swelling, if you can see, and even there is a loss of differentiation between white and gray matter and on the CT. And coma with no hematoma is likely due to deep axonal injury. The next one, if you can see, I think some of you will know what is this. This is, we call it the subdural hematoma. It is common, actually. It is about 5 to 10 times more common than the slowly progressive, the one like epidural or the other severe type, the diffuse axonal injury. And it is sometimes we pick it up early and observe the patient, and most of it, the cases will need only conservative management, observation, and some percentage like will go into, may go and progress into epidural hematoma, which I will show you later. And usually this is in the area between the dura and the arachnoid membranes. And there are two major sources of bleeding usually which cause this subdural hematoma, which is bridging blood vessels that cross the subdural space, and cerebral cortical hemorrhage caused by direct brain trauma, or sometimes this is the most common presentation, I mean the most common CT finding on children with shaken impact syndrome, abusive head trauma. And usually they also present with retinal hemorrhage, and the outcome is really worse than the epidural. Then the next one is the epidural, and epidural, usually it is about 20 to 50% of the cases with head injury, those present, and it is like, if you can see here, the lucent, as you can see it, it is on this side, it's a lucent shape, okay, and it is known as extradural hematoma. And it is a hemorrhage into the space between the dura and the overlying calvarium. Okay, here. And it is due to most, commonly due to the disruption. It is an arterial bleed. That's why a disruption of meningeal artery, but sometimes also including the middle meningeal vein and venous sinuses. And if we didn't pick up these cases early, and usually they have like a lucid interval, okay, the loss of, fainting attacks, or for in most of the cases up to 50%. Okay, and if we didn't actually pick up these cases early, it may lead to ankle herniation and cause a significant problem in these cases. Stop breathing and have a problem. Usually it may associated with the skull fracture, and the outcome will excellent if we pick it up early and send them to the neurosurgery. The small one, the small type, they don't require surgery. Okay. Also, there is a basilar skull fracture, which is sometimes we cannot see it on X-ray. Okay, and we will talk about the X-ray indication in head injuries, which is not anymore recommended. And 40% they also not detected in CT, but we can detect it clinically by finding this, what is in the picture, like, for example, bleeding in the ear, internal ear, middle ear, hematympanium, or the battle sign, as you can see it here, or the what we call it raccoon eye, which is periorbital ecchymosis. We'll start now with cases, and I need the problem that I cannot hear your feedback, but it will be more better if we can have like interactive discussion for these cases. Let's start with this patient. This is a 12-year-old boy who slept on a wet surface, and he lost his consciousness for 3 minutes. And he was brought to the emergency department 1 hour later. His initial assessment, he had a normal vital signs, his Glasgow Coma scale of 14/15, and detailed physical examination was normal apart from small occipital contusion. So what you will do for this? I can't see anyone can tell us. Okay. For the sake of the time, I will go. So for like a 12 years, who is now completely normal, except he has a Glasgow Coma scale of 14/15, slightly confused. So how you will manage this patient? Would you do X-ray for this patient? Is there any role for plain film X-ray in the assessment of acute mild head injury in the emergency department? Some of you will say yes, some of you will say no. Those who will say yes, please raise your hand. I didn't see anyone raising his hand. Who will do X-ray for this patient? Oh, mashallah. We have now almost 20 people, they raise their hand. Okay, okay, stop. Who will not do X-ray for this patient? Who will not do X-ray for this patient? Yeah, I see more, almost like 30. Okay, so I agree with those who did not recommend to do an X-ray, because a skull film X-ray are not recommended anymore in the evaluation of mild head injury. Although the presence of a skull fracture increases the likelihood of intracranial lesion, but its sensitivity is not sufficient to be useful screening test. So we don't recommend actually to do X-ray on children with mild head injury, because sometimes even if there is a fracture, okay, it may mislead you, okay? And even if it is negative, the X-ray, because sometimes we do X-ray and someone will say, oh, the X-ray were normal. It doesn't mean the negative finding, it doesn't mean that he has no significant head injury. So no X-ray or radiological recommendation as per the American Academy of Pediatrics is not recommended anymore, unless in a special situation, like if there is any penetrating injury or like if you are in a places where there is no CT scan or there is nothing, actually you can tell, you can have to do it for the child, then you have no choice. You can do a radiological study, I mean X-ray. What is the alternative? CT scan. Okay, so CT scan now considered to be the the gold standard actually for doing CT, the gold standard for head injury, and it is very important because it can tell us, and it gives a very good image about the brain tissue. Okay. In general, we recommend to do CT scan, for example, in a patient who is Glasgow Coma scale less than 15, 2 hours after injury. And if there is a neurological deficit, or there is obvious open skull fracture, or there is a signs of basal skull fracture, vomiting more than 2 to 3 episodes, extreme age, for example, if it is less than 1 year, and now they reduce it to less than 6 months or 3 months, or retrograde amnesia, he didn't remember what happened before, or he has a severe headache, like he's coming holding his head, and this is very serious. So you have to go ahead and do urgent CT scan. So this is in general, and then we will go over the other criteria for doing. We have like some tools to determine whether you is it indicated or not to do like BCARN with this, which we use it, and there is a catch, and there is other Canadian American tools to determine if he met the criteria. If they meet the criteria, then you have to do an X-ray. So for the previous patient, I will do a CT for him just to make sure, because there is a history of loss of consciousness, and also he still his Glasgow Coma scale below 15. Case number 2, and this is a 2-year-old girl who fell off a swing and hit the dirt, approximately 3 feet below, and was consoled by her parents. She did not vomit, and her parents say that she seems to be back to her usual self. This is a 2 years old who fell off a swing on her head about 3 feet, like almost 1 meter, and she lost her consciousness for only less than a minute, about even half a minute. She cries immediately, and she was consoled by her parents, and there is no vomiting, completely asymptomatic when she presented to the emergency. So you examine her, and she has a 3 centimeter occipital cephalohematoma without a step off, no laceration or abrasion. Her vital signs were stable. Blood pressure okay, heart rate okay, respiratory okay. Glasgow Coma scale was 15, and she has no neurological deficit on examination. And she was and cries inconsolably when you approach her. Okay, she was anxious when you approach her, and she does not appear to have any other injury. How you will manage this patient? Yeah. Who will do CT for this patient? Please raise your hand. Who will do a CT for this patient? Please raise your hand. Those who will do CT for this patient. Yes, almost around 40 people. Okay, okay, stop. Who will not do a CT for this patient? Okay, almost the same number. Yeah, almost around 40 also. Well, so let us go and see, according to our guidelines, initial evaluation and management of a child with minor closed head injury and no loss of consciousness. This patient less than 30 seconds, so we almost consider it nothing. So although a history and an appropriate physical examination, we have to do a thorough history physical examination. This is very important. Also, this patient, according to the recommendation, the use of cranial CT scan, skull radiograph, or magnetic MRI is not recommended. This is for this patient. Okay, some of you will argue and say, but doctor, this patient, he has a history of loss of consciousness. I agree with you. If there is a history of loss of consciousness, according to some protocol, I think Karen, more than 5 seconds, you have to consider doing CT scan. So there is no problem. You can go ahead and CT scan. Other protocol like CATCH or the other child, they mentioned that if it is less than a minute, it wouldn't consider be like an indication to do a CT. Okay. As you know, and this is very important to understand that doing CT for every patient that coming to the emergency department, it is a high risk, okay, because of the exposure to radiation. As you know, we agree that the CT, it is still the standard of care, but the problem, and remain the gold standard, but the problem that malignancy risk from radiation from the CT is there, especially for those who are, for a younger age group, 1 year or less. It's been mentioned that it is 1 in 1,500, while for those who are more than 10 years or older, it is like 1 in 5,000. So it is less, but still the radiation risk is there. So we have to weigh the risk against the benefit. And please make sure, I know some families, they are coming to the emergency and they are asking for CT, okay? And if you feel that CT, it's really indicated based on the guidelines like CATCH or Chalice or Bikaran, then you can go ahead and do it. But still, we have some parents who will refuse also doing CT because they hear the word the radiation, and you think the child really needs the imaging study. So you have to try to convince them and to explain to them the risk of bleeding. But for those who, I think the more difficult will be for those who are coming to do CT. Doctor, we are here to do CT, please, for our child. And you don't believe that he needs it, and you think that this is not, he's not a high risk. So now you can use your knowledge by telling them, listen, we know that the CT, it's almost 400 times the X-ray, the ordinary X-ray. So just imagine how much radiation your son will be exposed to. That's why we don't feel that he needs it. Otherwise, if he needs it, we'll go ahead. But at this stage, he doesn't need it. So this way, they will be convinced. Okay. Here, this is just an just to give you. This is, I think, a Karen recommendation. Like, you know, if there is no altered mental status, this is for children less than 2 years. If there is no altered mental status, no hematoma, no loss of consciousness, no severe mechanism of injury like ejected from the car or death in the accident or from high fall from height, a significant height, or palpable skull fracture, and not behaving or acting abnormal, there is no need to do CT scan or any imaging study, because this will be like the incident of the significant clinically important head injury will be less than 0.02, and this is 100% specific and sensitive. If we go to children more than 2 years and more, the same also, if they didn't have all these signs, also you don't have to do CT, because the risk of significant or clinically important head injury will be very low, 0.05%, which is with 99.95% sensitivity. Okay, so this is the same what I have said before. Okay, for those patients who's coming with the brain minor head injury, as we mentioned, and less than 1 minute, okay, we know that only 2% around may require neurosurgical intervention. A thorough history and examination should be observation, and this is the most important. You have to observe them in the emergency department for like 6 hours. This is according to the American Academy of Pediatric guidelines. Okay, because if there is any abnormal finding, it will appear on his behavior within this 6 hours. CT scan, as we mentioned, it may be done, okay, since there is a loss of consciousness, and the use of skull X-ray and the initial management is not recommended. And also, most of the time, we are given instruction, printed instruction and red flags when they should come back to the emergency. Okay. All right. The last case, this is a 4-month-old who was brought to the emergency department, and the parents reported that he was vomiting after meals and sleeping more than usual, and not moving that much, okay, and not easy to arouse, lacking motivation. So what do you think? They didn't mention any history of head injury. Okay. So when I see this patient in the emergency department, honestly speaking, the family, they brought him and they said, well, he was vomiting after meal and sleeping more than usual. I will check if there is any history of like, you know, stuffy nose, blocked nose, any runny nose. And most of the time we label him as a viral infection. Okay. But the interesting thing for this patient, he came back like 10 days later or 7 days later. He came to the emergency and still he has the same symptoms. And he is, this time he is dehydrated because the mother, she said, he is always keeps vomiting and also after meals, and his intake become poor. So what do you think? Let me read. If somebody write, please, it will be. Okay. The one who will know the answer will give him 2 hours extra. Senior, yalla. Okay. Hawara al-Muslim. Hawra al-Muslim. Child neglect. You are right. She is the one who answered. Right. So this is true. So you have to think about child abuse. If you notice that his Glasgow Coma Scale score is 12, and usually we don't do Glasgow Coma Scale score for patients presenting with rollout sepsis or viral illnesses, but because his, you know, his neurological status is not normal, that's why they did this. Okay. So what is the diagnosis? Hawra al-Muslim, she read the diagnosis, which is child abuse. And how you will manage this patient? Oh, you see, because of his decreased activity, decreased intake, and he's coming for the second time, the physician there okay, was smart. So he said, let me do a CT brain for him. And you can see here, what is this? Okay, Yallah, will write down. This is, yeah, subdural hematoma. So this is shaken baby syndrome. Shaken baby syndrome, it is a very serious problem. And the most important, we have to understand, this is a preventable cases, and this is a preventable diagnosis that we can save these children. I remember in our hospital, we have seen a child who keeps coming, to be honest with you, with different complaints. One day he's coming with vomiting, the next day he's coming with decreased oral intake, the third day he's coming with history of trauma, fell down. The fourth day, or there was like 1 week episode before, and 1 week later they brought him dead. And when we exposed the whole body, we noticed there is bruises and there is old traumas, there is old fractures, there is old, injuries. So how can you forgive yourself? Because this is a preventable. You could save his life by. So you have to have a high index of suspicion for these cases, please. And this is very important. And so whenever you notice that the history is not compatible with what you are looking at, so you think of child abuse. And I remember also one time there is a mother, she brought her baby who was like 2 weeks old, and there was a burn in his foot. I told her, how did this happen? She said, well, doctor, we were sitting in the, on the ground floor, and she came and she tried to pull the cup of tea, and she fell it in herself, Excuse me, this is a 2 weeks old. She cannot move, she cannot walk, she cannot do anything. You have to have like a high index of suspicion when the history is not compatible with your finding. Right. Usually one of every 4 babies who is have this shaken baby syndrome, they died because of misdiagnosis. Okay, because we didn't pick them early. So 25%, they died. So this is a huge number. So we have to be careful. And almost all the survivors, they end up by having some consequences: mental retardation, developmental delay, cerebral palsy, severe motor function, some of them blindness because of the retinal hemorrhage, and some of them even seizure. But this is also the same. So how come? So when we should raise our suspicion of child abuse or shaken baby syndrome, if there is any infant or young child who presents with a history that is not consistent with the presenting sign and symptoms, or the presence of a new adult in the family, in the home, like for example, the mother divorced and she has a new husband, or the father has a new wife, or there is a new housemate, okay, or some, or the father, he has some abnormal, he's a psychic or something, all this should be considered. There is a previous history of suspicion of abuse. And also we notice that these family, they are having delay in seeking medical attention. They come and you notice there is a fracture and there is like all the bruise. Why you didn't come early? It is too late now, They said, well, we thought it will heal and it will, So this is also important. And the absence of primary caregiver at the onset. And there is also multiple injuries at varying stages of time and healing. Unexplained changes in neurological status, unexplained shock, or unexplained cardiovascular collapse. So this is very important. How we manage these cases, this is very important. We have to manage them. I think some of you had done like the ATLS guidelines, A, B, C, D, E, okay? and look for other associated injury. You have to examine the patient from head to toe and ask for a CT brain and CT plan CT of the whole body, and also X-rays, also labs, liver enzymes, and you know, chemistry, ophthalmology assessment. All right. If you suspect a child abuse, then what you should do. Some of you feel scared because they will say, you know, doctor, if I report these people as a child abuser, I will be in trouble. No, you will not be in trouble. What you should do now, I think in most hospitals, and Professor Dr. Mahal Munif, who established this is child prevention or, you know, protection. Now what you should do, there is a scan team in every hospital. You just involve the social service and you tell them that I'm not convinced this is like a normal complaint, but just I feel there is maybe a suspicion of child abuse. I'm suspecting only. Nobody will blame you. Okay? If it turned to be not true, nobody will blame you. They will be grateful to you that you, just to make sure. Okay? Because you will save lives. Just imagine if this child you have seen today, he will come tomorrow and he's dead. And they will say he came to XX or XY yesterday and they saw her, they saw the child and they left, they discharged them home. So this is very bad and you will not forgive yourself and you will be accountable for what happened to the child. Okay? And usually we admit these children to the hospital. So shaken baby syndrome, it's not only a crime, it's a preventable. This is very important. It's a preventable public health problem. And the emergency physician can help to prevent it by asking parents how they are coping and with their care for their child, okay? And you have to talk to them, how do they behave in case of stress? How do they behave when the child becoming more, you know, crying a lot, and you can sense that, you can feel, oh, they are become, you know, they have some aggressive attitude. So that's why you have to activate the child protection team. And you have to emphasize and explain to the parents, especially the new parent, that this is a normal behavior of crying and irritable because of infantile colic or whatever. Okay, so any questions, please? I think before Dr. Hamad Al-Madi start, we have like, oh my goodness, I think we are running out of time. Right, we'll leave the questions to the session. You can write your questions and we can answer it later during the break. But now let me see if Dr. Hamad Al-Madi, he's around, so he can present.
السلام عليكم ورحمة الله وبركاته. صباح الله بالخير دكتور.
وعليكم السلام ورحمة الله. طيب, let me just stop sharing and give you the time. Dr. Hamad Al-Madi, he is the pediatric emergency consultant and at King Saud Medical City, and he is also an assistant professor at Al Faisal University College of Medicine. Dr. Hamad will talk about very important topic, orthopedic fractures in pediatric emergency medicine. And he will be with you for almost more than 1.5 hours. Dr. Hamad, you can start, please.
Thank you, Dr. Muhammad. It is very important to have some skills and knowledge about the types of fractures, and especially we are working in the emergency department. You receive and we encounter many cases came to the ER as complaining for the fracture, which one is have to be referred to the orthopedic, which one is no necessary for this one, and you can reassure the parent and you can send to home. Will be my talk will be divided to two parts. The first part will be covering the upper limb. the common fractures in the upper limb, the pediatric age, and the second one will be cover the lower limb. I think it's a little bit tough because some pediatrician is not familiar to the orthopedic terminology and some common fracture in the orthopedic. Just to be focused in some important point in the fracture, how to be read the image, how to be make good assessment for the patient came to the ER with the fracture. So let's start. So it's very important to be familiar first what's the part of the bone. The bone for this bone, you have to be, this is divided to important thing, that's epiphysis and physis or growth plate, and metaphysis and diaphysis. So diaphysis, and it's very important when you speak about this one and to divide and to mention this one in the fracture. You have to be familiar where you have to read what's your comment about the fracture. So this one, the epiphysis, this is the, and this is physical growth or physis and metaphysis and diaphysis. So other important thing, you have to know about the blood supply. The blood supply coming from the epiphysis and metaphysis to the rest of the bone. In the infancy or the age from the 0 to the 18 months age, usually that's blood supply coming from the transfacial to the rest of the bone. So if there is any infection in the epiphysis or the metaphysis area, we can be spreading the infection to the rest of the bone and can cause osteomyelitis. So what's the content of that physis part? This one is multiple zone, this rapidly dividing and not yet classified. So it's very important to be familiar for this one. That's depend on that the growth of the bone is depend on the physis or growth of plate of that part of the bone. So the type of the fracture and especially in the pediatric age is there is special some concern about this one, and there is some unique you have to be familiar for this one. The pediatric is that the periosteum is very thicker and bone is more elastic and the muscle is more stronger than the bone. So you can find some different fracture type. You will not find this one in the adults. The torus fracture or buccal fracture, a grain stick or a bone type of fracture. So it's very important. Also, when you see this is the fulgen is not common to see in the pediatric and the adult because that muscle is more stronger. So is the fulgen can be present and confined in the pediatric age. So also that's very important to be familiar with the Salter-Harris classification for this one. This is the type 1. We cannot see in the X-ray anything. Usually the patient came with the tenderness, so you cannot see anything or finding in the X-ray. But Salter-Harris type 2, you can see this is the fracture or linear fracture is the proximal part or metaphysis part. And then we go to the third Salter-Harris will be in the epiphysis, but is not reach that metaphysis. When you're crossing the metaphysis and the epiphysis, this one, sorry, can be labeled this one as the fourth type, and the crush injury to the physical growth is the type 5. We'll go through the upper limb fracture. It's very important. So when you just describe that image, or that's when you see and you describe what you see, you have to mention this one. This the fracture is there is any displacement or displaced the two ends from each other, or there is any angulation for this one, or overriding for this one. So it's very important to mention this one in your report, and to when you refer the case to the orthopedic to be familiar what you mentioned in the report. Other important that assessment of the nerve supply. The nerve supply is sometimes can be injury during the time of the time of that fracture, especially in the elbow. So it's very important to familiar where is the supply to be make good assessment for the nerve supply. You know that nerve supply for a radial branch will be covered that's dorsal surface of the thumb and the index and the middle finger and part or half of the half of the index ring finger, but the distal part would be supplied by median nerve. The half of the ring finger and little finger will be supplied by the ulnar nerve. When you go the palmar surface will be remain of this all that's thumb and also the index and also the middle finger, and half of that half of the ring finger will be supplied by the median nerve. The ulnar same will be supply the half of the ring finger and little finger. So it's very important to familiar what is the supply to be when you make good assessment for that nerve supply to be make good assessment for the nerve. Also, you have to make good assessment for motor assessment for any patient came with the injury. The median nerve, you have to ask the patient to make finger flexion to be sure this is good and intact. And when you make good assessment for radial, you have to ask the patient to make good extension of the wrist and the metacarpal phalanx joint. And when you make good assessment for the ulnar, just to have to go, this is the the ulnar will be supplied the small muscle between that's between the metacarpal bone muscles with the so will be the ask the patient to be make good abduction and adduction of the finger. If you do that one, that's another motor nerve is intact. But about the anterior interosseous, you just ask the patient to make good flexion of the thumb and touching interference of the flexion of the index of finger. If you can do that one, that's anterior interosseous is intact also. We'll start first with the clavicle. Will be start from the proximal to the distal part of the upper limb. You know that clavicle is the most commonly fracture bone during the delivery. Sometimes present that neonate with the deformity, and there is he can't move one side. Usually, when the difficult labor, this one can be present with the fracture in the clavicle. The clavicle fracture is around 10 to 15 of all the pediatric fractures. He will be the fourth bone in the older children with fracture. Most of that clavicle fracture in the middle third, and usually can give the patient a sling for comfort for 2 to 3 weeks, and you can give something for pain, and that one will give good, excellent remodeling. You have to be asked to tell the parent is very important, and you have to warn the parent about that the bump or lump for this one, it will be developed and maybe can cause some scar later on. So to be the parent is familiar what will be going on with that patient. You have to make a good follow-up with the family doctor or orthopedic and around average for 6 to 8 weeks. Take long time to see that radiograph healing for this one. Sometimes it's better to be, if you find fracture, is better to be discussed with the orthopedic as to be taking good follow-up later on with the orthopedic. This study is comparing between the sling and old practice, this figure 8. He found this is figure 8 sometimes can be used or used to be as a part of the management of the patient with the clavicle fracture. And we compared this sling with the figure 8. We found in the 79 patient, some going with the figure of 8, the other one with the simple sling. You found that simple sling cause less discomfort and perhaps fewer complication than the figure of 8. So the function and the cosmetic, and this one will be similar to each other, but this more comfort and more acceptable for the patient. Will we start the proximal and distal clavicle fracture with, you know, that proximal fracture is not common as the middle, less than 2%, but usually involve the growth plate, Salter-Hurst type 1 and 2. If the clavicle displaced posterior, that means it will be make bad compression on the tracheoesophageal and make some discomfort. So it's better to be referred this patient and going for CT scan to the orthopedic. About the distal clavicle, same Salter-Hurst type 1 and 2, and often difficult to be distinguished from between if the patient has a chromoclavicular joint separation. And also this case is better to be taken good follow-up with the orthopedic and crucially if the patient unstable. What about the dislocation? You know, this dislocation is not common as the adult, but it's very important to familiar if this one happened for this patient. Usually the anterior dislocation is the common in the pediatric. What's the physical examination? You will be patient present to the ER. You can see this one. He lose of the normal rounded contour and with a slight abduction and external rotation. And the humeral head, you find this very palpable and to anterior of the glenoid fossa. So what you have to request, there is a special view for that patient present with the shoulder dislocation. You have to request X-ray for this patient, or it's better to be asked that technician to do trans-axillary view to be easy to see that glenoid fossa and also that head of the humerus to be clear if it is dislocated or not. Provide adequate analgesia, relax the patient before the reduction. And what you have to do, just to make procedure by either to traction, to counter-traction, scapular manipulation or external rotation technique. Both is succeed is good and can be get that the benefit from that technique. Immobilize after that the joint after that after reduction for 3 to 6 weeks and begin rehabilitation for therapy for this patient. Also, don't forget to examine the axillary nerve. Sometimes be injury, so I have to be make good assessment for the sensation and the deltoid muscle pre and post the reduction. About the proximal humerus, usually can happen in the age between the 5 to 11 years old. Usually start on the Salter-Hurst type 1 grain stick or torso or buccal fracture. But about the patient and from the 11 years to 15 years usually present with the Salter-Hurst type 2 injury. Most fracture heal well with the sling or swath. Just need some cases to close a reduction attempt or operative treatment depend on the age of the patient. When is different between the different age and different approach for this one. So the degree of the angulation and the age of the patient will be decide what's the good treatment for this patient and what's the good approach for that patient. What about the humerus shaft? Usually the proximal and the distal is the common than diaphyseal injury or the shaft. So we can see that's happen after a blow to the area. So can see that's a fracture can be happen for this patient. Also can be happen from that torsion for this one, force from the fault, or to be severe twisted, maybe a result of the spiral diaphyseal fracture for this one. Mid-shaft fracture heal will with the angulation between the 15 to 20, or if that's overriding 2 centimeter, can be healed without any need to be going for reduction. Use sling and swath for this one, young children, and sometimes you can use the sugar tank splint for the adolescent, but is not comfortable, is not recommended for the small age. So fracture involved just the junction of the middle and distal third will be can be risky for this injury for radial nerve. So you have to be considered and you have to make good assessment. Fat pad is very important for the elbow. So it's very important to be make good assessment for that. And you have to be see there is any fat pad. If his anterior is accepted, but when you increase this fat pad to be enlarged and can give seal sign, so is this one you can think this one is not going with the normal view. So also the posterior is abnormal. So it's very important to be consider any patient with the large or seal sign or patient with the posterior. So if you think about patient may has supracondylar fracture or other problem with the elbow. Other important thing, you have to make familiar how to make humeral line for this one. You have to, this is the humerus. The anterior humeral line would be have to be intersect the middle third of the capitulum distally, and when you find this one is cannot happen, that's you think about supracondylar fracture with this patient. So you can just make that anterior humeral line, and you have to be intersect this one. If he is not intersect this one, the capitulum, that means that patient may has supracondylar fracture. Other, you can just make the axis for the radius. You have to be, if in this one, usually that's the first one is in the lateral side or lateral view. Usually use this one lateral view in the proper angle for this one, a good view to be make good assessment for the humeral line. About this one, this is the radiocapitellar line. This is the axis from the radius, and you have to be dissect or bisect. This is the capitulum. If this not make doing this one, if in this change the flexion of this one, that's meaning maybe this patient has radial fracture or patient maybe has some dislocation. Supracondylar fracture is around 50 to 60 of the elbow fracture, usually from the 30 years to the 10 years old. Usually the mechanism of that patient is patient fall on the outstretched hand. This common mechanism can happen for this one is around 95 patient present to the ER. And we can classify this is the supracondylar fracture to three important parts, three types. The first type is non-displaced or just minimal displaced for this one. Like this one, you can, there is fracture and you can't, there is fracture, but non-displaced fracture. Okay, some cases maybe have minimally displaced, but accepted as type 1. Type 2 is displaced, but hinged on the posterior cortex. So still connected from the posterior cortex, maybe rotated as well, but still connected these two parts to each other. So like this one, you can see hinged in the posterior, but this patient is still, the two parts is connected to each other. So this is the type 2. The third type is completely displaced posterior cortex and disrupted. So it's very important when you see this image, you can see this is two parts is separated from each other. It's very important when you make good assessment for this one. Supracondylar fracture management, if he's type 1, you can just make a back slap and send home with the analgesia. Type 2 and 3 fracture is required to be going for operative reduction or internal fixation. I have to be discussed with the orthopedic. Most children have to be discussed with the orthopedic, and you maybe can go for this patient to be observation to be 24 to 48 hours. And I have to make good assessment for neurovascular status for this one, and to be reassessed frequently to be sure that there is any injury for this patient. Sometimes maybe can go for open reduction in some cases, especially for the third type for internal fixation. What the complication can happen for this patient? Usually there is a neurological injury from, it is around 8 to 15% of this patient with a supracondylar fracture, like injury to the interosseous branch or median, and some cases there is a radial to ulnar injury. Also can be injury for the artery. Radial artery can be injured. There is 2% of patient overall, especially for this type 3 is around 50% of that injury of radial artery coming from the type 3. Some cases can go for compartment syndrome. Later on, or for longer term for this patient, can be patient present with the capitis varus. Capitis varus, this deformity of that hand, this is the normal for this one, capitis valgus. Okay, this is the normal, this valgus, this common can be seen in the female, and this is the normal for this pediatric, or the normal for any patient. And when the patient just in or varus, this one abnormal. This can happen with this patient with supracondylar fracture as a complication for longer term. Volkmann's syndrome, Volkmann's ischemia can happen for the bone, and there is ischemia in the bone, and this can be ischemia can change in the bone. We can go for the lateral condylar fracture. Lateral condylar fracture is around 15% of the elbow fracture, usually present with the Salter-Harris 4. The age usually from the 4 to 10 years old, and the presentation of mechanism for this one, for on the outstretched hand, usually associated with the acute neurovascular injury, require aggressive intervention to prevent later the complication can happen, like non-union for this one, a loss of the elbow mobility and growth arrest, or lateral condylar phases, and can sometimes, if you feel very close to the ulnar, can cause ulnar palsy for this patient. What's the management? Usually operative. You can see this one is there is separation of the lateral condylar, and you can see it's very clear, very obvious for this one. Sometimes it can be confused with the growth plate, but you have to be, if you are doubt or confused, you can make comparing with the other side. Medial condylar fracture usually seen in the adolescent boy. Don't involve in the joint surface. Usually is not in the joint surface. You can you have to be check the ulnar nerve injury. some of the cases can be associated with the dislocation. What's the treatment? Usually non-operative. Usually, while it is very severe for this patient, you can, or there is injury for that nerve, you can consider the relative indication for the operative management. I think you see this one commonly in the pediatric nursemaid elbow. Sometimes that mother, she just pulled that hand and try to make avoid the baby from that in the street, or just to pull this baby, or try in the winter to struggling with, into the coat, or that when you try to um, um, into when you give make this, for this patient, and he present sometimes with he cannot move that same side, and that's happen if it is entrapment of the ulnar ligament between the radial head and the capitulum. So the mother, she concerned about the wrist more than the elbow. He didn't focus because the patient, he's just he pointed at the wrist. He think that all the parents, this problem is just from the wrist. Uh, Usually the age from the 1 to 5 years old, and there is a recurrence for this patient, can be recurrence. When you present to this AR, is very simple. Just you have two technique for this one, as to make hyperpronation or supination. Okay, you can put your left hand in the elbow and just make little bit traction. If it's not difficult to feel the pop for this one, you just make minimal traction, and you go for hyperpronation, maybe very helpful to make a reduction for that nursemaid elbow. If you fail, you can go for supination for this one. Mostly this 90% will be succeed with the hyperpronation. No need for go for diagnostic study or X-ray. This is usually classic history. If you find this patient no tenderness, no posing or edema in the elbow, it's easy to be just make a reduction and send home and reassure the parent. If the patient present with the equivocal this one cases and you doubting about that diagnosis, you can go for X-ray. About the fracture in the forearm, you can talking about the radius, it is and ulna, and it's very common to be present to the ER with this presentation. Usually 50% of the all fracture present to the ER, present with the radius and ulna, and the common part of that radius and ulna, this is the distal part, maybe around 3/4 of the presentation to the ER. Which one is can be leave this one alone? Which one you need to be going for reduction? Which one you have to be consult the ortho? So proximal radius fracture most common in the from the age 8 to 12, usually involve the metaphysis and or the basis, and not be radial head. Usually present patient with the Salter-Harris type 1 and type 2. Radial neck is not common to see the fracture as common in the presentation that they are. If the patient present with the radial head fracture, usually present with the Salter-Harris type 4. Usually in the older children, you can find this patient with the radial head fracture. Abnormal fat pad, as you mentioned in the beginning, also you can find that the line of radiocapitular line is very common to be abnormal. Usually, as mentioned, for that bisected the capitulum. If you not bisect this one, let's think about radial fracture or dislocation. Ollocranian, this fracture occur commonly in the combination with the other elbow for injury. Management, if there is angulation less than 15 degree, just put posterior slab and follow up with the ortho. If the fracture just or the angulation with 15 to 30, just give early follow up with the ortho and posterior slab. If he's more than 30 angulation, call the ortho immediately and for consultation in the ER. This one is montage fracture. It's very important to be familiar with the montage fracture. Montage fracture is ulnar fracture with the dislocation, proximal radial dislocation. With the patient will present with the deformity or blasted deformity of the ulnar can occur just about 70% of the patient with the montage fracture. Usually the patient 8 to 17% associated with a neurological deficit like posterior anterosseous branch or radial branch finding or injury. Usually you have to call the, for the management, you have to call the orthopedic to be managed by the orthopedic. Mid-shaft for radius and ulnar injury, when you have to go for a reduction, if there is any radial and ulnar angulation, both, if there is any rotation, deformity, that is patient with angulation more than 25 if the patient infant, children is more than 10, and if the patient prepubertal age need to go for reduction because this take time to be remodeling, not like other age or younger age. Was the displacement acceptable? If young, is much to is 90% for this patient present to the ER. So when you this more younger, you can accept more angulation. If the patient going to the around the prepubertal age, usually you have to be make good reduction for this patient. Other important fracture was very important to be familiar with this one, bone deformity. This will not remodel for this one. So it's very important to be familiar for this one. Must be reduced if visible deformity or restrict range of the motion. Sometimes it's very difficult for this patient and to manage. So you have to be attempting to make reduction for this one and check for all that supination and pronation. If lost of this is the range of motion or cannot do a supination or pronation, is very important to be going for admission and to be consult orthopedic and follow up for this patient. Other important, the facial injury of the distal part of the radius, usually Salter-Harris type 1 or 2. If the patient displaced posteriorly, this Colles type like fork, displaced this one posterior. If he's displaced, that fracture is an anterior, this is going with the if you're going to displace posterior, will be going this one displaced posterior, this one going with the Colles fracture. If it's displaced anterior, going with the Smith. This is less common to see this one in the pediatric. You can see this one. Colles is displaced posterior and Smith is displaced anterior. So you have to be familiar for this one. Smith is not common in the pediatric, but you have to be familiar for this type. When you can go for reduction, as you know, this reduction is very important, especially for distal one. You have to be very going to close for anatomical alignment for this one, and you have to be put the folar and tilting that folar going with the natural position for this patient to make minimum displacement for this patient, and need to be make good modeling for this patient. Need to call ortho if you cannot, difficult to make good correction for dorsal angulation. You have to, or more than 10% of this one displaced, you have to call the orthopedic for management. Galeazzi fracture is radial fracture with the distal radial ulnar dislocation. Is not common in the pediatric, but you have to be familiar with this one. Also, with this type of Galeazzi fracture, you have to call the orthopedic. Also, the metavasal injury of the radius. There is three important terminology in the orthopedic. Buccal fracture. Buccal fracture. There is one side, the other side is intact. For green stick, there is one side is there is fracture, clear fracture. And the other one, there is angulation for this one, and this is reach this one to the other side. So it's very important. Can be that green stick. If you leave this one not managed, you can go to complete fracture. So the prognosis of the buccal fracture is good compared to the green stick. So this cortex on opposite side, it must be unaffected. In the buccal fracture, they are stable fracture, so you can just make back slab or removable splint. Green stick is cortex fracture on the one side and the bent on the other one. So if you leave this one, you can go unstable fracture and can go complete fracture. The most common orthopedic injury in children, the distal fracture, distal radius, usually from the 6 to 12 years old. Usually the presentation, the mechanism, usually that fall on the outstretched hand. Tenderness usually offer the phases, and normal sometimes can be patient present with the normal X-ray, but this patient is still with the tenderness and he's not comfortable. So we think about Salter-Harris type 1 injury. Buccal fracture management can be treated by removable splint, and you can keep this 1 to 3 weeks. Complication is uncommon with this type of fracture. Green stick and complete fracture. We can go for reduction if this patient present with the radial or ulnar angulation together. And if there is rotational deformity with this patient present if the patient infant age more than 30-degree angulation, children more than 15 angulation, and pubertal age usually you can go for reduction because it will take time for remodeling, more than 2 to 3 years. Scaphoid fracture also is not common in the pediatric, but you have to make good assessment if the patient present with the limitation of the range of the motion and pain in the and swelling and the tenderness in the anatomical snap box. So patient can be present with the mechanism of the full on outstretched hand. Usually scaphoid fracture are most commonly encounter of the carpal bone fracture, and just apply a short arm thumb spica splint and refer the patient to early orthopedic evaluation. Metacarpal bone fracture, there is some types you have to go through that one. The fracture of this one, usually the neck is the most common area of the fracture. Most metacarpal fracture are the undisplaced or minimally displaced, and you can't treat it initially with this just immobilize and with the splint. But that displaced fracture generally can be treated with the closure reduction and splinting. There is one type of that fracture. This one is in the metacarpal boxer. Boxer's fracture, it can be happen in the fifth metacarpal bone. Can happen when the patient is fisted hand and striking the someone or solid object. Usually close reduction need for this patient if there's more than 30 to 40 angulation with this bone. You can see this is that is the fifth one. This angulation with this one. This is the boxer fracture. Usually can go for ulnar gutter splint, and you have to refer the patient to the orthopedic. Roland fracture, you have to be differentiated from Bennett fracture. Roland fracture is comminuted intra-articular fracture through this is the base of the first or that first metacarpal bone and of the thumb. Okay, and this is three distinct fragment. There is three type of three fragment of that fracture, and you can see this as like shape of the T shape or Y shape. Rolando fracture is less commonly than the Bennett fracture and associated with the worse prognosis. What's the mechanism? Mechanism for this one usually with the axial force applied to the thumb when he's flexion, make flexion, or blow with the fisted hand. So can be make good bad fracture for that first metacarpal bone. You can see swelling and tenderness on the base of the thumb with the limitation and range of the motion, and you have has some pain. You has to go for giving control for that pain and immobilize this one. You can put the patient in thumb spica. Some cases, majority can go for operative management. Bennett fracture also in the first metacarpal bone, but this one happened between the carpal and metacarpal joint. This is in the base of that first metacarpal bone with the extent into the carpal metacarpal joint. Can be going to the interarticular fracture is that most commonly fracture for the thumb, and the prognosis better than the Rolando. Always this is combined by some degree of the subluxation or a frank dislocation of the carpal joint, but still the prognosis is better than Rolando fracture. Scare injury can call this one gamekeeper for this one. Scare injury just only a tear in the ulnar collateral ligament of the also the ligament of the thumb and cause limitation and pain when you move that thumb. This injury can be happen when the patient is just pulled back by to the side and away from your finger. Usually when patient usually happen with that during the football. It's often happen when the patient or scare fall on the outstretched hand that's holding the sky ball. That can happen. This one is tear to that ligament or collateral ligament, and make swelling and make discoloration of that area. So it's very important to keep the patient immobilized and put the patient in the thumb spica. Middle and proximal phalanx. This is fracture usually in the happen in the Salter-Harris type 2 fracture. Common fracture of the little finger can be sometimes little finger. Proximal phalanx results on the extra octava finger. Octava finger, this one displacement of the little finger outside or lateral. This can reduce by fixation of the metacarpal phalanx joint and make good adduction for that finger and good splint for this one. Also, we have to be familiar for this also the distal part of the phalanx. The distal phalanx is millet, or can call this one Arabic. كان نقول يسمونها المضربة أو شو اسمه المطرقة أو الإصبع المطرقة. هذه is caused by the effulsion of the extensor. This is the extensor tendon from the distal phalanx or from the fracture of the dorsal base, just only the dorsal base of the distal phalanx. So this patient can be extension lack. It cannot do a good extension for the distal interphalanx joint, and this patient unable to be actively to be extend the distal interphalanx joint. Usually patient present with the Salter-Harris type 1 or 2 for young age, and the adolescent Salter-Harris type 3. You need for this patient close reduction and slight hyperextension for this one, and you have to consult the orthopedic. This is the first part for upper limb. Now we go for the second part for the lower limb. So you have to be familiar for this is the common fracture. Commonly can be seen this one in the on counter in your area. So you have to be familiar for this is the important type of fracture. Just 1 minute. Second part of my talk is very important, the lower limb. My slide is clear?
Yes, very clear.
So, lower limb fracture, we will start from the proximal to go to the distal part. Fracture is the will be start in the pelvis area. It's very quite rare in children, but usually, as mentioned by Dr. Muhammad, if a patient involved in the motor vehicle accident, one of the important assessment for this patient, you have to make good assessment for pelvis to be sure this patient no any fracture for this one. Usually, if the patient present with the fracture, usually is stable. If he is unstable, we have this patient with the pelvic ring where there is two fracture. Okay, this can cause unstable fracture. Also, stabular fracture are rare in children, but it's almost that associated with the hip dislocation. You have to go for routine AB X-ray for this patient. If the patient go for CT scan, no need or no indication to go for AB X-ray for this patient. But it's in general, its outcome is very good. Just only conservative treatment, no surgical management need for this patient. One of important that's effulsion for this patient, usually patient may be present with a effulsion fracture with the hip, usually the adolescent or patient playing with the sport, he be present with the severely pain and strong muscle, you know that strong muscle can be make bad effulgence for the patient, especially in the ischial tuberosity and anterior inferior iliac spine, or anterior superior iliac spine, or pubic symphysis or iliac crest. This different muscle attached this one and can be make bad effulgence for this one. So you have to make good rest, and then you have to make progressive range of the motion and strengthening of that muscle and with exercise and for physiotherapy for this patient. Sometimes non-union for this very painful for this one, and there is displacement more than 3 centimeters may require surgery and fixation for this one. You can see in this slide, this is some of effulgence can happen in that different part of the pelvic bone. That's one iliac crest can be make effulgence by abdominal muscle, or also the anterior superior iliac spine can be made by serratus muscle, can be made effulgence for this part, or anterior inferior iliac spine can make by the rectus femoris, and also lesser trochanter can be by iliopsoas or symphysis pubis by the abductor groove, or ischial tuberosity by the hamstring, or greater trochanter by the gluteal muscles. So all the muscles, different type muscle, and can be more strength and more stronger that bone, and so it can be make effulgence and make tenderness for this patient. For hip dislocation is very rare and less than 5% of all the dislocation in the age group, but you have to consider and you have to be familiar for this one. For patient or sporting injury due to the shallow acetabulum and increase the laxity of that ligament, so easy to be make a dislocation for the hip. So if the patient presents with severe discomfort and the shortening of the leg, and he's flexed the hip with internal rotation, can be the patient present like the presentation of the adult posterior dislocation without accompanying by the fracture, should be reduced within 6 hours. Why? By flexing of the hip to 90 degrees and providing axial traction for that thigh to avoid any complication or shortening of the muscle. Also, other important, you have to be familiar with this one, leg calf Behr's disease can be happen 1 cases every 3,000 children present to the ER with that's limping. The boy is more common than girl, usually from the age from the 4 to 9 years old. Usually can be hereditary or familial in this cases in around 20%. What happened for this patient Behr's disease is a vascular necrosis of the femoral head with the trabecular collapse secondary to the growth disturbance by the deformity, because cut a blood supply for that the head of the femur. What's the patient, how to present? Present with the pain in the area of the hip, referred to the knee. Sometimes the patient just present to the ER, he think that's problem from the knee. So it's very important to be consider a patient present with the knee pain. You have to make good assessment for the hip. Child can be walk with the limping and decrease of the hip range of motion. You have to go for frog position for this one and make a view for this patient to make good assessment. You can see in this image the contour of this the femur is shrink and distorted, the contour, and sometimes can be found in the X-ray like crescent sign the crescent sign will be can see in the remain of the contour of this one, and this cut of the supply to that rest of the head of the femur. So patient in the late can be irregular and flattened of that the head. So it's very important to consider when you see like this sign. Maybe the first sign, maybe the head is contour is normal, but it's wide one side to the different to the other side. You can see this is the contour of the head of the femur is different in the contour of this one. So is clearly this one is abnormal and the other one is looks normal for this patient.
Dr. Hamid, can you see your slide is not showing, by the way.
Sorry?
السلايد ما قاعد تبين الزملاء.
Is not clear. I will go, I'll stop the sharing. I will go back. Huh?
Okay.
Okay. Now?
Yeah,
Clear?
perfect. Now we
Yeah.
can see your slide.
That's clear now.
This patient you can see this contour of the femur is shrink, and he lost the contour of the head of the femur compared to the other side. Sometimes it can be present bilateral. See that contour of the head is compared to the left one is lost of the contour, so is clearly this one is distorted and completely looks abnormal compared to the other one. You have to consult directly to the orthopedic. Difficult management usually, this is difficult, it's not easy, and you have to will be take time and long time, maybe 1 to 2 years follow up for this one. You maybe need casting and bracing for this one. May sometimes can go for surgery. Also the complication can be severe degenerative hip disease in some cases, and require hip replacement by the middle age in 50% of cases. Slipped capital femoral epiphysis. This is one incident every 100,000 cases. We can find 4 cases, usually in the adolescent age. Can be present more than black than Caucasian people. When that increase the risk of that slip in the patient with the obese, also the tall and the slender or with higher risk than other group of people. What's happened for the slipped capital femoral epiphysis? This one usually that femoral head move or slips with the respect of the rest of the femur. So usually the femoral head is in the cup of the hip joint. You will not change the position, but the rest of the femur will be shifted and change. So what happened usually occur usually before the growth plate close, and usually in the maximum or growth spurt, you know, that's male from the 13 to 15 years old, and female from 11 to 13 years old. You can classify this is SCIF to acute or chronic or chronic. If the patient is stable, around 90% of the patient is present with stable, you can able to walk. Unstable patient and he can unable to walk, usually around 10%. This one patient you have to go and discuss with the orthopedic. Usually the patient stable with history of intermittent limping with pain several weeks or month. He can look poorly localized that to the thigh. Just he localized patient, he just pointed or just he think that's a problem from the groin or from knee joint. So it's very difficult to localize that tenderness or the source of the pain from where, or from the limbing from where. He has sometimes hip pain, but less frequently, but it's not common to find or to be clear, or so it's very fake history is for you. Also, any patient present with a limping with pain, you have to think about Skype, especially that's if the patient in the teenage and patient with chronic presentation of limping and no clear history of the trauma. If the epiphysis is continued to slip, the child lose of the hip motion, including the internal rotation and flexion and abduction position of that patient present to the ER. Unstable Skype is present with the extreme pain with often after that sport-related trauma, and he fall with the twisting injury. Most children have no proper history of symptoms, so increase the rate of this vascular necrosis can happen with this case for unstable Skype, and can be make a disruption of the epiphyseal vascularity. Usually the patient can present with the hip head on the abduction and external rotation, make limitation of the internal rotation. So you have to go for X-ray for the hip in frog position. You can find widen epiphyseal blade and displacement of the femoral head. You can see here the clean line. You can draw the clean line in the upper area of that neck, and you normally have to dissect around 10% of the femur head, the head of the femur. If we cannot, the clean line is not the dissect of the femur. This one is can label. This one is patient maybe has Skype. You can see the clean line. You cannot dissect any part of the head. This is the normal. Also can be present bilateral. When you make the clean line, also when you draw this clean line, he's not dissect anyone. Also the other one, but you can just make a follow up and assessment and refer it to the orthopedic. If the patient is stable, you have to be make a strict non-weight bearing, refer to the orthopedic surgery from the next one or from the next day for this patient. If patient is stable, you have to be strict non-weight bearing and admit the patient under the orthopedic. For proximal femur fracture, usually is less than 1% of the around the hip. Usually the complication can happen by premature, the physical closure and the vascular necrosis can happen. You have to consult the orthopedic. Sometimes with the proximal femur fracture can present with the effulgent fracture of the greater and lesser trochanter. Fracture of the femoral shaft fracture, usually in the middle third of the femoral shaft, and you have to make good assessment for neurovascular, and you have to go for pain control, splinting before going to the patient for X-ray evaluation. So what you can see for this one include that femoral shaft. You have to go make good X-ray for the knee and also for the hip to be not missing or possible dislocation or accompanying injury can happen with the shaft or fracture of the shaft of the femur. Orthopedic have to be involved, absolutely, and hip spike cast can be is good option, and some cases depend on the age of the patient. If the a younger age can go, and it depend on the rotation of that the part of that fracture. So hip spike one option for this patient, and maybe can go if this is patient with the more older children can go for the surgery for correction of this injury. About fracture in the knee, common injuries in the sport or patient falls or motor vehicle accident can happen. Some complication for this can cause growth arrest for this one, and can be progressive to make deformity and in that region. And also the distal femur can associate with the Salter-Harris type 2. So like this is a patient present with the type 2, we have to go for reduction, and can be occasionally pinning for this one and to show this anatomical alignment to be sure there's good alignment for this one. For proximal tibia, usually is not common. Why? Because it's protected by the fibula and the insertion of the medial collateral ligament. So it's not common to see that proximal tibial fracture. About the patella, it's rare to find or to present with fracture in the patella because large amount of cartilaginous or padding of this one. So it's examination for this patient present with IR. You have to examine any palpation of the bony prominence, faces and the collateral ligament and the distal pulse to be sure there is not fault in this injury. Also, don't forget the popliteal artery. Go for AB and lateral X-ray for this patient, and also patella view. Immobilize the patient and non-weight bearing for this patient, and you can go for follow-up with the orthopedic or sport medicine physician after 3 to 5 days from that presentation. I think is some here about this Osgood-Schlitter disease. This Osgood-Schlitter disease can be due to the avulsion or traction of the tibial tuberosity by the extensor mechanism. Usually sparse more in the boy than the girl. Common cause of the knee pain and active in the adolescent. Can happen bilateral, in some cases 25%. Management just only supportive, ice and non-steroidal, and this one will be self-limited condition. And the severe type, maybe sometimes severity of fluctuant of the severity over that 1 to 2 years period. Knee dislocation is rare in children, but can be associated with the popliteal artery damage, 40%, peroneal nerve injury, 33%. You have to go for reduction immediately and admission for this patient to avoid a neurovascular damage, and you have to check this one frequently to be sure this patient has any complication. Patella dislocation is common in adolescents, usually in the lateral dislocation, and the reduction usually can be spontaneously before also the X-ray. When the patient going with the full extension of the knee, patient go for a spontaneous reduction without any intervention from that physician. You have to make repeated X-ray for this patient. Can happen osteochondrial fragment from that frequent happen of that dislocation by the patella. The fracture of the shaft of the tibia and fibula, that's most common in the long bone fracture of the lower extremities. In pediatric, usually can happen from the high energy mechanism. Risk of this patient and can happen compartment syndrome, ischemia, especially in the fracture is more proximal, where the tibial artery is easily damaged. Other important fracture, tubular fracture, can be as occult tibial fracture and sometimes minimal mechanism or low energy mechanism, common in a young child with limping and refuse to walk. Usually present like this one spiral fracture of the tibia. We have to go and make X-ray for the AB and lateral. Usually is an impressive exam. When you examine the patient, he is not give any severely pain for when you make good examination for that patient. But the main and important symptoms, he is refused to walk or to stand. What you can put for this one, just above the knee cast for 3 weeks, and you have to make good follow-up with the orthopedic. Fracture of the ankle, the most important mechanism for this fracture, inversion and supination, which place the great deal of the stress on the distal fibula faces. Most fracture of this distal fibular faces are non-displaced. The distal tibia faces is most commonly injury in the Salter-Harris type 2, requiring reduction and maybe as combined by the grain stick fracture with the fibula. Ottawa is very important. You have to be familiar with Ottawa rule. Ottawa rule is just to be give rule for who's need go for X-ray for ankle or for foot trauma. If the patient is the pain in the malleolar zone or of the ankle, yes, you can check for tenderness at the posterior edge of that medial malleolus or in the lateral. He cannot unable to bear his weight immediately after the injury, or in the emergency department, or can do 4 steps. If yes, you can go for X-ray. About the foot, if the patient present with the mid-foot zone tenderness, if yes, you have to go for check for any tenderness at the base of the 5th metatarsal bone, and if there is any tenderness navicular bone, you have to make other assessment. A patient he is not able to walk or to bear his weight immediately after the injury, or in the emergency cannot make 4 steps, so you have to go for the X-ray. If no for both, no need for go for X-ray. This one assessment you can go or make for that patient 5 years old and older. About the distal fibula, Salter-Harris type 1, clinical diagnosis is very important. Widening of the X-ray often not to be appreciated. So if unsure, posterior slab and follow up after 1 week for reassessment. You have to fairly sure that below knee cast for 3 weeks, and maybe sometimes can put the patient in walking cast, may be very helpful and very comfortable with this one. What you can see, this one, you can see the like fracture in the lateral part of the tibia. How does this happen? This is talus fracture. Talus fracture. This one, sorry. Terafracture is that fracture of that anterolateral tibial epiphysis that's commonly seen in the adolescent. That's one fragment is pulled by the fibula. During that one, happen on the strong anterior tibiofibular ligament, and with external rotation injury for this one of the leg. If they cannot see anything, you can go for CT scan and call the orthopedic. Need closer reduction, maybe it's very important for attempt. And if you patient there is displacement 2 millimeter, you can accept it, this one. No need for any reduction or intervention for this patient. What about this one? What the difference between the previous one and this? This is trabecular fracture. There is fracture in the facial growth and also epiphysis and metaphysis for this one. So is part of this one is talus fracture and with the Salter-Harris type 2. Both can give Salter-Harris 4. Usually is mechanism forced external rotation of the foot of the leg. Is basically this pediatric fracture. Usually occur that's before the facial growth or closer of the facial growth. So usually the age of from 12 to 15 years old, male more the common than female. Usually affect a significant growth plate damage. 50% of the fibula would be there is fracture associated with the fracture with the patient. Management just also you can just consult ortho for evaluation and CT scan. Usually close reduction in 30 to 50%, and maybe patient over reduction and for internal fixation for this some cases. Last part for my talk, this is foot fracture. Usually the fracture, foot fracture in the metatarsal bone usually happen in the inversion of the ankle.
Dr. Hamad.
Yes.
You already exceed like more than 10 minutes, but you can have 2 minutes, please, if you can.
I have 2 slides more, but.
Okay, excellent. Thank you. Because we end by having question and answer soon. Yalla, go ahead, no problem.
Yeah, usually this is the happen in the metatarsal bone. If there is any inversion of the ankle and direct to blow to the twisting force and patient maybe is fault. The Jones fracture, this is the effulsion of the base of the fifth metatarsal during the ankle inversion injury is not common in the pediatric. Just will make go for reduction if necessary and immobilize this patient and posterior splinting. For this Lisfranc is happen in the metatarsal bone. Usually it is either by ligament broken or in the bone, maybe in the just only in the ligament, or sometimes in the bone. In the midfoot area can be make separation of the tarsal and metatarsal area or dislocation. Fracture on this markedly of tenderness and swelling in the midfoot for this one, and you have to go for the view of the oblique or weight bearing view. Can go, it's very important, maybe go for surgical fixation for this, like this scenario. About calcaneus fracture, really to be injured in the children, but if patient fall from the significant high, you have to go for AB or lateral or axial view. Sometimes can be see this one. You have to go for CT scan for this patient. Talus fracture is common in the neck of the talus fracture after a forced dorsiflexion. Usually, you can see this one. Talus fracture is common in the neck. Happen the anterior ankle pain, swelling with the inability to ambulate it. So you can go for posterior splint and non-weight bearing and follow up with closely due to the risk of the osteonecrosis for this patient can happen. Thank you.
Thank you very much, Dr. Hamad. I hope now you are all around, Dr. Saleh, Dr. Hamad. If there is any questions before we start our break, and I will review the questions of the. Okay, I saw one question. There is one guy who was asking about pneumococcal vaccine in a patient with head injury. Is it like a standard of treatment? I don't think it's really a standard of treatment. There was a study done in England. They noticed that a patient with open head fracture, some percentage they got like a pneumococcal meningitis or infection. That's why they advised to give pneumococcal vaccine for patient coming with open head injury. But it is according to their study, they need more and more studies to review and to either to make it as a standard of treatment or not. So this is, I think, the answer.
Yeah, I think the Iman, she said, you asked about humerus, if there is a patient with a spiral fracture. Did you raise this point of this patient abuse? Yes, you can think about, because this mechanism is just a twisting of that bone. Like this is mechanism, we think about abuse, and you have to think and examine other part, and there is any old fracture for this patient or bruising to be and can go for history, more detailed history to be sure this patient is not abused.
Okay, also I think there was a question by Amin Ahmed. She was asking, do you mean head x-rays? I think because when we talk about the minor head injury and head injuries, we are talking about the radiological studies. Yes, I mean the head x-ray. Head x-ray, it is not a standard of treatment or managing in patient with the head injury. CT now, it's the gold standard for imaging study. And this is in most of the hospital. But if you are in a hospital where you don't have CT and you have X-ray and you think this patient need images study like the breast skull fracture or something, you may do head X-ray. Okay. Is there any question for Dr. Saleh? Okay. I didn't find. Okay. Okay. One guy is asking about the CT in a very young age group, below 1 year of age. Is it indicated, especially there is no loss of consciousness because of there is some guidelines advising to do in extreme of age, like below 1 year of age, CT should be done, even if there is no loss of consciousness, no vomiting, no everything. Well, this is like it's been recommended in the past to be a standard, but recently I think you should use your clinical sense because now most of the time whenever we have even minor head injury, the family, they come to the emergency. In the past, they don't show up to the emergency. But now with the improvement of the health services provided to the families, they are coming even with minor head injury. If you remember, in old years, we've been having significant head injury and nobody even cared, the parents or the mother or the father. يستاهل, and you are sitting there and you will be okay. But now, okay, with the improvement of the medical services, with even minor headache, but for children less than 1 year, if he is presenting no, no loss of consciousness, no vomiting, and his intake and activity and behavior almost the same as before the head injury, just keep him for observation for like 6 hours. By 6 hours, even if there is like a minimal bleed, by 6 hours, the symptoms will become more profound and more clear. Then you can consider doing a CT. Thank you very much. Is there any other question? Yes, there is a question for Dr. Saleh. Dr. Saleh, you are with us? Dr. Saleh.
Yes, Dr. Mohammed.
Yes, there is a question here from Osama and Nasser.
Okay.
I hope he is Osama, the one I know. I have a question for Dr. Saleh regarding yesterday's topic of seizure. Is it true that the incident of seizure increased after corona due to children has poor sleeping and stay long time in screen, etc.? Okay, which exhaust the CNS system. Personally, I face it a lot since corona started. Well, this is a very good question. What do you think?
After corona, we see everything, all the old diseases written back again. Even the meningitis, we start to see it again. Septic ill child, we start to see it again. And many of this contributed to the lifestyle. Also the vaccines, most of the kids, now they're not receiving their vaccines regularly. That's why we are start to see again the strep and the bacterial meningitis again. So many things different, and we start to go to the old. We are going to our old school again for that.
I see. Okay, and this is
Recording in progress.
sorry.
Some I think Reem, she asked about polar angle for pediatric. Is same in children. She asked about this one. Usually is we not use this polar for this pediatric. We usually use the mortis view, like inversion of that foot, this one with the make good like almost like oblique view for this one, but polar is not commonly used for to rule out some fracture for the ankle joint. Especially with this is what I know about this is in children and to rule out any fracture in the ankle joint.
Here another question from Osama. Another question about appendicitis. I review a surgical systemic review analysis with paracetamol and non-steroidal will not mask appendicitis pain. Do you personally advise it for patients appendicitis to give fleet enema, especially if the abdominal pain not classic? Meaning, is it true that fleet enema can rupture inflamed appendix? I tried to find an answer. Theoretically mentioned it's contraindicated, but by expert surgeons said fleet enema has low pressure that will cause rupture. Well, I don't know this question directed to whom, but for me personally, one of the differential diagnoses we face it in the emergency department when we are facing picture of abdominal pain and appendicitis query. Most of the children, to be honest with you, especially in our society, more than 80–90%, those who are presented to the emergency department, they have functional constipation. And the problem that the resident, or even sometimes the fellow, when they ask about the bowel movement, they used to answer, no, he just passes stool. And he said, okay, he has no constipation, which is wrong. Even if he just passes stool like an hour ago, still he could be constipated. Because, you know, the problem, the definition of constipation is difficulty in passing the stool or straining during, you know, bowel movement. And I have seen cases, you know, they just pass a stool and we did an X-ray and it is full of impacted stool, okay? And, you know, the typical presentation of abdominal pain with constipation, it is on and off pain. That's why if you have doubt, but appendicitis, most of the time, the typical appendicitis, usually once you touch the right lower quadrant, it is positive. They cannot, you know, stand and set. And now with the advanced use of the ultrasound, it may help. And Dr. Hamad, he can highlight on this. But I think given fleet enema, if you are doubting your diagnosis of appendicitis, it won't be a problem, and we use it sometimes. I hope this can answer your question. Because we will start at 11:10, so we can be on time with Dr. Saleh, cardiac emergency. But if there is any more question.
Also, the Mesono fractures can be happen in ischiasca in the children. It's not. I'm not familiar for this one. It's happened in children or not, but is what I know. This one Mesono fracture happened due to a combination of the fracture with the proximal fibula and a stable ankle, and dislocated of the fibula. Tibial ligament, distal part, but I didn't know how it's common in the children for this.
Yes, any question, please? Any questions, guys? And because the system here, it cannot. طبعا البعض يسأل انه ما استطاع انه يحضر بالامس. طبعا هذا depends on the calculation. It's better to have more than 70% of the time of the lectures to be eligible to get the hours, the CMA hours. For those who has an excuse, maybe we will try our best. Otherwise, I cannot promise you, but we will do our best, inshallah. There is a question here. Is antegrade amnesia is assuring in contrast to retrograde amnesia and head injuries? والله يا إيمان يعني ما شاء الله عليك. You have very interesting questions. To be honest with you, I don't know the answer. Okay, but we know that there is a sudden memory loss. It is more common, you know, the retrograde, which is with head injury, and it is like a memory loss of the before the head injury, but after the head injury, they cannot remember. I cannot answer this. I'm sorry. سؤال هنا يقول لك احنا بنتسجل اننا حاضرين بمجرد الدخول ولا لازم نكتب اسماءنا في الشات؟ ايوه، اللي يكتب اسمه في الشات ما راح ياخذ ساعات، لان احنا مليون مره قلناها don't write your names on the chat. يعني مجرد ما تدخل انت في السيستم وتكون معانا automatically your name will be reflected that you are already attending, so you don't have to write your name في الشات please. تمام؟ طيب بعدين من هذا anonymous attendee please write your name like the rest of the group. Okay. طيب I think now we should start so we can Dr. Saleh, are you ready? Dr. Saleh
Yes. Yeah.
So now Dr. Saleh al-Shihri will talk about so we can run
Just give me 2 minutes. I want to put the slide now.
Okay, put the slide.
Okay.
So I will go back to the question and answer to see if there is any questions. بعض الزملاء يسأل يقول دكتور أحيانا يفصل معي بس أرجع أسجل من جديد دخول بسرعة، يعني ما غبت هل يحتسب الحضور؟ نعم يحتسب بإذن الله يحتسب don't worry. Okay. واللي تواجهه أي مشكلة في الساعات أو تواجهه أي مشكلة في الحضور أو يقدر يتواصل مع السبورت سيرفيسز اللي بنفس الشركة الجلوبال فيجن و they are more than يعني happy to help you and to support you. طيب now I will ask Dr. Saleh to start talking about very important lecture, cardiac emergency. Dr. Saleh, you can start, please.
طيب الصوت واضح؟
ما شاء الله واضح. Go ahead.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه ومن والاه إلى يوم الدين. I would like just first to thank Dr. Hamad. Actually, I was very interested with his lectures. Also, Dr. Mohammed Al-Fayfi. It's very enjoyable صراحة البرزنتيشن اللي سواها عجبني. In next 30 minutes إن شاء الله we'll present briefly about the common acute cardiac emergency that present to the pediatric emergency area. طبعا الobjects here will list the common presentations of the cardiac related to the emergency, and you will see most of it. It's not clear. You need to have more sensitive to pick up the common symptoms and signs there. It's being confused with other differential diagnoses like lethargics, like child abuse, like sepsis, pneumonia. So you need to sort it out in the emergency and quickly. Second, describe the initial evaluation and treatment of the child with potential cardiac emergency. And we will discuss a few things about the ECGs and the radiographic there. The overview overall, we are dealing with it is about structural and congenital heart disease that can present to the emergency, which is account for 8 to 1,000 live birth. So expect if you see like 100 patients in ER, you may expect 1 patient being discharged from NICU or from the gynae with after delivery with no diagnosis of the heart disease. Most of the cases present during the infancy, less than 2 months. It's more common in the preterms, and it will be high 10 times due to the genetic cause. The presentation of the cardiac will be diagnosed from after delivery or undiagnosed. We will talk here we will be mainly concerned here about undiagnosed cases. Either the cases have been treated with cardiac medication, anti-failure medications, or have been untreated. It's either medically, surgically. It can be presented also with cyanotic or acyanotic heart disease, sick or not sick. Also, we'll deal about some common of conductive electricity in the heart, like supraventricular tachycardia, prolonged QT interval, which is common, unfortunately, being missed, diagnosed in emergency, digoxin overdose. Or in elderly child, we can talk about acquired like Kawasaki, myocarditis, and cardiomyopathy. Just in brief here about the fetal circulations, why we sometimes highly concerned about cyanotic or acyanotic heart disease, because you know the baby is maybe taking his oxygens and nutrition from the placenta, and he doesn't have a lung is still not yet still functioning. So still we are highly depending intrauterine about the BDA, beta ductus arteriosus. Beta ductal arteriosus functionally will be closed within a few hours after birth, from 6 to 12 hours. And it may be to take anatomically closed up to 2 weeks for that. Some of kids, they need it to be open, and we should not allow it to be closed. And the main factor to close the BDA is the oxygens. Once he's breathing and start to enter the oxygen to the body, the BDA starts to be closed because there will be no more function for this. The common presentation here, it's really vague, unclear. It's ranged from respiratory distress, tachypnea, tachycardia, cyanosis, dysmorphism, lethargic, decreased oral intake, sweating when he is feeding, range of the temperature of the child. He can be present like septic shock symptoms, seizures, sudden death, abdominal pain, chest pain. In the examinations, we'll mainly concern about diastolic. All diastolic, always is pathological. Never been diastolic being physiologically, all pathological. Thrills, symptoms of heart failures, most of the time it's never been sudden, it's been gradual, started by poor feeding, because it's the main exercise the baby is doing, the poor feeding. He can be sweating from while he's feeding, irritables, chronic cough, weak crying, fuzziness, irritability. Even the mother, she came to you after 2 months or 3 months, she tell you, my baby is not gaining weight. So this may be symptoms of heart failure. The presentation with potentially cardiac problems, we'll talk here a little bit about cyanosis. Either can be central, peripheral, or combined. Central, that's mean less than 5 grams of the blood being desaturated. So expecting the child having severe anemic, you will not be cyanosis. The main sites for that is the lips and mucosa and the nail bits, and the temperature of the child will be warm. Peripheral, many causes for this, especially with temperature variation, environmental temperature variations. It's mainly because of increased tissue oxygen extraction. Peripheral extremity, circumoral, and the patient usually is cool and come down. Combined, it can be central and peripheral, and this is one of the worst diagnoses ممكن تشوفونها في cardiac disease, what we call it hypoplastic left heart syndrome, also severe coarctation, aortic coarctation. Central cyanosis, why it's happened? Because the blood is not receiving enough oxygen. بمعنى انه فيه blood is passing from right to left shunt without passing to the lung, either from inside the heart or from the vessels, or it can be inside the lung by itself. It will pass through the vessels, so it will not pass through the alveoli. It can be also non-cardiac cause, more common, either toxic or from the pulmonary because of ventilation mismatch. Also, you expect from the kids who are receiving many doses of Ventolin, so you expect to have some ventilation mismatch also there, and hemoglobinopathies. So ductal dependent lesions is very important here for those kids who's highly dependent on that. Suspected in any infant in the first week of life with sudden onset circulatory collapse, present with hypoperfusion, hypotension, severe acidosis, cyanosis. Infant may be present in the second week of life, even it can be present in the second month also. Rarely present beyond the 4 weeks of age. So ductal dependent lesions here. Ductal dependent here, we have two types, either restricted to the pulmonary flow or to the systemic blood flow. The pulmonary blood flow here, it's restricted to the pulmonary atresia, tricuspid atresia, critical pulmonary stenosis. So the blood will be restricted to go to the lung. So you need a BDA to shift the blood from systemic to the lung. Here, the second one, ductal dependent systemic flow, which is restricted, the blood flow go to the systemic. So you need the BDA, so you need to shift some blood from the lung to the systemic. Like what happened in coarctation of the aorta, aortic arc interruptions, and hypoplastic left heart syndrome. We need to pay attention here. If you suspect ductal dependent here in a patient present with cyanosis and not improving with the oxygen in emergency, start immediately prostaglandin. There is no major contraindication except from some cases of pulmonary hypertension, which is most likely being diagnosed after birth direct. So don't hesitate to start prostaglandin, which is a dose vary from 0.05 to 0.1 mic per kg per minute. And you can go up to 0.2 mic per kg per minute if that's needed. So the adverse events here of the prostaglandin will start from emergency. First, you need to tube the patient, because you will expect to patient having frequent apnea, hyperthermia, hypotension, rash, tremors, focal seizures, also the bradycardia. This is one of the commonest having adverse effect after starting the prostaglandin. Just can you give me 1 minute? I'm coming to you. Just I will modify my internet because it looks weak. Just give me half a second, please.
خلاص, you will have 1 minute. We have a question from Imad. If I have doubt about the mechanism of head trauma and severity, but clinically the patient is fine, is observation is enough? Well, as we mentioned, you can follow the guidelines. You have BCARN, you have so many guidelines. If the patient has no loss of consciousness, has no vomiting, has no severe headache, has no red flags, okay, and by examination he's completely normal, yes, you have to observe the patient and it will be enough, and you have to document this. So if anything happened later, your documentation is very clear. Dr. Saleh, once you are ready, let me know, huh?
Yeah, we are ready now.
Yeah, go ahead, yalla.
Okay, so again, we'll speak about the adverse effect when you start prostaglandin. The main things you need to be careful about the apnea. So better to secure the airway and tube the patient. So question that we need to know, if patient we suspected cardiac disease, we can just write it and list it there. The biggest question here is the patient cyanotic or acyanotic. If he's cyanotic, we need to remember the 5 T's here. Number 1, from truncus arteriosus, 2 double, mean transposition of the great vessels. So we have 2 different systemic there. 3, still mean tricuspid atresia. 4, that's meaning 4 tetralogy of Fallot's. And the 5 fingers mix everything, which is total anomaly pulmonary venous drains here. All this can be present after birth. We have a lot of things there of differential diagnosis, but the 5 things of cyanotic heart disease, this is the main things: truncus, transposition great artery, tricuspid atresia, tetralogy of Fallot, and total anomaly pulmonary venous drain. So how about pulmonary blood flow here? We can have a child with the cyanotic heart disease, but sometimes we have overflow to the lung, like here, and we may have underflow to the lung here. That's present cyanosis and congested lung, like transposition great artery, because there is more blood flow to the lung because you're coming from system. Instead to go to systemic, the aorta will push it to the lung. Also total anomaly pulmonary venous drains, truncus arteriosus, and hypoplastic left heart syndrome. We have two differential diagnoses here, which is restricted blood flow to the lung, which is end by tetralogy of Fallot and tricuspid atresia. How about the blood flow also here with no cyanosis here, expected to have more lung flow with blood with VSD, ASD, PTA, and atrioseptal defect. We have also decreased blood flow here in case of pulmonary stenosis, aortic coarctations. Timing of presentation here is very important because the patient will present after birth immediately to the ER. You will think mainly about transposition great artery, total anomaly pulmonary venous drain, and the hypoplastic left heart syndrome, which is critically life-threatening. Though the differential diagnosis also for cases who present in less than 2 months, truncus arteriosus, tricuspid atresia, and AV canal. VSD, ASD can present at any age, up to can be even VSD can be diagnosed, misdiagnosed until the age of 5 years, 7 years, whatever. Tetralogy of Fallot's usually presentation either after the birth and can be diagnosed any time. Aortic coarctation most of the time is diagnosis below the 6 months. Aortic stenosis, the same things. Aortic stenosis, one of the misdiagnoses, especially with the athletics who have recurrent syncopal or sudden death. So the timing of presentation here, think about less than 2 weeks. If it's ductal dependent lesions, we think about hypoplastic left heart syndrome, aortic coarctation, aortic stenosis. If it's cyanosis, we think all about 5 T's that we think about it: truncus, the transposition of great artery, etc. Between 2 and 6 weeks, patient can present with heart failure because large VSD, large BDA, AV canal defect, and we will think about 3 T's, not 5 T's, only 3 T's: truncus arteriosus, tetralogy of Fallot, and tricuspid atresia. And we will remove transposition of great artery and total anomaly pulmonary venous drain. Those 2 cases will be presented after birth, not after that 2 weeks. Between 6 weeks and 6 months, when they present with the heart failure, also let's think about large VSD, ASD, and large AV canal, and cyanotic will end up with tetralogy of Fallot. And by the way, once the patient is living in high altitude area like Antalya, Filbaha, Abha, the presentation will be earlier than this because the oxygen compromising there they will present to you earlier there. So you'll expect those patients who are having some heart problems, they will present earlier in this high altitude area. Still at the time, between childhood and adulthood, ASD, arrhythmia, all types of arrhythmia, BDA, aortic pulmonary stenosis, hypertension, they usually in the early and the late childhood because of the misdiagnosis of aortic coarctations, syncopal exercise, usually in the teenagers or adolescents because of the aortic stenosis or complication of Eisenmenger syndrome. Our rules here in emergency to evaluate the patients who we're thinking about cardiac disease, take a careful history about the age, birth history, birth weight. Need to think about the heart failure symptoms like the poor oral intake, not gaining weight, etc. Either cyanosis or not cyanotic. Family history, because we think about genetic also. Physical exam is very important to start from triage, from bad triangle, which is about the appearance, breathing, and color of the patients. Important to look to the vital signs, especially the heart rate, respiratory rate, and saturation. Assess the color of the patients, for extremity of blood pressures and pulses to make sure about coarctations, upper and lower limb pulse, pre and post ductal oxygenation saturation, right arm and either of the legs. Auscultate for murmur carefully. If the child is crying, you may think about sedate him, light sedate him, just to listen well to the murmurs. And also looks carefully about the hepatomegaly here. So you don't like to miss this or examine the patient with the mother. Ask her to put her down in the flat in the bed. So you be carefully examine about the liver size. Remember when the winter time came, we are diagnosed out of patient with bronchitis. We may miss. Patients will present with the same symptoms of bronchitis, but we end up with heart failure. Hyperoxic test is good to do it in ER, but just be careful about it. So you will give oxygen 100% for 10 minutes, and just keep an eye on that. If the oxygen saturation improving, so that's meaning most likely it's from the lung. If it's not improving, it's most likely because of the cardiac, and stop to give extra oxygen. X-ray, look to the size and the shape of the heart. Careful to look to the lung blood flow and flooding of the blood, the fluid in the lung. And ECG, you needed to look to the axis, rhythms. You need to calculate also the QT intervals. Looks for the ST elevations or depressions for any electrolyte disturbance, of course, in the ECG. Look for any hypertrophy and ischemia in the heart. Remember, there's a diagnosis called Al-Kaba, which is patient can present to the emergency with ischemic heart disease. He will present with ischemic and ST elevation because diagnosis Al-Kaba. Usually the presentation between 2 months and 3 months. So case number 1 here is 9-day-old female brought to the emergency by the mother. History of rapid breathing, decreased oral intake, less active today. There is no history of fever, no history of cough, no vomiting or diarrhea. Just the vital signs in the emergency was temperature was normal, respiratory rate is high, is 80, heart rate is high, 180, weight is okay, but capillary refill here is more than 3 seconds. So when you examine the patient, you will notice that there is increased work of breathing, that there is retraction, there is grunting, there is tachycardia, tachypnea, and the child looks gray color. It's not normal color, he looks gray. Also, there is a large liver, generalized hypotonia, pulse weak distally, and the lower extremity. So anyone can estimate what happened with this patient. What's most likely? So always think about septic shock. Once the patient having lethargic and decreased oral intake. Keep an eye on this. Pulmonary, dehydrations, intracranial hemorrhage because of the mild treatment, metabolic abnormality, and of course, we think about the cardiac here. Okay, so the time of presentation here between 0 and 2 weeks, we'll think about all the 5 T's, truncus arteriosus, transposition of the great artery, tricuspid atresia, tetralogy of Fallot, total anomaly pulmonary venous drain. And also we'll think about ductal dependent lesion like hypoplastic left heart syndrome, aortic coarctation, aortic stenosis. Which most likely between this? What's most likely diagnosis here? The child is great. So we'll think about perfusions, going to systemic perfusions. So gray colors with poor pulse score perfusions. Most likely we think about coarctations of the aorta or interruption or hypoplastic left heart syndrome. The lab came to be blood gas 7.1. Lactate was high, 3 or 4. And bicarb, I think it was 12. Glucose 150. X-ray was showing mild cardiomegaly, and ECG was sinus-threatening. This is about coarctations here, which is need to open, keep open the BDA here. But hopefully the child having large VSD, so having some shunt here. So that's maybe going to be survived for it. That's the systemic flow here, and now more left to right lung shunt here. Then we need to start on IV fluid treatment for keeping hydrations. Immediately start on prostaglandin, intubate the patient, secure the airway, and send him, call the cardiac and cardiac surgery for OR treatment. So in circulatory collapse, less than 1 month, it's ductal dependent till proven otherwise. Airway breathing assist ventilation. Don't give the patient 100% oxygen. This is going to be killing, by the way. So you need to open the airway, to open the BDA. Circulation, you need to give him fluids because you'll expect to have a hypotensive anytime. Prostaglandin, we mentioned the dose again, 0.05 to 0.1 mic, and we could even double the dose up to 0.2 mic per kg per minute to keep the duct open. Call the cardiac immediately for echo, and later on he needs cardiac intervention, cardiac surgery intervention. Of course, we'll not miss this patient. He can be having infection, serious infection, especially he's less than 2 months with lethargic and poor oral intake. So start him empirically on antibiotic. So cyanotic in 2 weeks old here, present with tachypnea, no murmur. We'll think about 5 T's. This is the X-ray. What most likely looks like. What is this? It's egg on string. So this is transposition of great artery, which is two different systemic. There is no mix between them, and you need to keep the PDA to mix the blood. TGA, transposition of great artery, left ventricle will go to the pulmonary trunk, and the right ventricle will go to the systemic flow. It's 2 separate circulations, and you need to mix it up and keep the PDA open here. Cyanosis in 2 weeks old, tachypnea, hepatomegaly. We'll think about also about 5 T's, truncus arteriosus, TGA, tricuspid, tetrahydrophilic, total anomaly pulmonary venous drain. And this is the X-ray. What most likely? Okay, this is snowman. And this is total pulmonary venous drain. أنا I wish في الكومنت إنه ما تجيبوا سيرة الساعات وكم ساعة تحسب. خلونا focus on the lecture now. And later on you can ask the moderator about the calculation of the hours. فالآن خلونا نركز فقط على المحاضرة الآن. Cyanosis in 5-week-old. Present with tachypnea, murmur, and hepatomegaly. Let us think about from 2 to 6 weeks about heart failure symptoms in VSD, BDA, AV canal, and cyanosis about truncus, tetrahydrophilic, and tricuspid atresia. And this is the X-ray. What most likely? So this is what we call wall-to-wall heart. And this is tricuspid atresia. 4-month-old with cyanosis with agitation, murmur, ECG showed right ventricular hypertrophy, right atrial enlarged, and we'll think about from 6 weeks to 6 months about heart failure, VSD, ASD, AV canal, and cyanosis will remain by tetralogy followed. And this is the X-ray, what looks like. Boot shape, yes. This is a boot shape, and it's going with tetralogy followed. So the treatment here, man, just don't be rushed with the patient and insert IV lines, put oxygens, and noisy area. The child will be desatting more. So just calm down the child, just do maneuver niches, maneuvers, light oxygens, let him in the mother, let the mother hold the child. If it's possible, insert the IV lines. You can give also morphine to settle down the child. Even it can be given IM, just be careful about it. Be careful about the IM when you give morphine with the child, because you may insert it the wrong way. But morphine is an excellent choice, or intranasal fentanyl sometimes to work well and let the child calm down. Case number 6. This 8-week-old male, lethargic and decreased activity, poor oral intake. He presents with high temperature 38 and pulse rate is so high, 240, tachypneic, and saturation is 92. He's having motile skin, liver 2 centimeters below the costal margin. Blood gas here, mainly metabolic acidosis by carb is 9, and CBC 23,000, and slight enlargement of the heart size. What was likely diagnosis here? Sepsis, pneumonia, cardiac. What kind of cardiac disease? With high heart rate. So this patient ended with intubations because he's very sick, line and fluid, given bicarb, given antibiotic, ampicillin, and cefotaxime. Reassess him, no improvement, mottling, capillary fill more than 5 seconds, and tachycardia. So we'll think about cardiac cause of tachycardia here. الحين بنمشي مع البلس. Pediatric advanced life support. 5Hs, 40s. 5Hs اللي hypoxia, hypovolemia, hyperthermia, hyperkalemia, metabolic. وال40s اللي راح work with it, tamponade, tension, toxic, thromboembolisms, plus the pain, anxiety, fear, and fever. بس هذه will not make the heart rate reach to up to 240. هذا ECG, what it looks like. We cannot jump into viral myocarditis immediately. We need just to work up the child before that. So this is SVT, and we have 2 types of SVT, either to be unstable or stable. And stable SVT, that's can be do vagal maneuvers. Immediately, if it's not working, go to the adenosine. Make sure the IV line is try to choose the best site close to the heart. Start from 0.1 milligrams and then double the dose. If not work, go with antiarrhythmic, procanamide, amiodarone, verapamil, lidocaine even. Case number 7, child who presented with syncopal. He's 7 years old, boy, was at home, become unresponsive, staring, incontinent urine. The mother, she's having seizing. No significant past medical history, trauma or cardiac, no family history of sudden death or cardiac disease. CPR done by the family until the Red Crescent arrived. Diagnosis here, seizures, trauma, ingestion. We don't know what's happened with the patient. Cardiac dysrhythmia, myocarditis, congenital heart disease. Tell me, what's the most common cause of like this sudden syncopal child? You can look to the ECG, abnormal ECG. So we're talking about arrhythmia, all types of arrhythmia. So syncopal here is many causes for the kids. One of it is aortic stenosis. They can present with chest pain, dyspnea, murmur, and they present later on with recurrent syncopal or maybe sudden death. لا قدر الله. hypertrophic cardiomyopathies, which is one of the common misdiagnosis في الأثليتيك اللي هو بيصير عندهم sudden death. الاريثمياز can be from VTAC, VF, either transient or it's continuous until death. Congenital heart disease like tetralogy of Fallot. Tetralogy of Fallot, by the way, it can be missed, not diagnosed until the adolescence or maybe old age. Transposition of a great artery or any cardiac surgery. For history, you need to be careful about past medical history, about any cardiac illness or any cardiac surgery, about what's happened with the dizziness, chest pain, shortness of breath, palpitation, about the rapid recovery. Physical exam, careful exam from head to toe of the patient, careful examine the heart, especially for looks for ejection murmurs, for example, like aortic stenosis. It's important to do blood pressures when he sit down and standing. ECG looks carefully for the rhythms. Is it sinus or not sinus? Any heart block there. Carefully about the prolonged QT intervals to work with any potential for arrhythmia. Looks for also for any delta waves for sites of left ventricular hypertrophy. You can request also the echo also. Hypertrophic cardiomyopathies, most common cause of death during the exercise in the adolescents and teenagers. Left side hypertrophy, outflow obstruction here. البرزنتيشن حقها تقريبا من 1000 لنص مليون تقريبا 1.5 million athletics. Mostly in male, post-puberty and autosomal dominant. What is this case? It's VF. So that's why pre-discalculations about what we call QT intervals. لاحظوا انه احنا we calculated this equation QT corrections looks for QT which is make one square before one square, don't count in the square, one square before the Q until the T waves, and RR should be from R1 square before until the R here. So this is the calculation, how to calculate it. It's of course more than 0.46. It usually is pathology. This is the long QT intervals here, how it's happened here. Look at the T wave here and look at the T waves here. The chest pain, need to be careful about taking the history of the chest pain, descriptions, the frequency, and the radiations, just to make sure about is it muscle pains or the cardiac reason there? Is it associated with the syncopal attack? Is it associated with the exercise? Family history is important. Vital signs, exam, the ECG is important. Look to the all criteria of the sinus rhythm, QT intervals, delta waves, the T shapes. Looks to the oxygen saturation on X-ray. X-ray, maybe it's helpful, not helpful, but we need to do it as a routine for the chest pain here to look for other causes. Some facts here about chest pain here. It happened in all age group. Most of them is benign. 3% of them is cardiac illness. It's common cause less than 2 years because of the cough, asthma, pneumonia, also other cardiac diseases like myocarditis. More than 2 years, idiopathic costochondritis, asthma, chest wall strains, and heart disease. We know that most of our patients who present with the chest pain, they present because of the muscular pain, either because of the change in the environments, trauma, costochondritis, pneumonia, effusions, pneumothorax, asthma, GI reflux. We have so many differential diagnoses for chest pain. But our main here is about rule out lethal cardiac problems. Structure here, aortic stenosis, pulmonary stenosis, hypertrophic obstructive cardiomyopathy, mitral valve prolapse, aortic dissections, Eisenmenger syndromes, coronary artery disease because so many cases been misdiagnosed as a Kawasaki syndromes, either because the family didn't go to the emergency or to the clinic to be diagnosed with prolonged fevers, or being misdiagnosed in emergency. Anomalies of coronaries and coronary artery disease, inflammatory processes like pericarditis, myocarditis, arrhythmia like SVT, chest trauma, and teenagers in the Western country, those who taking cocaine and vitamins and drug medications, they may present with lethal chest pain. So the red flag for chest pain here: history chest pain with exercise, syncopal with exercise, recent chest wall trauma, in exams, murmur, especially the diastolic murmurs or harsh murmur or murmur with a frill, abnormal ECG, evidence of trauma. Be careful about teenagers when they present to the emergency, about the chest pain, hypermobility joint, history of your upper respiratory tract infections, complaining from the fast heartbeats, because you need to calculate the heart rate with the fevers. It's not corresponding. Every temperature is up, is meaning heart rate will increase from 12 to 14 per minute. Facial butterfly rash and chest wall when they build. Case number 9, this 8-year-old male presents with a fever, arthralgia. Mother mentioned that he had sore throat for 3 weeks ago for a few days with the spontaneous resolutions. ايش متوقع تكون ممكن الحالة هذه؟ Throat swab was done and positive for group A streptococcal, but patient bitter, but didn't take the prescribed antibiotic. What's most likely? We think about acute traumatic fever at a school age associated with a certain strain of group A streptococcal organism that stimulate antibodies productions, and with carditis, myocarditis, endomyocarditis. It's happened after 2 to 6 weeks after post-exposure to the infection. And here we need to go to the Jones criteria, measures. We need one measure: carditis, new change in the murmurs, cardiomegaly, pericarditis, migratory polyarthritis, chorea, increase in ESR, subcutaneous nodules. And minors here, we need 2, like fever, arthralgia. Arthralgia, that meaning joint having pain without signs of swelling or signs of inflammatory in the knee or in the joint. History of previous acute rheumatic fever, elevated ESR, CRP, prolonged PR in ECG, rising titer of anti-streptococcal antibodies. And so many times the patient present to us in the emergency because of ASR, and they want to diagnose them as acute rheumatic fever. This is only one criteria, but we need both combining, major and minor. Thank you very much, and hopefully I'm trying to revise all the cardiac emergency in the 40 minutes. Hopefully I could cover most of it. Thank you so much.
Thank you very much, Dr. Saleh, for this excellent presentation. And I'll be the next presenter, and I'm going to talk about, we'll leave the questions to the end, okay, after my session. So if there is any question, you can send it, please. And okay. I'm going to talk about respiratory disease in children. I think this is a very important talk, and how can I share the screen? I hope it's clear now. Okay. As you know, this is the most common presentation usually coming to the emergency most of the time. They are coming with, flu-like symptoms or some distress, and they need to be seen in the emergency department. And this is what we have said before, that some cases, they don't need to come to the emergency. And most of the cases of respiratory disease, to be honest with you, they shouldn't come to the emergency department. And and it is started like from simple upper respiratory tract infection, flu-like symptoms, end up by having significant respiratory failure. It is very big topic, but I will try to summarize the most common cases that they are coming to the emergency department that they need, which needs an attention by the emergency physician or general practitioner in his clinic. There is a lot of things that we should really consider in managing these cases. The topics that I will discuss: asthma, mild, moderate, severe, bronchiolitis, croup. Before I start my talk, I will just give you an important study which was done by Professor Jane Knapp. Actually, she was one of our speaker, and she is one of our speaker in 2012. And Professor Knapp. And what she did in her study, she collected all those patients visited emergency department in USA, and she had like a total of almost more than 500,000 cases, okay? And she analyzed their data. She took all the pediatric population from 1 year to 19 years, those who presented with moderate and severe asthma. And also she took those 3 months to 2 years of age with bronchiolitis. And you know, this is the age of bronchiolitis. Also, as well, she took 3 months to 3 years with croup. And she checked how did they manage these cases in most of the emergency department in USA. And the result was, to be honest with you, were shocking result. Just before I go to the result, I will just remind you, like when we used to see patient coming to the emergency with moderate to severe asthma, would you give a steroid or not? Who will give a steroid? Please raise your hand, like dexamethasone or prednisone. Only 2, my goodness. Patient presented to the emergency department with moderate to severe asthma. Will you give steroid, Dexa, or part of your management, I mean? Yes. Okay, okay, we have almost 50 said we give a steroid. Like, stop here, please. Who will not give steroid? Who will not give steroid, please? Raise your hand. The one who will not give steroid. MashaAllah, 20. Okay, okay. I can see here. Okay, so there is around 20. I think it is wrong. Any patient coming to the emergency with moderate to severe asthma, he should receive steroid. This is a standard of treatment, okay? What about 3 to 2 years with bronchiolitis? Would you give antibiotics? Patient with bronchiolitis, straightforward. Those who will give antibiotics, raise your hand. Okay, there is a good number, only around 30. Stop. The one who will not give antibiotics to okay. I can see your comment on chat. If you like, you can give me your comment on chat page. Excellent, excellent. Yes, very good. So bronchiolitis is a viral disease. You don't have to give antibiotics. You are right. Okay. I like your answers in chat. I think that so there is no rule for antibiotics. What about doing X-rays for bronchiolitis patient? Patient straightforward bronchiolitis. Would you do X-rays for them or asthma or croup? Let us go for this. Patient with asthma attack and croup bronchiolitis. You will do X-rays? Very good. Very good. Excellent. 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 Excellent, Doctora. Excellent. I like the participation of some of you. Dr. Hidayah, Dr. Abdul Latif, Dr. Al-Muslim. Very nice. Okay. So let's go ahead and see what is the Americans are doing there. Most of our people, they love to go there and to be treated. And they are fighting with Ministry of Health with this committee to go there. Okay, here, as you can see, we notice that, the screen here, corticosteroid, only almost 70%, they are given steroid, which indicate that this is under treating the case, the asthmatic patient. The number here should be 100%, okay? And only 30%, they are given a steroid to croup. Oh, I didn't ask you about croup. Would you give a steroid to all patients with a croup coming to the emergency? Dr. Hidayah said yes. Dr. Kadia Jabir said yes, yes. Amro, even if it is mild croup. Yasmin, Modi said no. Modi said no, even for mild cases. But Elias, he said majority we should give. For mild, no. This is Amro Hussein. Okay. Well, Amro, you are wrong. Modi, you are wrong. All cases presented to the emergency with mild croup, even very mild croup, you just hear they are, you have to start treatment. Because if you didn't give Dexa or steroid, they will come back to you later with a very bad stridor and severe crop. So this number, 31%, it should be 100%. Okay, let's go to antibiotics. 53% of estimated annual visit of bronchiolitis, they are given antibiotics. 53, half of them. This is right or wrong? What do you think, Amro? Yasmin? Antibiotics should be given. What is the number should be here? So the number should be here, 0. Okay, excellent. Right. What about here? Let's go. X-ray. Would you do X-ray for this patient? For bronchiolitis, they 72% with straight for bronchiolitis. What should be the number? Let's say 100% or 0%? No need, no need. Excellent, Amro. Yes, you're right. What about croup? What about croup? To see the pencil sign and to see, no need. No need. Excellent. So there is no need for X-ray for patient with bronchiolitis, for patient with a croup, and also for patient with asthma. Okay? So this is a very important. Okay. And so we noticed from this study that physician treating children with asthma bronchiolitis croup in USA emergency department, they are underusing non-effective treatment like steroid in asthma and dexamethasone in croup, like so, and overusing ineffective or unproven therapies like antibiotics for bronchiolitis, okay? Or diagnostic tests like X-rays in asthma or croup or or bronchiolitis. I think this is what we should highlight on our lecture today, because this is a very important, and some of you mentioned that this will delay the management of patient, and not only delay the management, but cause problems, okay? I remember patient coming with a croup, okay? And the emergency physician, that was like around 10 years ago. And they called me to see the patient. And when I arrived, the patient was in severe respiratory distress because the nurses, they were trying to put a line, they were trying to get blood work, they were trying to send him to X-ray, to do X-ray. And this patient, he's only like 3 years old, very irritable, screaming, crying, and he's a croup. And then because of the vocal cord continuous crying, it became edematous, and then he stopped breathing. So we had to intubate him, and it was very difficult intubation. So you see, simple things, if you do it at the right time, you could save the patient, you could save the time, you could save the hospital a lot of money and everything. We know the patient is the most important thing. So for patient safety, we shouldn't do all these things, okay? Unless there is a specific indication, we'll go and talk about it. So this is very important, please. Okay. I will start with this case. A 7-year-old girl presented to the emergency department with shortness of breath, and she had a previous admission to ICU. She looks in distress, and her saturation is 88% room air. So she's hypoxic. She has wheezes bilateral, and she is using her accessory muscles. So what do you think? What is the most likely diagnosis here? Yalla. Very common. You don't have to tell. Okay. Asthma. Excellent, Elias. Yes, you are right. And what is the simple question that we should ask? Maybe this will be the first time she presented to the emergency. Have you ever used Ventolin before? She will say yes. Some people, they said Ventolin. No, they didn't. She never used Ventolin. They are giving her some oxygen. The family, they didn't know what is Ventolin. Some of them, they said she's taken oxygen. Sometimes she got sick, she go to the hospital, they give her oxygen. This is Ventolin, by the way. Okay? So she is on treatment, but she is not on a regular treatment. And this is what we will talk about it. Okay, in a minute. Okay. What is important question you should ask for? Okay? When you face a patient like this one, the one I present, you know, if you are in a board exam or a promotion exam or any exam, and you have a respiratory case like flu or whatever, asthma or anything, if you didn't ask about smoking history in the family, it will be a bad sign, and you may fail in this case. So smoking is very important. They don't have to be actively smoking like this guy, okay? They are passively smoker. The family, the father, he's a heavily smoker, and now the mother, maybe she is, yes, passive. The mother, she could be also a smoker, and this will expose them to smoke, and this is the most irritant to the child. And there is a studies also, okay, also Bakhor, yes, you're right. And there is some studies, they mention that if one of the family, one members of the family, he's a smoker, there is a risk of having asthma in the family, and it will be difficult to be managed. We have seen cases coming to the emergency. They are managed very well, and they are coming the next day. Why? Because the father, he's heavy smoker, okay, or the mother. So you have to be careful with these cases, please. Okay. Then, so smoking history is very important. Okay. What is the differential diagnosis? Sometimes they may present with the first time, especially the younger age, very young age. For example, if she is like 1 year. So you have to consider other differential diagnoses like bronchiolitis or foreign body aspiration, especially if it is an acute, okay, and by examination one side compared to the other side, or reflux or cystic fibrosis or anaphylaxis. And all these things can present with wheezy chest, but sometimes the scenario will be different, okay? Like in anaphylaxis, they will be like in shock, and because of the, exposure to any anaphylactic agent, okay, and so on. Okay, how we manage these cases? This is very important. And I think really, I hope from this presentation, you may have the right way of managing these cases, because, in our society, most of the emergency department, they are seeing these cases on a daily basis. Yani if you go today, how many patients we have see asthmatic during the 24 hours? Almost like 10, 20 cases, like almost about 20% of the cases, they are asthmatic or bronchiolitis, and this can be managed at home. And because of poor management and poor education, that's why these cases, they are coming very frequent to the emergency department. If you go to North America, okay, or Europe, rarely you can see these cases coming to the emergency, because the family, they are well educated how to manage their kids. So they don't wait till the child, he become very sick and in severe asthma attack. They manage them from the minute they have very mild symptoms. And this is what we should do and what we should encourage to do in our society. Okay? Any patient coming to the emergency now, pulse oximetry, it's considered to be one of the vital signs. Okay? It is one of the vital signs. When they are checking the temperature, the heart rate, the respiratory rate, before 10 years, 15 years, it wasn't there, only for respiratory cases. But now it is for every case. And it is non-invasive, non-expensive. It can help also to predict for hospitalization. Patient with asthma, when they present to the emergency, most of the time, if you remember, their saturation is around 95, 94, 90, above 92. But if these cases, if any patient present to the emergency with saturation less than 90, like 88, 85, okay, based on so many studies, it showed that they end up by admitting these cases. So it's a predict need for hospitalization. So when you see patient with saturation 88, 85, you feel, oh, most likely this patient will not improve after 3 doses of Ventolin back-to-back and steroid. Most likely later on he will be will need, most of these cases, they need admission. Some of them, they may improve dramatically and they don't need admission. So we should do it for every patient, not moderate to severe. No, I think now for every patient. And we have to provide patient with oxygen if his saturation less than 92. We consider 92 is the accepted. But still, if you have patient whose saturation is 95 and he is symptomatic, like he's tachypneic, working hard, you have to give oxygen. Because oxygen, it's a medicine also, it's a bronchodilator, and it will reduce the work of breathing. It will help, okay? And decrease the work of hard breathing. I hope this is clear. Bye. X-ray, do we have to do X-ray? Okay. No, we don't have to do X-ray. As we mentioned before, if someone will tell me, doctor, please, why don't we have to, why it's not important to do an X-ray? I know I've been working with some consultant and they are always, whenever the patient present to the emergency, they are asking for chest X-ray. Actually, this is wrong, okay? And I will show you, this is an evidence-based, okay, recommendation. As you can see, usually the X-rays, it showed hyperventilation. You see, hyperventilation and flat diaphragm, okay? And increase anterior-posterior diameter, okay? There is an old study done more than 20 years ago, or even more than 20, or more than 40 now years ago. Okay, this Gershel, what he did, he collected all patients presented to the emergency with first-time wheezing. Because some of you will say, oh, if he is a non-asthmatic, non-bronchiolitis, non-group, whatever, first time we should do it. Even first time, you didn't have to do it, but let's go to the study and see what he did. He collected around 400 children, more than 1 year of age, and he did a chest X-ray for all of them. They are all having a wheezing, okay, first time, okay? And he analyzed the result of this X-ray. 94% of the X-rays were normal. You see, 94%. And only 6% were having abnormal finding. What is the 6%, which is mean like 20%? Okay, and he analyzed this data. What was the abnormal? Okay, finding. What were, when they did their X-ray, what was their presentation? They are in severe distress. You know, age more than 1 year, the respiratory rate should be around 20, 25. 60, this is the maximum respiratory rate for neonate. So this is a very significant distress in a patient more than 1 year, okay? Heart rate more than 160. There is a high fever, and there is a focal exam, okay? This is what they find on this on those patients of abnormal X-ray findings. So based on this result, okay, they already decide which patient should go for chest X-ray when they present to the emergency. If there is a focal finding, someone said, well, doctor, I noticed there is a decreased air entry in the right side compared to the left side. Okay, so this could be foreign body, or could be pneumonia, or could be something else. So it's better to do an X-ray, okay? Or fever and severe disease. For example, let's say asthmatic, but we give him the treatment and everything, but still there is no improvement whatsoever. So we have to make sure maybe there is another problem, okay? Maybe he's in failure now, heart failure. Okay, so you have to see. Right. This is for X-ray. So what we usually do for this patient, how we manage this patient, okay? What is the management? Most of the time, it's the standard of management, which we used to do like Ventolin, nebulizer, okay? Ventolin nebulizer and, which beta-2 agonist, okay? Other name called albuterol or Ventolin. So it can be given as inhaler, nebulizer. You know the nebulizer. This is what we usually do in most of the emergency and in the hospital. It's a nebulizer, okay? And there is another way to inhale, which is MDI, meter dose inhaler, اللي هي البفs, okay? And there is another way you can give it subcutaneous, like if the patient is difficult to give inhaler, okay? Like this is very severe cases, okay? Those who are not cooperative, they are very agitated and they cannot inhale anything. You can give sub-Q Ventolin or terbutaline, we call it, okay? And sometimes in ICU setting, if the patient is status asthmaticus and he's not improving to nebulizer or whatever medication, then you have to start intravenous beta agonist, which IV terbutaline. Okay, I hope we will not reach this stage, like to give subcutaneous or intravenous. Please, we can manage this patient. If we pick up these cases early, it will be great. Okay? Okay. What about steroid? steroids should be given as early as possible. Okay? Orally can be given, and also as a nebulized or intramuscular, intravenous. I noticed we used to do as like a program for emergency medicine, pediatric medicine. We used to go to المزاحمية, القويعية, المجمعة, these places, and to give some topic, some lecture about it. I noticed they are still using intramuscular dexamethasone or intramuscular steroid for patient coming with asthma. They said it is a quick, effective. They didn't give oral. They said oral, it is not. This is like 20 years ago or before 20 years. We don't do it anymore. There is so many studies. They compare oral steroid with IV steroid, with intramuscular steroid, okay? And they notice there is no difference. So why we put my child to suffer for IV line and all these things? It's better to give it oral. And this is the same also for croup when we give dexamethasone, especially croup, because if you irritate him and they will, we will talk about croup in a minute, but also steroid can be given oral in croupy patient. What about ipratropium bromide and magnesium sulfate? Magnesium sulfate, now it is one of the promising medication for severe asthma, okay? And it should be given as early as possible. You don't have to wait. And it is a very safe drug. In the past, they were scared because of the risk of hypotension and arrhythmias. So they were very reluctant to give it, but now they feel very safe, and I will tell you why in a minute. Okay, if you have any question, you can put it in the chat, please, so we can be on the same line. Ipratropium bromide, which is the atropine, you can give it also with each dose if nebulizer. Okay. طبعا نتكلم عن البيتا agonist. This is beta agonist. It's remained the standard of care, which is the Ventolin for asthma, and it should be given every 20 minutes. This is the standard in the first 1 hour. So we usually give 3 doses back to back, because back to back means you give the medicine, it will take like 10 to 15 minutes, and then 5 minutes to prepare and give it, and then so on. Okay, it should be given by nebulizer or MDI, withholding chamber of each, طبعا مع الايرو chamber. And we should take all the measures to have very good optimal delivery. I noticed some of the nurses, they are putting the flow of the oxygen up to 10, so they can give the delivery will be very fast. This will not be beneficial to the child. The flow of the oxygen should be around 6 to 8 maximum. Okay. What else? This is one way to give Ventolin. What do you think? This is good or bad? Just write good or bad. Let me see your response, just to make sure that you are still bad. Who said good? Worse. Not the recommended. Excellent. This is very bad. This is very bad, okay, in asthmatic patient. An asthmatic patient, and even if you see the nurse doing like this, tell her, please don't do it, because the child will nothing will reach his lungs. The most important, we need the Ventolin to reach the lungs. But this way, maybe the nebulizer here may reach the upper airway. Okay, but it will never reach the lung, so it will not be beneficial. Okay, absolutely nothing will be delivered. So they will say, okay, but doctor, she is not cooperative, she will cry. Okay, let her cry, because when she starts crying, she will inhale more. This is an asthma case, but this one I can use it in croup. In croup, yes, use this one and keep the baby in the mother lap. See the mother, she's holding her baby and she's, this is a croupy child. This is not asthmatic child. That's why this is right to give it in a croup child, in croup. But in asthmatic, please don't do this. Thank you. Bye. Let's go. Leukotrienes, this is as an outpatient, not an emergency, please, because it will take time to work. Bye. This is the air chamber. This is the way how to deliver the nebulizer, okay, not the air chamber. And this is the best way for children those who are cooperative, you know. This one, he's like 6 years old, and I gave him this one. I told him, can you show me how? And he's very nicely, you see, inhaling very well. Okay. I noticed one of the nurses, she covered this area here. She put a tape, and I noticed he is very distressed. My goodness. I don't know, why did you cover him? She said, because we need the Ventolin to come from the other side. It is wrong, because he cannot inhale. So this one, this end should be open. Okay? Okay? Good. Bye. But in the previous picture, okay, like this one, this area should be closed. Unless the child will start using the mouthpiece, then we have to open this area. Okay, so nebulizer, the best way to deliver is by mouthpiece. But in younger age group, those who are 2 years, or for example, 1 year, it is very difficult. But like 3 and above or 4 and above, if you show to them how to use it, they will be very expert in using it. Okay, very good. But this is the air chamber. And this is the different size. This is the for a very young age group. This is for toddler, and this is for older children. Okay, this is here. You can see the air chamber is using the mouthpiece. If you can appreciate, I hope the picture is clear. While here is using the mask, because they didn't know how to use the mouthpiece. Okay, so this is very important. I think education is very important in patients with asthma or respiratory disease, because if you give all the medication and everything, but they didn't know how to use it, it will be very difficult. Okay. What about ipratropium bromide, which is atrovent? Atrovent, it's proven to be effective as a synergistic effect. And we are usually given it to the first 3 doses of Ventolin. And it should be with each dose. Some people, they said with the first dose. Some people said with the second dose. No, with every dose that in the first 1 hour. Because as I said, Ventolin every 20 minutes. So 3 doses back to back. And you can add Atrovent to it. And very simple to calculate the Ventolin and Atrovent. Please. Those children below 6 or below 5 years, below 5 and 4 years, or below 6, you can say, or below 20 kg of weight, you can use the small dose of Ventolin, which is 2.5 milligram, which half a cc. Okay, those children more than 6 years of age or more than 20 kg, you can give 5 milligram or 1 cc. This is, take it like this. You don't have to calculate 0.125 milligram per kg per dose. Don't. In emergency, they will teach you how to be very fast. Okay, this is, yes, I'm talking about nebulizer. And you can add to the Ventolin nebulizer at the same time, you can add the ipratropium bromide, which is the, the Atrovent. Pulmicort, we didn't talk about Pulmicort, please. We are talking about the Atrovent and Ventolin. We are talking about what is the standard of treatment, the GINA guidelines, global international management. What is the best, management? This is an emergency department, okay? So you give it 3 doses back to back. What is the dose of the Atrovent? Also the same, 250 microgram for those below 6 years of age or below 20 kg, and 500 for those who are more than 20 kg or more than 6 years of age. Okay, and it is they mentioned that it will be some studies showed that it will be more effective than Ventolin, give it alone. Excellent. طيب, this is what we talk about Ventolin as beta agonist and the abratrobin. What about the steroid? Steroid, we mentioned that it should be given for any patient coming with moderate to severe. Those cases, mild, very mild cases, no, we never. And you can give it as oral or IV. And this is the studies here show that the oral versus IV is the same effect. Okay, I don't want to go over it because we don't want to waste time because I think I'm running out of time. So the moderate asthma attack, we give Ventolin with Atrovent back to back, okay, as a nebulizer with Atrovent, okay, and we can give a steroid, either prednisone, okay, or dexamethasone. Prednisone, you know, which is oral, 1 to 2, usually 1 to 2 milligram. Usually we are given 1 milligram per kg per dose for the first 3 to 5 days, okay? Or dexamethasone, you can give 0.6 milligram, okay, per kg per dose, only as a single dose, or you can give it for 2 days only. But usually there is some studies now, they recommend even with single dose, it will be effective. As you know, dexamethasone, it has a long half-life, up to 92 hours, okay, 3 days, yes, 72 hours, I mean. Okay, and you can give it oral. Tamam? This is about the initial management. Okay. Till now, we didn't put an IV line, we didn't do blood work, we didn't do anything, and this is the management. All right. Bye. So simply, what is the management of moderate asthma? طبعا mild asthma, most of the time they don't come to the emergency. They are managed at home, or if they call you by phone, what we should do, you just encourage them to give the Ventolin. Okay, so albuterol nebulization, we said, okay, 3 doses back to back with Atrovent, which is pratrobium bromide. It should be every 20 minutes, okay, for 3 doses, and then you assess the response. If there is no improvement whatsoever, then you may consider hospitalization, and then you may consider magnesium sulfate, you may consider another treatment. If there is slight improvement, you may give more time in the emergency, more doses, and then discharge home. If there is a marked improvement, you can discharge home with, and to continue Ventolin for every 30 minutes. You know, this is 30 minutes, this is for slightly improvement. Okay. The most important, disposition. Okay. When you discharge them, you have to have like peak expiratory flow rate more than 70%. Most of the time they don't do it, but we can assess it clinically by looking at the patient and his symptoms improved. And the symptoms are minimal or absent, and most of the time you cannot clear the chest completely. There is few fine wheezes. It's okay as long as he's maintaining his saturation, he's not in significant distress, and he will continue the treatment at home. So there is no problem. You can discharge him with sufficient medication to be prescribed. Outpatient care will be established with them. Then you can give him a follow-up with his family doctor or primary care center in 1 week. Education, education, education. It's very, very important. Okay. Those who are not improving, okay, and feel that still they are sick, okay, we may consider admission, sometimes ICU admission. This is if he requiring more aggressive treatment, okay, and how do you know this patient, he is at a high risk? If there is like, you know, previous history of intubation or ICU admission or severe exacerbation before, or in the last year he was admitted more than 2 times. Yeah, this considered to be one of the, you know, red flags when you see these cases. Or he has, you know, other medical problems, cardiac problem, systemic problem like, you know, chronic lung disease, cystic fibrosis. These patients, sometimes they need more attention. Or they are low socioeconomic status or live in far in urban areas. Okay. Bye. what is the treatment as outpatient? You give them like, Ventolin as puffs, and sometimes you give them as liquid if they are preferring to use nebulizer. Then you give steroid. If you are given, for example, prednisolone, you have to complete 5 days, or dexamethasone, only 1 dose. And especially for those family that you feel they are not compliant with medication, okay? Inhaled, maybe you have to give like Flexotide or medication. Education is very, very important. Before I start talking about severe asthma, I need from you, please, to write quickly how you will prescribe. Can you prescribe for me Ventolin for patient as an outpatient? Write it down, please. Okay? In the chat. Like how many those Ventolin, only the Ventolin. Okay? It's okay. Then you can make mistakes, no problem. As an outpatient, 4 buffs, Q 6 hours. Excellent. Q 4 hours for 2 days. 6 buffs, Q 4 hours. Then space it as improved. Excellent. Okay, who else? طيب. I really thank you, Malak, Elias, okay, and Ramla, for your participation. Amro also, 2 buffs as needed. Allah بدبحك يا Amro. What else? Yalla, Atoni. All what you write, then Q 6, 2 buffs as needed. Then Q 6 hours for 2 days. But let me tell you one thing. I think, guys, we should go back and review the GINA guidelines. GINA guidelines every year, every 2 years, they are reviewing it and they are updating it. Based on our studies, and we have noticed that from our experience in the emergency department, okay, patient, they are not taking enough medication at home. Okay, I'm talking about salbutamol inhaler, yes. Ventolin, which is Ventolin, yes. 4 buffs, Q 6 hours for 3 days, then evaluate. What you have wrote there, all our colleagues who participate, this is what we usually do. And I've done it before, but this is all wrong, okay? This is why we are seeing all our pediatric patients coming back to the emergency. And from now, I think we have to change our practice, please. How? I will tell you. According to GINA guidelines, they notice that children, they don't inhale very well, the Ventolin. And only small percentage will reach the lung. They did a study in adult population, and they notice around 10% or even less reach their lungs. They are using the best way to deliver the Ventolin to their lungs, okay? And, mouthpiece, good inhalation and everything, and they notice that less than 10%. Just imagine if we did this study in children, how much we will find in their lungs? Nothing, okay? This is one thing. Of course, you have to use it with a spacer, but still, how frequent we should do it? Because of this poor inhalation and poor cooperation from the children, and they need more, the recommendation now to give 4 to 8 puffs, okay? 4 to 8 puffs every 2 hours, not every 6 hours, not every 4 hours, every 2 hours. And then you can space it according to the response. Sometimes if your child, you can tell the family or if your child has an asthma attack and you think that he needs the emergency, you can keep giving the Ventolin buffs by the air chamber, of course, okay? Till you reach the emergency department. Someone will say, doctor, if it is more than 50, I will tell him, even if it is more than 100 puffs, keep giving the buffs till he reaches the emergency. Okay? Don't worry. it is very safe. And this is evidence-based. It is not from my head, just على قولتهم يقدح من راسه. No, this is based on evidence. Okay, so you ask them to, I'll give you one example, to be honest with you. This is one of our colleagues. He was working in Security Force Hospital during the flood in Riyadh. You remember تقريبا قبل حوالي 5 سنوات أو أقل, there was a lot of rain وكل الكباري almost all closed. And he called me. He was still working in the hospital. He told me, Muhammad, فزعتك بالله. What's the problem? My daughter, she is like 9 years old. She has a severe asthma attack. And I called the Red Crescent, her mother. She said, because of the rain and flood, nobody, they said they cannot go there. And it will take hours. And if I go now to my house, it will take me like 3-4 hours. All the streets were closed. I told him, do you have puffs at home with a spacer, with everything? He said, yes, the mother, she gave it to her 2 puffs 4 hours ago. I told him, my dear, let the mother keep and empty the whole spacer. Okay? He said, no, this will cause tachycardia and she will be. I told him, listen to me, just ask her, please, to give it. And she keep giving the mother till the father reach there. And I swear to God, he told me, I think the mother was lying to me. Because he said, when I arrived home, she was completely well. So this is why I think, because, children, they don't know how to inhale. Very minimal amount of Ventolin will reach the lungs. And it is very well known that Ventolin, it's a very safe drug. So please, guys, and this is even mentioned most of the conferences I attend with respiratory, with all this, they said people, they are under treating, especially the primary care physician, the family medicine, the emergency physician, all of us. So I think from this presentation, you have to change your practice for these cases asthmatic, because this is a very common. What is the percentage of asthma in our population? From 20 to 25%. My goodness, this is a huge number. So just imagine if we can manage these cases, they will never come to the emergency. I give you another example just to convince you, okay, to give Ventolin very frequent and more doses. When you come to the emergency, these cases, and give them back to back, let's say more than 6 years, and how much this 5 milligram, how much puff in this 5 milligram nebulizer? 5 milligram يعني 5000. Each puff is 100. معناته ان الجرعة الواحدة اللي هي 5 ملغ تعادل 50 بخة. فتخيل انت بتعطي اوكي شو اسمه 150 بخة في خلال ساعة. This is why feel free, please, to give Ventolin very frequent every 2 hours, and then based on the response you can space it to 4 hours, space it to 6 hours, space it to 8 hours, and then you can stop. And very important, you have to ask the family, please, you have to be ahead of the disease. For example, your child, he start having some runny nose, and this is a triggering factor to asthma attack. Start the Ventolin right away, because asthma, it is 2 stages. The first is alveolar obstruction, and then the second stage is the edema, okay, inflammation process. So you have to give a steroid, and we don't like to give a steroid. We try to avoid giving a steroid. This way you can avoid giving a steroid, and you can avoid also coming to the emergency very frequent. Tell the mother, once he start having runny nose, start the Ventolin. We'll be generous, don't worry. Okay, you want to go to the Malahi, to playground, to whatever, he will have some activities, everything. Okay, give him like 4 puffs before. And if he run and play and he feels some tired, give him another 4 puffs. Most of the families, when you ask them, he was playing today a lot, ya doctor, and the whole night he keeps coughing. Why you didn't give him before he started playing? We know there is something called exercise-induced asthma. Okay, all these measures should be considered, please. This way, I can tell you, we will reduce the number of cases coming to the emergency with asthma or asthma attacks. So it's a very important. Okay, I hope you can understand. And if there is any question regarding this issue, just let me know. We'll go now quickly to severe asthma. Okay, why I'm talking about moderate asthma? Because this is the most common. Okay, and mild asthma, you have to treat it like moderate asthma, but you don't have to give steroid. يعني mild asthma, okay, you should give what is it? The Ventolin buffs with air chamber, very frequent. Be generous with it. Don't worry. Sometimes we give Ventolin continuous nebulization in the ICU. Just imagine how many puffs this will be, thousands of puffs. But you don't like to see your kid or in such ICU. Okay? طيب. By the way, I'm not Dr. Saleh. I'm Dr. Mohammed Al-Feifi. It's okay.
Excellent.
طيب. Now we'll continue with the severe asthma. Okay. So the management for severe asthma, most of them, they have hypoxia. So you have to be aggressive with the management. You start oxygen right away. You start also Ventolin back to back with ipratropium bromide. And sometimes these patients with severe asthma, they cannot tolerate oral steroid. But if they can tolerate oral steroid, okay, it will be great. Okay. And if they cannot, you have to put an IV line and start the intravenous steroid. These patients usually, okay, they may need, some of them, they come to the emergency very agitated. I will tell you a bad story. One of our colleagues, I don't want to mention her name, but her brother, he came to the emergency department. She's a well-known emergency physician. Her brother came to the emergency and he died in the emergency because of asthma attack. He was around 15, 16. It is unfortunate, okay? Because he became agitated. When you have a hypoxia, you become very agitated. So that's why we don't have to delay the management, and we have to be aggressive in managing these cases. Like this one who came very agitated, uncooperative, anxious, you have to give him subcutaneous terbutaline. You have to treat him like anaphylactic shock. If you don't have, some of you, they don't have terbutaline, give him epinephrine. Epinephrine, it has a beta agonist. Yes, alpha and beta, but will get benefit from the beta agonist. Okay. And then we are forced. Yeah, Abdurrahman Shweir, I don't think this is the right time to talk about the hours. Please, once we finish, you can talk about these hours. Don't worry, please. Because you are disrupting and disturbing. Thank you very much. If the patient is so severe and you feel like he has a silent chest, okay, so you should give, as I mentioned, IV terbutaline or subcutaneous. I mean, subcutaneous because this is the easy and very fast, okay? And at the same time, you have to continue the nebulization because terbutaline, there will be, it will go through the circulation, systemic absorption, and it will open an airway slightly, and the patient will benefit from the nebulized Ventolin, okay? Also important to start the magnesium sulfate as early as possible. In the past, we wait until the patient becomes very sick. Nowadays, if there is no improvement, the improvement is not that much like I wish, okay, I should start magnesium sulfate. And by the way, it is very safe drug. I remember I was a fan of magnesium sulfate when I start my work back here. And I noticed our colleague in ICU, they mentioned that we don't like to give it actually in the emergency department. Patients should be moved to ICU, and there in the ICU, you can start the magnesium sulfate. Why? Because they are afraid of hypotension, afraid of conduction disturbances. But if you know that the normal magnesium level in the blood is around 0.8 to 1, okay, milligram, but when you give the right dose of magnesium sulfate, which is 50 to 70, okay, and sometimes maximum not to exceed 2 grams, the level of the magnesium sulfate will not reach, 2 or 3. And the level that you have to be afraid of, more than 8, they will have hypotension and cardiac disturbances. So feel free to give magnesium sulfate as an IV, okay? And it works in the calcium channel, and it is dilate the airway, and it is very absorbed very fast. And sometimes now there is some studies they are recommending to repeat the magnesium sulfate also again. طيب خلاص. IV terbutaline, this is if the patient is not responding, then we have no choice. But please, guys, we have to start I'm not going to go into the details of the ICU management. I think the most important, back-to-back Ventolin with Atrovent, magnesium steroid, of course, should be started early, and magnesium after the first 1 hour. The patient, he didn't improve that much, slightly improvement, but still you need more, give magnesium sulfate, there is no harm. طيب. Intubation, I will not go, I think because of the time. كم باقي لي يا شباب؟ والله تراني ما طلعت من الوقت. هاي صالح؟ Still we have time ولا؟
هو من زمان خلص الوقت.
أسألك بالله. طيب خلاص اوكي. طيب. لا but it is 2 parts. ها؟ أيوة I should finish by. لا الله يسامحك يا أخي. I should finish by 1:30. أيوة. لا أيوة still finish by 1:30. لا الحمد لله عندي الوقت. طيب. let us go back. إذن IV terbutaline, but still, we don't recommend to give this unless it is in the ICU setting. Okay, but we will continue giving the continuous nebulized Ventolin. All right. Like 10 milligrams over 1 hour, or there is a calculation to calculate the continuous nebulization. Okay. What else? In severe asthma, if you think that the patient, do we do arterial blood gases, blood gases? When we do blood gases, sometimes they said to decide whether you to intubate. We don't rely on the blood gases for asthma, and we have to delay actually intubation in an asthmatic patient. Okay, because this is a very important in asthma. Once you intubate, they may go into hypotension. Okay, and and you have to consider, it will be the last weapon that you should use. Which is the intubation for asthmatic children. And this is why I'm advising you that by educating the families, by educating our junior resident and general practitioner and our physician, we can avoid reaching severe asthma and to the stage of intubating and reaching this stage. There is some medication can be given. Ketamine, still there was an option for ketamine, like 1 milligram they mentioned per kilogram. Sometimes it causes bronchodilator. Aminophylline, it's not anymore recommended, but in some ICU they go back to it. They went back to this medication, and the best thing for as I told you, the indication for intubation, it's not the blood gases, but the patient presentation. It's if he is very agitated, very anxious, and he's hypoxic, you have to consider intubation, okay? Because he may deteriorate very fast. So this is just simple, and it's very important. This one, in severe asthma, it is the same, like moderate asthma. If he is hypoxic, you give oxygen. And I told you, even if he's in distress, there is no harm, you can give oxygen. And we give him Ventolin back to back based on the weight or the age with Atrovent, 3 doses. If there is a poor response, before you give subcutaneous terbutaline, okay, steroids should be given, of course, and magnesium sulfate. I like to give the high dose, 75 milligram, but you shouldn't exceed 2 grams. What about dexamethasone? It is 0.6 per kg, but also there is a maximum dose. You shouldn't, okay, exceed the 16 milligram. In some literature, in some books, they said 12 milligrams, some books, they said 14 milligram. Okay. If there is a good response, then you discharge home with Ventolin buffs. By the way, we are encouraging now most of our patients to use buffs better than the nebulizer at home. Nebulizer very concentrated, as I told you, and sometimes it's causing tachycardia, palpitation. Okay, so but by using the buffs, the MDI, they can use it at school. They can use it when they play outside. They can use it anywhere. Okay, and this is very important. So even now, I remember, you know, in North America, they were a fan of giving nebulizer in the emergency department till like 2005, 2010. And in England and in the European, okay, they've been using the MDI even in the emergency department. But in North America, they don't like to use MDI because of the nursing issue. The nurses, they don't like to sit next to the patient and give puffs and count and then shake the puffs again and count. It is easy for them just to put, you know, 3 cc of Ventolin with Atrovent and the system and nebulizer and leave the patient for 20 minutes and come back, which is wrong. We should encourage now in our emergency department to use MDI, but this needs a lot of work, okay? Because you will face a lot of resistance, even from the families. Oh, la, more effective than nebulizer. We should encourage people to use MDI. MDI, very important. Some families, they are going to the school until the principal ولا المدير ولدي ترى عنده حساسية ما أبي أشوفه يلعب ترى على مسؤوليتكم خلوه يقعد. This is يعني you destroy your child by doing this. خلاص حطمته. In North America, they encourage their kids to practice every kind of sport, okay? And they have their buffs in their bags. Before you go and practice with your colleague, before you start playing, just take 4 buffs, okay? And play. If you feel like you're a little bit tired, don't continue, just stop and take buffs. This way, you encourage your child to, you know, practice the right, his lovely sport or whatever he likes, okay? نحطمه يعني, it's not right. طيب. خلوني الآن أخذ أسئلتكم بسرعة. طبعا عندنا هنا ملونة عنيزي أنت absent لأن قلنا مليون مرة لا تسجلون الأسامي وشكرا لك. حمادة باشا برضو أنت متغيب لأن قلنا لا تسجل أساميكم. واضح أنك توك داخل علينا. طيب نرجع الحين لأسئلتكم اللي في الشات. I'm sorry, I think that was before. خلاص, I'm sorry. طيب نرجع للأسئلة. أيوة. Doctor, I have questions. The steroids are not recommended to be given for mild asthma. Yes, it is not recommended for mild asthma. Okay, it depends on you. يعني, maybe you said this is mild asthma while somebody else said no, this is moderate. That's why I gave a steroid. Okay, but guys, we don't want to reach to the moderate or severe asthma. This is very important. Okay. I hope this is only the question. Okay, طيب. السلام عليكم. طيب ممتاز. Let's go to the next case because 5 months old present to the with the history of cough for 2 days preceded by upper respiratory infection. His feeding has decreased and his cough interrupts sleep. Temperature 38 at home and normal past medical history. طيب يلا, who will tell me the diagnosis from the history? If you like, I can give you also the examination. أيوة, 5 months old, present with cough. Okay. طيب, for 2 days preceded by upper, his feeding has decreased and interrupt temperature. Yes, it could be croup, it could be bronchiolitis. You are right. Yes. طيب. Temperature 38.5, respiratory rate 60, okay, and saturation 94 in room air, mild rhinorrhea, air entry good, wheezing in all field, wheezing, well hydrated, feeds well, no grunting or retraction. So what is this? Finally, bronchiolitis. Excellent. So this is bronchiolitis. طيب, how you manage bronchiolitis? You know, usually bronchiolitis, it is airway inflammation of the small alveoli. That's why you hear some wheezes and crepitations. Okay, you can see here the normal bronchioles and see here the abnormal. Okay, the affected one. Okay, because of the mucus and the inflammation of the wall. طيب. What is the diagnosis? As we mentioned, this is bronchiolitis. Shall we do? الله 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 الله. أنا طلعت من الصفحة. Okay. How we diagnose it? What is the most common organism that cause bronchiolitis? طبعا قلنا ال RSV. It is well known. Okay. And most of the people, by the way, by the year by 1 year or 2 years of age, by 1 year, they said up to 90%, they have bronchiolitis. By 2 years, 100% RSV bronchiolitis. So this is very common. That's why most of the scientists and infectious disease people, they are working hard to have a vaccine for RSV, okay, bronchiolitis. But till now, they didn't reach it. So do we have to do RSV test, you know, nasopharyngeal aspirate for RSV to diagnose? No, we shouldn't. Absolutely, yes. Unless the patient need admission, okay, and need to be admitted at this stage, yes, we have to do, so we can isolate them all together, those all positive RSV cases. Okay. طيب, do we have to do not all bronchiolitis RSV yet, which is like bacteremia? Okay, if the patient, let's say, someone will ask, you have this 1 year, 1 month or 2 months of age who has typical bronchiolitis, but you are in a hospital where your consultant is very, you know, protective, and he said you will do blood work. And then you said, well, Dr. Al-Fayfi, we attend his lecture. He said, no, I shouldn't do blood work. Okay. Then how you answer? Your answer would be, you know, most cases, not most cases, almost all cases with typical RSV bronchiolitis, okay? They have a decrease. Oh, I'm sorry. My voice is low. Most cases of bronchiolitis, patient, typical bronchiolitis, RSV bronchiolitis, very unlikely to have positive blood culture. Okay, that's why we don't do blood work for them. But they are prone to have UTI. That's why only when you face patient coming with bronchiolitis, you have to do the urine dip, in and out catheter, and check the urine. If it is positive, then you have to continue the rest of investigation and start IV antibiotics. This is if he is like around 1 month or 2 months, below 3 months of age, because usually these patients, they need admission and IV antibiotics. طيب. My voice clear now? طيب. What about febrile infant with confirmed viral infection are at a lower risk for serious bacterial infection than those in whom a viral infection is not detected. And this is confirmed what I have said already. So viral diagnostic data can positively contribute to the management of febrile infant, especially those who are at classified a high risk. What is the differential diagnosis for the patient that we have just present now? Reflux disease, okay, fistula, tracheomalacia, vascular ring, cystic fibrosis, heart failure. Sometimes they present because this is a very young age, usually the bronchiolitis patient. So you have to consider, or foreign body aspiration. So still, when you face these cases, you have to check the differential diagnosis and think about differential diagnosis. Okay, I think you know Dr. Khalid Al-Mubarak, who is a consultant and professor of pulmonary at the university, King Saud University. He did a study for patients with asthma. He collected like around more than 20 cases, those difficult management asthma. And he found a very interesting finding. Some of them, they have foreign body, some of them laryngeal web, some of them congenital anomalies of the trachea, some of them. That's why difficult management cases like asthma or bronchiolitis, you have to think of other causes like tracheoesophageal fistula, tracheomalacia, vascular ring, all these things. So you have to widen your differential diagnosis. X-ray, do we have to do X-ray? وش قلنا? Yes or no? Excellent. طيب, no X-ray to be done, and the typical finding, it's the same like asthma, okay, hyperinflation with flat diaphragm, and sometimes there is like bronchogram on the right hilar region, which is okay. طيب. Do we have to do X-ray for this patient? Simply no. And this is the recommendation that we shouldn't do an X-ray for this patient. Excellent. Type what else? So conclusion, this is the American Academy of Pediatric conclusion recommendation for history and physical examination should be the basis for diagnosis and disease severity assessment. Okay, so labs and X-rays studies are not ordered routinely unless it's indicated. Okay, what is the high risk group? Oh, this is very important. When you are in the emergency and they told you, the nurse, doctor, we have here like 32 weeker. He's a premature and he is like 2 months old. Oh, this is very high risk. So you have to run and see this patient. Also younger age, below 6 months. But when you have a bronchiolitis patient who is like 1 year of age and full term baby, you feel he will be fine. Still full term and less than 1 month, this is a high risk. Or he has a chronic disease like bronchopulmonary disease or chronic lung disease or cystic fibrosis or congenital heart disease or immune deficient. Or there is a history of apnea. Oh, this is, you should take it serious. And usually these cases should be admitted. Management, what is the management? When we should consider admitting this patient? Can somebody tell me? Bronchiolitis patient. There is 2 indications, okay? Number 1 is, yalla, who will tell me? Hypoxia. Yani his saturation less than 90 or 92. You are right, Elias. Also poor oral intake. So you are afraid of dehydration. He's in significant distress and you know that he cannot tolerate oral intake. So these 2 indications are very important. Hypoxia and poor oral intake. But how we manage this patient? Nasal suctioning, Ventolin, yes. Most of the time we are using Ventolin, and some of them, they said, yet there is most of the studies said there is no benefit, but still there is some group, as you see the last line here, some group they may respond. So still we can give Ventolin. And you don't know, maybe there is a family history of asthma or allergic history, or the baby has eczema before or something. So a trial of Ventolin, yes, should be considered. And if he improved, fair enough. If he didn't improve, Ventolin will never kill him. Okay, very good. طيب, if he didn't improve with Ventolin, no matter what you give, he didn't improve. Okay, but in very small age, is there any reported effect? Yes, even very small age, you can give Ventolin, no problem. Okay, طيب. Because even the doses, because children, even very small age, they don't inhale very well. So the amount which will taken, it's very little amount. طيب, bronchodilator for bronchiolitis, yes. As a Cochrane review, they are still, all of them, they said there is no different, okay, in the rate of hospitalization and the rate of hospitalization and the length of the hospitalization too. So, but there is some short, maybe term of improvement, but it will not change the whole picture. Right. If he didn't, this is the usual, what we usually do. We will start by simple thing like Ventolin. He didn't improve the Ventolin, then I should consider given epinephrine. There is some studies, meta-analysis, suggested that a decrease in clinical symptoms when compared with either placebo or beta-2 agonist. And this is proven by studies. Okay? Mm-hmm. What about Atrovent? Still some people, they are using it, but as a standard of treatment, still there is no room for it, and it's not justified to be treated in the emergency trial. But you don't know. Maybe one day we will have it. And I believe sometimes it has some rule, but still, especially for those who are have a positive family history of asthma, or they have like allergic history, it may help, but still it's not justified based on evidence base. Okay. What about steroid and bronchiolitis? Who will give steroid? Yeah. And bronchiolitis. اللي يعطي steroid يقول لي yes yes، واللي لا يقول no. steroid. طيب. someone say no, someone yes. Okay, Yusuf said no. Okay. What about the rest? ما يبغوا يدخلوا يعطونا رأيهم. طيب, okay. Steroid and bronchiolitis. No. I think this is the right answer, no. But however, Suzanne Shu, who is the program director for fellowship program in pediatric emergency medicine in sick kids, okay, she did a study on a group of patients, and she gave them a steroid, and they did bronchiolitis cases, and they did well. Okay, and she made the study, and she advised to give a steroid for these cases. But later on, they discovered that her cases, most of the cases, they were the families of these cases, they are having like asthma and steroid, and also strong family history of asthma and allergic history. That's why they reject this study and said it's not anymore, it's not effective. Okay, so as you can see here, Buchanan Pediatric Emergency Care, okay, said that compared dexamethasone and placebo in the emergency department with bronchiolitis, there is no difference in admission at 4 hours. Okay. Bye. And this is a study of Suzanne Shaw. I just want to show it to you. Okay, that she has 70 children, and dexamethasone versus placebo, and dexamethasone more improved in clinical score وفيو hospitalization 19. بس عاد للأسف تلعب غيرها، لأن الحالات هذه كلها from asthmatic families or strong family history of asthma, just to let you know. But you don't know, maybe after 5 years, 10 years, there will be another studies, more studies, and it will suggest and recommend using a steroid. But as a standard of treatment, no, it shouldn't be given. And this is the American Academy of Pediatrics subcommittee recommending that bronchiolitis should not include the use of corticosteroid medication. And the treatment should routinely include bronchodilator, which is Ventolin. And if the Ventolin is not working, then you can give like epinephrine. Okay. And I noticed some people, I don't know why, they are start with epinephrine first. I think this is aggressive approach. Start with the simple thing first. If they improved, alhamdulillah. If they didn't improve and they are sick, then you can start the epinephrine. Okay, طيب. Any question for bronchiolitis before we go to the third case? طبعا usually bronchiolitis patients sometimes they go to ICU because of the hypoxia. So, and sometimes they need BiPAP in the emergency department before they go. So the most important problem that we face in bronchiolitis patients is the hypoxia. Okay, so we will start with the Ventolin. If they didn't respond, epinephrine. If they didn't respond, then we consider BiPAP. And in your experience, do you notice decrease in the rate of acute bronchiolitis in its season with COVID pandemic? Wallahi, yani Ramla, excellent questions. And the answer was yes, Hidayah, I think she's right. Yes, we noticed there is a decrease, to be honest with you. Not only bronchiolitis, most of the people, they don't have flu. يعني انتوا لو تلاحظون السنتين اللي كانت فيها البانديميك السنة اللي فاتت مثلا ما حد أحد جته viral illnesses ولا كحة ولا شيء. I think this is because of the social distancing and following the strict regulation والأمور هذه. تمام؟ I think also bronchiolitis attack, you are right. We noticed that. Yes, you are right. Very good thing to notice. وعلى قولتها yes, no daycare also. طيب. Any questions regarding the bronchiolitis or asthma? Please feel free to ask before we start the third case. Let me go to the third case. Okay. This a 3-year-old with cough at 2 a.m. The child had upper respiratory infection for 2 days and then began to cough with hoarseness and stridor. In the emergency department, he is febrile, 38, running around the room without stridor, without at rest. No drooling, lungs clear. MashaAllah. Croup, of course, there is nothing difficult in this case. It is straightforward croup. Okay. My symptoms data stage. All right. Bye. How you, let me see. Oh, yes, croup. Excellent. Bye. Do you do a chest X-ray for croup? No, excellent. طيب في ناس ما شاء الله عليهم very good and they are following. طيب no, big no. Okay. Please, guys, we should educate our colleagues. Some of our colleagues, they keep asking for X-ray like, mashallah, like anything. Okay, for bronchiolitis, for croup, for asthma, and blood work also. I notice in some centers, patient coming with asthma. Yalla, CBC, differential, IV line, why? Bronchiolitis, chest X-ray, IV line, fluid, CBC. Doctor, they will not accept him in the floor if you didn't do blood work. Come on, we should change this practice. Last time I had an asthmatic patient who is still hypoxic. He needs admission. And I told him there is no need to do chemistry or the CBC or whatever. He needs only Ventolin, and they said we don't accept him unless to do blood work. I talked to the consultant. I told him I need a justification why you need to do the one covering the floor. Why you want to do this? In a state in North America, they are charging the physician who is requesting unnecessary lab works. Okay? The insurance company and the hospital. Okay? For everything, it is really a waste of money. So that's why we have to change our practice. We have to try our best to avoid doing unnecessary labs. طيب. Very easy, very simple. So what is the management usually for patient group coming to the emergency? هذه أنا أعتقد إنه piece of cake. There is nothing difficult in this case, but you have to be careful. You may, okay? Dexa IM. هداية. بذبحك. There is nothing called, but good. يعني it is very nice. You mention IM. There is nothing anymore IM. Please, خلاص. And you have to disseminate this information to everyone. We don't give dexamethasone anymore IM. هداية تقول يا دكتور بس اللي عندنا في الطوارئ هو IM preparation. أقول لها okay. ال IM preparation, give it oral. There is no harm. طيب عندنا IV, give it oral, the same dose. There is no problem. واضح هداية؟ No more IM. Sometimes you give IM medicine, the patient will scream and he will be irritable more and then he will end up by intubating. Okay? Yes, we have to minimize painful trigger. Excellent. Like ENT exam, ya salam. Very nice, Ramla. This is very important. Okay? Sometimes, excellent. Put him in the most calming, position. I didn't even, sometimes I got upset to the resident or fellow, or even the nurses. They are taking the child and putting him in the bed. And he's screaming. He wants to stay with his mother. No, he should be there. We have to put a monitor, connect him to the monitor. Please, he doesn't need all this. If you want to connect the monitor, connect it while he is in the mother lap. Okay? You have to keep him in the most comfortable position. Don't mobilize, please. Otherwise, you will end up by intubating this child because it is upper airway obstruction. This is very important. Do we have to do labs? No. Do we have to do X-ray? No. Do we have to? Nothing. But we have to give steroid as early as possible. Corticosteroid, which is dexamethasone. Okay. Question here. If dexamethasone is not available, can we give prednisone orally? Yes, you can give prednisone. You can give hydrocortisone. You can give whatever. But you have to calculate the dose base. يعني حنا مثلا نعرف إن البريدنيزون اللي هو around 1 per kg to 2 per kg. Okay? الهيدروكورتيزون الدكسا, it is the most potent. يعني each 1 milligram of dexa equal 2 milligram, I think, 2 milligram of prednisone, while 1 milligram of dexa equal 4 milligram of hydrocortisone. So whatever you have there, you can calculate it and give it. طبعا الدكسا, why we prefer dexa? Because it has a long half-life, up to 72 hours. And we have to give dexa because also, as I told you, have long half-life, but you have to be careful not to exceed 14 milligram. Some people, they said up to 16. Even in adult, the maximum dose for dexa is 14, 12 to 14. Some people, they give 16, but you didn't exceed. Please. مو يجيني واحد يقول يا دكتور البيشنت وزنه 50 اوكي 0.6 معناته 30 ملغ يروح يعطيه 30 ملغ انت بتضرب له الرينال السوبرارينال جلاند وتضرب له شو اسمه اوكي so you have to be careful. طيب so we'll go to the management. As we mentioned, steroid is very important. Effective, طبعا in all cases هنا مكتوب effective in moderate to severe croup POIM. ليش كتبنا هنا IM? If he is refusing to take oral, some children they refuse to take oral. At this stage you have no choice. You can give IM. تمام? But still you can give it also in mild. I forget to mention it here. So it should be given in mild, moderate or severe. طيب what about epinephrine? Yes, if the patient has stridor, give epinephrine. There is no problem. تمام؟ يجي واحد يقول يا دكتور بس we give epinephrine but still he is having stridor. Okay. What should we do? Can we give more racemic epinephrine if we give one dose and he is not responding? You can give another dose. You can give her a third dose. You can fourth dose. No problem. Okay? Because you are saving the life of the child. There is no problem. Sometimes, if there is a significant, if still there is a stridor, but it's not inspiratory, expiratory only, يعني, with the stimulation, okay? You can start with Pulmicort. Pulmicort, it has an effect and it has no adrenergic effect, okay? So you can still give Pulmicort because they tested the Pulmicort, they tested in the, they said in the rabbit or, you know, vocal cord and it causes vasoconstriction, okay? And this will help in a stridor. Still, Pulmicort, it has a room, especially also for asthmatic children. If they are very tachycardic, someone will ask, Doctor, if they're very, very tachycardic, still I have to give Ventolin? This is an MCQ question. Still, you can give Ventolin because you are managing maybe the tachycardia because of stress. So still you can give Ventolin, but you can give also Pulmicort, hold Ventolin and give Pulmicort. There is no problem. So racemic epinephrine can be given, no problem. This is the way sometimes we can give it for those children who are not cooperative. Those who are not cooperative, we can give it this way, but we have to close it from this end. Close it from this end, okay? الماوس هنا ما يشتغل كويس. I've closed it from this end, so it will continue going to the mouth, okay? But in asthma, no, you shouldn't give it like this. And bronchiolitis, you shouldn't, because it is a lower airway obstruction, not upper airway like a croup. Okay, I think I finish. Do you have any question? Please, if you have any question, let me know. I think we have like 15 minutes because I should finish by 1:30. خوفتني الله يهديك يا صالح. لكن okay, if there's any question we can discuss. لا صح بس أنا بديت yes, I think I started like 10 minutes early. You need guidelines for what? Yeah, Modi, she's asking. I'm confused with your, I want to see the question that was not in the chat. What do you mean? Okay, any other question, please? I think this is very important. Guys, we'll go just to wrap everything together. For asthmatic child, those who are coming to the emergency, okay. I think this one, okay. By the way, the Ventolin, please make sure for Ventolin, we should encourage our patient to use MDI. We are doing a study actually in King Faisal. I'm in charge of this study to make sure the awareness of people how to use Ventolin with air chamber. And so far we discovered there is a lot of mistakes. They don't know how to use it properly. Okay. And for those who are interested to participate in this study, they can send me an email or whatever on my account, Twitter or whatever. Okay, because we discovered there is a lot of things the people need to be educated in. Okay, they don't know how to give it properly, the time and frequency of giving it, a lot of things actually. But I hope from this presentation you can know how to do it in a better way. Hussein, you're around? Is Hussein around? Our colleague Hussein Al-Hababa. I think we can take now a break and we will start at 2 o'clock sharp, inshallah. What do you think? Okay? I will go to the answers if there is any questions. A question from from Abu Bakr, Abu Hassan. If patient presented with moderate to severe asthma managed in other hospital with oral steroid, can we give with oral steroid? Can we give an IV prednisone if planning for IV line? I don't think there is a problem. You can give an IV. Sometimes in the first 24 hours, we give a steroid every 6 hours. So there is no problem. How to manage a patient with asthma if he also a cardiac patient? Well, it will be the same management, but you have to be careful if he is like having arrhythmias or tachycardia, but still it will be the same. This is why Abdullah Al-Mishari, this is why Abdullah, we have to educate the family and educate ourselves and educate all our physician treating asthma to be aggressive when we are managing this asthma, yani not to reach this stage like severe asthma or moderate asthma. Okay, they should use Ventolin buffs, you know, 4 to 8 buffs every 2 hours to 4 hours. Then, yeah, if you start to every 2 hours, then you can space it 3 hours, 4 hours, based on the response of the child. Okay, gradually. You know, most of the mothers, educated mothers now, they don't need to go to the hospital. They know how to manage it better than some physician. Okay. What about prednisone in croup? As I said, you can give it in a croup. If you don't have dexamethasone, you can give hydrocortisone. Tamam? When we can use IM epinephrine? سؤال حلو أسامة الناصر. يا أسامة أول شيء welcome أسامة. Long time I didn't hear from you. أسامة زميل لنا ومن أعز الأصدقاء. Yes, we can give epinephrine. I know rarely we are using it, but if you face a child who's coming with severe asthma, silent chest, silent, he cannot breathe, like in anaphylactic reaction, okay? Give epinephrine. Treat him like anaphylactic reaction. Give him epinephrine. You can repeat the dose till the systemic absorption work, and at the same time, Ventolin خليه يشتغل. Okay? I hope this answers your question. Manage, Iman, she's asking about how to manage secretion with bronchiolitis. Well, I think we have to be careful when we are managing. Most of the children, they are swallow, you know, the secretion, which is okay. But, you know, some RTs and some nurses, they are not suctioning very. You shouldn't suction aggressively, and only like less than 5 seconds to 10 seconds, like what's written in PALS or in NRP. Because the more you suction, the more you stimulate gag reflex, and the more they aspirate, and the more they got sick. So this is. Yes. There is a question from Reyes Sayed Idris. Assalamu alaikum. What is the dose and duration for giving continuous salbutamol inhalation? Continuous salbutamol inhalation, you can give, for example, 10 milligram, okay, for 1 hour, over 1 hour. There is no harm, okay? Or if you calculate, I remember it is 4 multiplied by the weight, okay, in 200 cc of normal saline, and to run over 18 hours. مثلا وزنه 10 تعطي له 4 يعني 40 ملغرام and over 18 hours. But you can adjust according to the response. There is no specific duration. Some patients, they continue on Ventolin. That's why I'm encouraging you to use puffs more. Puffs ما في مشكلة. طيب. أبو بكر يقول إني إنه use steroid in another hospital. يا أخي, there is no problem. No problem. He was given oral steroid in another hospital, then he came to your hospital. يعني just ignore that dose. يعني it is not going to be a toxic dose. No problem. When I consider nebulizer epinephrine for croup and stridor, when there is inspiratory, expiratory stridor, go ahead and use it. Okay. Can we use systemic epinephrine if the as a nebulizer, if the racemic epinephrine or racemic? Yes, you can use it, but it is 10 times. You know, racemic epinephrine is very concentrated. We used to give like 0.2 or 0.3 to younger age group, and 0.5 for older, like those who are more than 20. And for in case of systemic epinephrine, you can use from 2 cc to 5 cc. This week was any question? I know that you have so many questions, but very good, Sarah, to review it. And does given nebulize has a risk of oralization possible for COVID-19? Of course, this is very good, Imad. And when we need to avoid it, well, nebulizer, I think there is a mechanism where you can give the nebulizer, okay, it's been to reduce the distribution of the viruses and or the aerolization in the room, okay? There is, I think, the nurses, they have some way. I didn't remember it. We order the medicine, but for during COVID time until now, they are very careful when they are given, especially in high-risk cases. Helium oxygen mixture. Yes, it's been okay, but because of the concentration of the oxygen in the helium is low, so, and the patient, he need more oxygen. That's why it's not that well advisable to use. Oral dexamethasone, oral amodi, if the croup patient married him in ER, then he can. Yes, Dr. Noor Al-Amoudi asked, if the croup patient, we manage him in ER, then he came again after 2 days with the same complaint. طيب, there is so many reasons. For example, maybe the management was not okay. You have to give the steroid. We said, okay. But there is some group of patients, they do come back later. This is the allergic type of group. The allergic type of group, and sometimes they come back and the treatment will be the same. We can give them dexamethasone. Okay. Okay, good. What patient present with moderate asthma and resist? Can I give IV dose? And then yes, bronchiolitis. When we can use. Iman, she mentioned we can involve the family to use MDI in the emergency. Of course, and this is what they are doing. And now in North America and Europe, the family, they are there and they are learning how to give the MDI. And this is the best way. So they can do the same at home and avoiding coming to the emergency. Absolutely, you are right. There is a question here, I think from Ali Dawood. He said, any update about the use of nebulized IV, intravenous, I think, in severe asthma in the pediatric population, early CPAP, then bilevel, when hypercapnia develops. In adult, we notice significant drop in rate of, this is the main treatment now. If you require intubation, the IV Ventolin will be continuous, okay, and you reduce it according to the response. And most of the children, but there is some group of patients, they do respond to aminophylline. That's why they came back to aminophylline again. This is like companies, fighting who's, but still, yeah. Exactly. I think we talk about magnesium sulfate and we said it is very safe drug and you can use it. Okay. And this question, when should I use magnesium sulfate? After the 3 doses of Ventolin, there is no much response. Like if there is no response, you can use it after the first 1 hour in the emergency. Okay. And
Okay, sorry guys, the screen was not sharing. So let's continue and let's agree in the following points that our pediatric population, when they arrive to emergency or arriving to the hospital or to any facility, they face unnecessarily, experience of pain. Beside their original pain, they face other pain. Okay, and we have many barriers for assessing and managing pediatric pain when they arrive, whether to emergency or in the hospital settings. So our aim from this session is to empower our nurses, okay, about, assessing, addressing pediatric pain in an emergency setting for the physician, so they can, manage pain and they can live a comfortable experience for pediatric after emergency physician. Let's start, breaking some of the ice, the old myth, okay, about, pain, that young infants do not feel pain. And this is, comes because we are not, communicating. We cannot communicate with the pediatric, and we don't have like, they cannot express themselves. They cannot speak for themselves. They might suffer, severe pain, and we are unaware as a healthcare provider they are in pain. Children easily become addicted to narcotics. So there's a fear, okay, in the healthcare settings that children might get, addicted to the narcotic if they get prescribed narcotic. And children tolerate pain more than the adults. And again, this is because we think that, pediatrics, they don't speak for themselves. So we think that they are tolerating the pain, they can manage the pain, and they don't need any pain management. And the other thing also is that the myth, the children unable to tell where there is the location of their pain. And this is also, if we have really start conversation, if we have interviewing the pediatric, the child very well, okay, in a good manners, in a good way of interviewing and communication skills, we will be able to know where is the pain. Now the truth is, and this is what the science says, the central nervous system starts developing by 26 weeks old as a fetus, and start to have some nociceptions. Now, when talking about narcotic, less than 1% of children treated with opioids develop addiction. And children tolerance for pain increases with the age. That's what also another thing that, nurses, physicians have to understand that, tolerance of pain might increase with their age. Children can express and identify the use of proper pain assessment scale. So there is, and we will discuss that in a minute, the using of appropriate scale to measure the pain, or identify the pain, or quantify the pain. And children, we need to remember that they are smart. If we tell them, the right tool, they will be able to tell us, okay, and we can manage their pain properly. So why is pediatric pain management is inadequate? Again, there's exaggeration about and concerns about the side effect of medication. So most of, healthcare provider, they will avoid using, opioids, okay, or adjuncts when they're using pain medication, and they will go for the, the first line, pain medication like, paracetamol or acetaminophen. Delegation of pain treatment, and leave this, from, one-to-one, from senior physician to junior physicians. Lack of positive enforcement. Believe that children do not feel pain. Again, this is an area that, we should remove the myth that, children, no matter how they are, what age they are, even 3 months, 4 months, 6 months, okay, they feel a pain. Inadequate knowledge of the healthcare provider about, that pediatric, they can face pain. Problem with the pain measurement, again, we will reinforce about, using the proper scale to measure the pediatric pain. Now the facts, regardless the age, and this is very important, whether 3 months, 6 months, 1 year, 10 years, infants, the youngest premature infant has anatomical and physiological component to perceive pain. And we said that before, the central nervous system start to develop at 26, gestational age. So they will start to have nociception and demonstrate and severe stress response to painful stimuli. So this is a fact, this is a science, that they perceive all this painful stimuli. And now it's the burden in our shoulder. The burden is in our shoulder as healthcare provider to identify and quantify the pain and manage this pain. Let's take them in classifications. Okay, we'll talk about the newborn. And as we said, you know, the development of the central nervous system starts 26 gestational age. You have complete myelination of the nerve pathway, not required for pain transmission. C fibers and unmyelinated delta fibers are thinly myelinated. Incomplete myelination result in slower. That's where the a newborn, that there's a slower conduction velocity, but of a shorter distance. If you continue, complete myelination of the nerves or pain pathway or to the brainstem will be developed by 30 weeks. By the age of 37 weeks, nociceptive nerve ending, cutaneous and mucous surface by 20 weeks of gestation. So we are expecting, you know, the neonate by the newborn by 37 weeks that the nociceptives and receiving the ending nerves start to work. Now, what happens in the neonate as a post-operatively pain? There's a biochemical changes. Stress hormone get released, corticosterone, adrenaline, noradrenaline, glucagon, aldosterone, and metabolates, glucose lactate pyruvate. Now, facts about pain in infant and children in general. Unrelieved pain in infants, we talk about, can permanently change their nervous system and may prime them for having chronic pain. So instead of having, you know, couple of visits with acute pain, unrelieved pain, this can be, you know, changed to chronic pain. Children do not tolerate pain better than the adults. Now, if we're talking about the children, as we said, children tolerance to pain actually increases with the age. So as long as they're getting older, they're getting more, they aged up, okay, they became tolerance to the pain. And tolerance means, as you all of you know, there's, you know, a response to the medication with listen over the time. So if you're using this medication over frequent times, as long as, you know, they aged up, you know, the effect of the medication became less. And that's why you need to have a higher dose to meet the same, you know, management level or the same comfort experience that he used to have it like a year ago. Now, children can tell you where they hurt. So if the children after infancy can accurately point to the body area and mark painful site on a drawing, children as young as the 3 years can use pain scale. So I have seen, you know, as a healthcare provider, as a nurse, you know, even kids when they have, you know, infant, when they have otitis media, they start, you know, to pull their ear, you know, they try to pointing where is the pain. So they can. And when they are above the 3 years, they can easily using, you know, the scales. Now, children, and these are the areas that we need to focus on. We need to build this trust and to examine the children. They don't tell the truth about the pain. Why? Because they are scared. They are afraid. They know that they're coming to the hospital to get, you know, medication or injection, especially if they are chronic patients. So they know they're coming, they're getting inside the hospital, they will get injection and they will given, you know, needles. So they have fear, they are scared. So, and when you ask them, you know, they have, you know, connection between pain and injections. So that's why, you know, they try to hide their pain. But again, as we said, you know, because they believe others know what they are feeling, the burden is in our shoulder. Children do not become accustomed to pain or painful procedures. Okay, as we said, children often demonstrate increased behavioral sign or discomfort with repeated painful procedure as much as they getting, frequent visit, frequent procedure, frequent, admissions, they became, they're showing some behavioral signs of discomfort. They are not accustomed, but they were showing this. Consequences of inadequate analgesia during painful procedure. This is a study, okay, might be a little bit older study, 21 children, okay, and whether they have lumbar puncture or placebo for transmucosal fentanyl. And they found, placebo group rated pain higher than transmucosal fentanyl group. Then placebo group then received the transmucosal fentanyl, the number probably 5, still rated pain higher than the transmucosal fentanyl. And this is, that's, inadequate, or showing inadequate treatment in analgesia and during the procedure. Now, behavioral manifestation of pain may not be reflect the pain intensity. And this is, as we said, this is difficulty about assessing the children, developmental level, developmental delay, coping abilities, activity level, intensity of reaction to pain, influence to pain and behavior. It might be difficult for a physician or nurse, to really, if this is, can reflect the intensity of the pain, or how much, the child is in pain. Now, also another, factors that you have to put in your mind, that parents want to be involved in their child pain control. They need to know about information, assessing pain, and using intervention to relieve pain. Parental presence during painful procedure is generally desirable for child and parent. So we'll talk about, this is method, non-pharmacological methods that can help, decrease the pain. Narcotics are no more dangerous for children than the adult. And this is, as we said, the myth that we have to clear is addiction from narcotic is not, is very low. And the same percentage that you think that adult may get, the same percentage with the pediatric. Used to treat pain is extremely rare in adults. No reports substantiate that the fear in children. Reports of respiratory depression in children are rare. So they are safe to be used, especially if the pediatric in severe pain. Now, definition that confused with addiction. And we talk about the drug tolerance, that, when you need a large doses of opioids to maintain the original effect. So over a period of time, recurrent visit, recurrent pain, or after the child gets aged up, they will build up something called drug tolerance. So the usual or the start, dose that is starting for this pain cycle, okay, will not help. They need to go higher dose. This is not an addiction, and this is like confusion. This is a drug tolerance. The kid became tolerant to this medication. The kid aged up and he need a higher dose, but this is not like considered as addiction. The other thing is physical dependence. When the medication gets stopped from those patients, okay, as a opioids, okay, they're showing some withdrawal symptoms, especially when chronic use of opioids is discontinued, or a patient given an Narcan. And these are confused. These terminology get confused with the addiction. Now, narcotic addiction behavioral and voluntary pattern. If you see any narcotic kid or who's really addicted to the narcotic, you will see some compulsive drug seeking behavior, leading to overwhelming involvement, okay, use of opioids not for medical reasons, such as pain relief. So they will become drug seekers and they will show some behavioral. Now, the golden rule when we talk about pain is pediatric, that pain is whether whatever is experienced, person says it is existing whenever he says it does. Believe the patient, and that's the most important thing. It's not about me. It's not something, an objective. It's a subjective. Whatever the patient is saying to you that he has a pain, you have to believe him, even if he's saying pain 10 out of 10 or he's in severe pain. The healthcare provider has to believe the patient, have to leave the child, okay, and not, put experience in order to say, oh, he's not feeling pain, he's not in pain, he's a child, I don't trust him, he doesn't know what's the pain scale. So we have to believe what they are saying. And we have to admit that children's pain continues to be poorly controlled. Pain during procedure and surgeries, post-operative pain, disease-related pain are inadequately controlled. Now, end of life also, we have to think about end of life. If you have, if you are in a tertiary hospital and you have a cancer patient, leukemic patient, PMT patient, failed transplant, those patients who are in, facing, a cancer pain, and this is a chronic pain, they need to be on a strong medication at home. Even when they get admitted, they need, a palliative care nurses assessment to look at their pain and make sure even the pain team or the pain service has to look at their, pain and make sure that their pain is attended and assessed and managed very well. Now, when it comes to the pediatric, pain assessment, we have to put in our mind that 4 aspects must be addressed, okay? And these aspects, physical, psychological, social, spiritual. Last 3 can be met only after pain and related symptoms are controlled. So if we think about, that we're looking for physical, psychological, social, spiritual. So this is like a difficult dilemma that we need to think about. So the child is, you need to think first about, controlling the pain by the medication. Then you look to the other, spiritual, social, and psychological together. And if we manage to do this, we complete the whole picture and we'll have a happy child and a happy experience in your department. Evaluate behavior, psychological signs, secure family involvement, take cause of pain into account, take action and assess effectiveness. And this is, about using pain scale, looking to the behavioral, aspect of pain, looking to the physiological aspect of pain, and get family involvement as well, okay? And what is causing pain to the pediatric, to the child. Question the child verbal indication for pain. That's if somebody reported that the voice is a little bit low. I'm gonna use the mic, maybe it might be very, tell me if it's better or not.
Your voice is very clear. Maybe
Okay.
the one who has a low, he should increase the volume in his computer or his mobile.
Okay, thank you, Dr. Fefi. I'm using the mic now, maybe it's better. Anyway, so much less common in the adult may not understand the terms such as pain. And we'll speak in Arabic here. I guess most of our audience are Arabic speaker. So choose the terminology that the child might understand. So example, you're gonna ask him يعني ايش اللي عورك in Arabic. So he doesn't know what alam, maybe كلمة alam, a word alam is not well understood for him. So use method what they are using in their in the community. So if they're using awrak, if they're using other terminology, you guys may be experienced than me, you have to use it. So you have to use the word that the kids use and understand to know what's the meaning of pain. May deny pain for fear of injection, cries, scream, groans, and moans. Again, this is an area that we have to think about it. The minute the child is step in the hospital, he start to cry and start, scream, not because of, screaming from the injection. He has a big fear and he's scared from the injections. He has a pain, but now, the anxiety level is higher than the pain. And we'll talk about, sometimes when the anxiety above the pain level. Use variety, as we said, use variety of words to describe pain, such, this is an English, ooey, woo, ouch, hurt, oh no, that's an English. Now you have to define other words in Arabic, okay, that match your community and your culture. What kids using for pain, okay? Are they screaming? Are they using like hour, like, oh, ouch, whatever, okay? They're using, you need to use these sounds even, not only a term, sounds. So you verbalize it for them in order to make them understand. This is, he's voicing the same, my terminology for pain. Also marking body parts. That's, how do they locate, marking body parts on the human figure, drawing point of area with one finger on self, doll, stuffed animal point too. Where mommy, where or daddy, would you put a bandage? So you have to, again, as we said, you have to be smart because they don't understand our language as adult, and you have to go down to use their language, and you have to have some communication skills. And by the way, Dr. Fefi, he's with us, hearing us. He is an excellent example when it comes to the communication with the kids. He make them engaged easily and they can express, their feeling, and he can easily assist them.
Thank you, Dr. Hussein. Thank you very much.
You're welcome, Dr. Fefi. Using Bain's rating scale. That's, that's our, aim here, is which pain scale that, is better to use for pediatric, and which one can quantify the pain and will make it easier for you to address the pain for the physician, and in order to get, the right medication or get right experience and get the child, managed very well. And remember, using different scale will not help you, or different using wrong scale will not help you to get, the right, pain rating. So select a scale that's suitable for the child age, abilities. Look at his ability, cognitive, developmentally, and preferences. Teach the child use the scale before the pain is expected. That's if the time permit, such as, that's like, in emergency, we don't have that, the luxury to have pre-expected, before the pain happens. They usually visit because of pain, but if the patient going pre-operatively, you might ask him before, in the day procedure, okay, in the day procedure about, the pain, explain him the scale that you will use. So post-operatively, you can use this pain scale easy. Now use the same scale with the child each time pain is assessed. Ask the child about the acceptable or functional pain level. Now, first one, we use the numeric scales, okay, and you can see using faces that can tell about, how bad and how severe, how moderate, how mild the pain is. And this is from 0 to 10. Now, using the flag one, okay, that is up to like, 17, 18 years. Okay, you can use it from 3 years and onward. And you see the flag is using the face, using the legs, the activity, and the crying, and the consolability. So sometimes it's difficult to assess pain in children who are non-verbal. So the flag pain will help you, can help parents, professionals to assess pain level in children who have limited or no expressive communication. And we can see that, severe pain when we are rating to 7 out of 10. So the patient will have, frequent or constant, quivering, kicking legs, rigid, jerking, difficult to or inconsolable, or showing discomfort. So if the child is really 7 to 10, so that's for if the child is non expressive, or he cannot express himself. Now, behavioral pain rating scales for infant and non-verbal children use appropriate observational skills. So use the cries, as we said, for 32 weeks to 60 weeks gestational age, flag full term, neonate to 7 years, and you have the neonatal pain assessment agitation sedation scale as well. Now you have to evaluate, the behavioral and physiological changes in the pain. Now, acute pain versus chronic pain. When it comes to the acute pain, body's fight or flight stress response, that's in the acute pain, and you'll start to have some physiological changes, and we'll talk about that in a minute, like the heart rate and the respiratory rate. But when the patient became adapted to this pain and the pain became chronic, the stress response, the adrenal gland, and the hormones are not anymore released. So you will not have any physiological, changes in the patient. And we're talking about this physiological changes. Most of you know this, fight and flight, like, dilated pupil, increase respiratory rate, increase, heart rate, decrease blood pressure, decrease urine output, decrease peristalsis. All of these, that, comes with the increased response to the sympathetic nerve. Possible, physiological signs of pain in neonate. If you look into the neonate, you have increased heart rate, respiratory rate, blood pressure, respiration, vagal nerve tone, diaphoresis, palmar sweating, okay, decreased O2 saturation, and EKG changes. Now, possible signs of pain in neonate behavioral. They're crying, change in their sleep, wake cycles, change in their activity, agitation, restlessness. All this is kind of behavioral changes in the neonate. Also, it can be also pain in neonate, like limb withdrawal, sweeping or thrashing, rigidity, flaccidity, clenching of fist. This is all kind of, also behavioral changes in the neonate. Now, when it comes to the management itself, after we've done the assessment, facial expression, most reliable signs. And I would like to mention something, that one of the physicians always used, and I like this question. He always asked the mothers or the caregiver, have you ever seen your child smiling today? So children, by their nature, they are, smiley creatures. They smile. The minute you play with them, or you give them some nice things or music or anything, they smile with you. They sing with you. And a good sign for that, if you see them not smiling, that means that they are in pain or they are sick. Eyes tightly closed or open mouth, you have bulging brow, deepened nasal labial fold. This is all signs of, facial expression about pain. What are the consequences of pain? Patient became irritable, scared, increased oxygen consumption, ventilation perfusion mismatch, decrease oral intake, increased gastric acidity. That's immediate. In a short term, he became, enhanced catabolism, need for more energy, altered immunological function, delayed healing, impaired emotional bonding. In a long term or chronic, he will have, a hardship about memory of pain, alteration response to the painful experience. And you may see this as a healthcare provider with the cancer patients when they come to the emergency. They lose their interaction, they lose their, communication with the healthcare provider, with the environment. You see them like, in another world, in another, they are not like, because of the bad experience in their mind and memory, they became preoccupied with this, feelings. The most important thing that we have to highlight also, that pain versus distress. As we said, when they come to emergency, they are scared and they have some fears. And young children, they're unable to describe their sensations. So we have to guess why they are in pain. We have to assess, and we have to quantify, and we have to recognize their pain. And we are probably not great at that. That's one of the studies. Children who can communicate often rate their distress higher than their pain. And that is an issue with it, because their fears, their worries, they're scary, making them, higher and than the pain itself. In younger children, the inability to communicate means that we are forced to make assumptions. And I think that it creates an ethical responsibility. And this is what we said in the beginning. We should not assume, we should not consider, oh, he is not in pain based on our, uh, experience, based in our, if we don't use the right tools, and we did not, initiate and get history about the baby or the child, we should not be, because at the end it's an ethical responsibility, and we don't want, again, as we said, leave them in a chronic pain and bad memory and bad experience. Now, the golden rule that we want to take home message today is, the best strategy to reduce pain is simply to avoid causing pain in the first place. So the child may comes because of, otitis media, or because of, fracture. We don't want him to have other pain. So instead of giving, procedures, invasive procedure, needles, okay, try to minimize all of these things, and concentrate to listen his pain and manage his pain. In many, situation, you will see the child will cry, and his, maybe about IV, maybe about NG tube, maybe about a Foley catheter. So these are invasive procedure, painful procedure. Okay, so now he forget totally about his otitis media, or about his abdominal pain, or about the pain. He is now concerning about, the tube that you're gonna insert, the lines that you're gonna put in his hands. So try to avoid, or sometimes one of the strategies, group all the procedure together. So you don't come like, do IV, after like, 15 minutes, we'll do blood. After like 30 minutes, we'll do blood culture. So this is a very invasive, and this is, making the child, experience a lot of pain. So try to group all these invasive procedure at one time. So otherwise, if you're gonna come every 15 minutes with something, you're gonna make his, you're gonna make your life, actually hard, and the child will have a bad experience. And remember always, remember that you be kind with them. And be kind with them that, you know, the non-pharmacological, you know, stuff that can be done in the hospital, like breastfeeding, tucking, holding, swaddling. As we said, you know, assist them, you know, while they are in mother lab, while the mother is holding them, listen to their chest, you know, while the mother is hugging them. Try to, you know, to initiate some of these things that, you know, may calm them. It's not like analgesic, but it will calm them and it will make your job easier, and you will do the procedure, you know, easier and faster, and will make it, you know, less painful for them. And as a healthcare provider, you know, for me, seeing kid crying while I'm doing an IV, this is actually, you know, irritate me sometimes and make it very stressful for me to get it from the first time. So you have to find a way where you make them, you know, at least, you know, calm before you do the procedure. And this is will help you doing the procedure from the first time and, you know, succeed from the first time. And limiting overall distress again. Distraction technique that might help you with other, you know, when the child is in older ages, giving smartphones, giving them, you know, thermometer to play with, you know, headset box, you know, iPads, name it, anything that, you know, is safe and will help them to be distracted while doing the procedures. Okay, that will help, you know, to decrease the pain. Now, the most important thing is avoid use language that falsely reassuring. And this is one of the issues that we have to put in our mind, that the kids, you know, if you lose the trust with them, okay, if you tell them that this is will not hurt and you hurt them, they will not trust you. And that not only you, they will not trust any physician, they will not trust any healthcare provider. So don't, you know, break that, you know, the rule. Tell them that, you know, it's gonna hurt, tell them that it's gonna be painful, okay, and tell them exactly what will happen, okay. And as we are from, you know, I would say, you know, Arabic culture, we tend to, you know, make things nice, like, you know, it does not hurt, it will not hurt, but actually it does. Actually, it is painful. So tell them the truth. They, okay, you might feel a small thing, it won't really hurt, or negative, this is will feel like a bee sting, this medicine will burn, don't cry. You have to tell them the truth. They understand what they are and they trust you. Now, what are the best route for to give this medication? You know, oral, intranasal, topical, intravenous routes are preferred. Intramuscular injection should not be used to manage pain except on discussion with the consultant. Subcutaneous route is useful for children receiving palliative care or where IV access is extremely poor. Now, it depends, you know, there are contraindications like using oral if your patient having, you know, nausea, vomiting, if your patient have, you know, intestinal obstruction or going MPO or surgeries. So it might be intranasal, you know, it's a limitation of the volume that you can give. All of this has some limitation, but are they preferred? And intramuscular is very painful for a pediatric. One of the special consideration that can be used also is modalities that we can use saccharose, administer orally before performing painful procedures, especially for less than 3 months babies. Example, before heel, break, before eye examination, insertion, removal of IV, phlebotomy, insertion of gastric tube, has shown to decrease the duration of crying, facial action associated with pain, heart rate, and composite saccharose in infant use at less than 3 months. That's one of the modalities or consideration. Some modalities also in acute otitis media, lidocaine drops 1 to 2%, topical and still in the affected ear, and have the patient lie with the affected ear up to 5 minutes. Provide short-term pain relief. And this is to be used in emergency, not a patient going home. Pharyngitis, dexamethasone has shown to be effective. So these are not, some of the special concerns. To be effective in reducing pain associated with pharyngitis and used in conjunction with the antibiotic. Coronial abrasion, one of the, the eye drops that we use, tetracaine. It helps, to achieve analgesic effects if there's any like trauma or coronial abrasion. Lidocaine, or what we have different names. It depends what you are using in your hospital or institution. We have EMLA, we have lidocaine, adrenaline, tetracaine. These are applied 30 to 40 minutes prior, laceration repair and cover with occlusive. Not suitable for areas that, in the peripherals where it may cause vasoconstriction. IV cannulation, phlebotomy. Now, using EMLA, it can help, decrease the pain for 45 minutes, especially if you're doing IV, providing that, it may cause vasoconstriction, affect, seeing the veins. One of the modalities or consideration to after using EMLA cream for the IVs is to use warming baths. It will help again for the provider, help the nurse to see the IV at the same time, will make sure that pain is free. And it is contraindicated in infant less than 1 month because of the skin toxicity might happen. Fentanyl intranasal, initial analgesia, aged a year or older, in moderate and severe pain. If your patient complains fracture, dislocations. Now, when it comes to the mild to moderate pains, as we said, it can be starting dose with non-opioid analgesics. Acetaminophen, okay, the route here using oral, using IV, and the frequency. Using ibuprofen more than 6 months. This is the recommendation, 5 to 10 milligram per kg. Other medication like ketorolac, indomethacin, or naproxen. That's for the mild to moderate. Opioids, when it comes to the severe, using fentanyl, hydromorphone, methadone, morphine, and oxycodone. Okay, and these are the doses that can be used. Fentanyl, 1 mics per kg per dose, and 1 to 2 mics. And when it comes to the child, more than less than 50, hydromorphone, 0.015, methadone, morphine. These are the doses, whether oral, IM, or IV. So as we said, intranasal is one of the modalities that can be used, not for smelling only, also for to give medication. It is a fast. Actually, it's not only for that. We can use it for patients. If you have the atomizer and you can use it to subside seizures, it's better than even the rectal ones to be used if you have atomizer to give midazolam. Fentanyl, 1 to 2 mics per kg maximum dose, expected in 10 to 15 minutes. Nausea, vomiting, respiratory depression, that's the expectation. Midaz, it can be anxiolysis and sedative, 0.2 to 3 milligram, maximum dose of 10 milligram, expected in 5 to 10 minutes. Ketamine also can be used intranasally, okay, 1 to 1.5 milligram for pediatric. So mainly these are the routes that can be used. Make sure that all pain assessment, reassessment should be documented. Not after giving you reassess, maybe the child need more pain medication. Education, patient family should be involved. Parents during the procedure, explain everything to them, educate them, and once he get discharged, explain about the plan of care, medication, frequency, and observation at home. Last, ABCD, ask about the pain regularly, assist pain systematically, believe the patient, believe the family, choose pain control option appropriate for the patient. Okay, deliver intervention in a timely manner, empower your patient, empower nurses, empower, to advocate for pain. And the conclusion, remember, the only reason to assess pain is to take action to relieve pain. So you don't assess pain and you don't treat pain at the same time. After intervention, assess the child. Determine timing for assessment based on the expected onset and peak effect of intervention. So if you're giving oral, you expected that, the peak effective like after 1 hour. So you're gonna assess the pain after 1 hour. If you're gonna give IM, maybe after 30 minutes. If you going give an IV, maybe you're gonna check your patient after 15 minutes. Final message: children, especially those who cannot speak, are vulnerable population whose pain is constantly undertreated. This is unacceptable, especially when considering the wide variety of treatment modalities we have nowadays. All emergency physician and healthcare providers should be comfortable controlling pain in pediatric population. And remember, what is painful to an adult is painful to an infant and child until proven otherwise. This is about the pain management for pediatric. I have to look at the questions here from Osama. I have seen many sicklers, adolescents come frequently with severe pain and treat with morphine. My question, how can I differentiate between real pain and addiction? Good question, Osama. As we mentioned, we have to think about tolerance, first of all. So, as you know, what used to be, effective for them, at some point, okay, is not anymore effective. So you're gonna need higher dose to reach to the same effect, to the pain management. So this is called tolerance. Now, as we said, there's a behavioral, components to the addiction. It's not only about, he's in pain. Sickler, they will have frequent cycles of pain and visit to the emergency. Now, part of this, as a clinician, as healthcare provider, you need to look to the behavioral addiction symptoms. If patients is showing behavioral addiction symptoms, we call this addiction. Otherwise, it is more a tolerance. So he need more a dose. And that's why, one of the question you need to ask, patient when they arrive to the ER and look to the, especially if you have to look at their, previous history. Let's say he came always with, back pain as a sickler. And last time, his back pain was, he was giving 2 milligram morphine. Now 2 milligram morphine need to be more, or to at least 2 milligram. So if you give him 1 milligram morphine and he still have pain, this is not an addiction, because you did not give him the right dose. That he used to receive 2 milligram every time for back pain, and this became like, chronically for him. Now, if you come and give him 1 milligram or 1.5 and he's still in pain, that means this is not addiction. This is a tolerance. You should give him the right dose that can overcome the tolerance. Is it true that lidocaine spray working in mucocutaneous area, meaning it's useless to use in a cut wound? Yes, all the spray or that can be used. We are not or use them in open wounds. Yes, we seeing like ethyl chloride sometimes, the freezing, sprays that can be used, but should be used in a closed skin or skin should be intact. If no further question, we'll give you like 5 minutes then before we move to the last one from Iman. She mentioned about how to manage anxiety and pain associated with establishing with IV line access in a sick child. When do you have, when we don't have IMLA? Now, even, if the time does not permit you and the child is very sick, okay, and this is not the time you apply IMLA for them, okay? If your child is in acute, critical situation, you don't apply IMLA and you wait 45 minutes. You need to start intervention and you need to manage your patient ABCD, and this is require, sometimes aggressiveness. But again, you might have used non-pharmacological, the techniques where you can, if the child is infant or he's 6 months, where you can wrap him in a blanket, put him in the mother lap, where you can feel that he's safe. At least in the mother lap, he will feel that he's safe. He can see family to be there, mother to be there. This is, will decrease the stress and decrease anxiety, maybe will calm him down and make your job easier to get the IV. Again, thank you very much. We'll give you 5 minutes before we move to the next session. We'll back with you again to talk about, some modalities that can be used when you have a difficult IV access. And one of them is the subcutaneous rehydration therapy. But before we go on that, I would like to share with you the level of recommendation for practice as per the Emergency Nurses Association and for difficult intravenous access. So the level 1A is highly recommended and reflects higher degree of clinical certainty among all the clinicians. When it comes to level B, there is reflects moderate clinical certainty among the clinicians, okay? And talking about level C, which is weak recommendations and based in consensus, usual practice, evidence, case series from study, treatment, screening, and evidence or opinion. There is limited, low quality patient-oriented evidence, has relevance and applicability to the emergency nursing practice, has limited or unknown effectiveness. And you have the last level, which is not recommended for practice. So when you experience a pediatric patient who has difficult IV access, okay, and what are other modalities can be used to improve, to look at the ultrasound guided intravenous access. I'm not sure how much you guys in your institution or other institution they're using this, and but it is one of the modalities that have been studied in pediatric population. In adults, several parameters have been studied in relation to the ultrasound use and IV standard technique. including the success rate. However, that in pediatric, there's a limited and there's no data about, using this. Successful, with the ultrasound guidance, as we said, appears ultrasound guided IV cannulation maybe improve successful rate. The evidence is not conclusive regarding the benefit of this technique. And whoever has used it, he will know, in a sick child, you need somebody who is very cooperative, very calm, need a good situation, not a very, small child, young child. So it needs specific criteria in order to this. And the ultrasound guidance may allow quicker IV cannulation, but again, the evidence is limited. Make it difficult, to make a recommendation about using ultrasound in pediatric. Intraosseous, yes, to be used, and I think the latest study is talking about, current data focus success rate of a manual drill assist IO insertion device between the manual or the dress, especially in less than 8 kilograms. Which one is better? The manual one was successful in children in both less than and more than 8 kilograms. So look like, there's in less than 8 kg, maybe the IO drill one is less preferred. And this is our topic, which is the subcutaneous rehydration therapy. And in pediatric, but it is extensively investigated, and this is what we will talk about. And if the time permit, guys, I would like also to share with you about the external jugular axis. If you guys familiar with, or you're doing this in your department. So many times, we fail, to insert IV for pediatrics, and we try, to be everywhere in the pediatrics, especially when they are sick, especially when they are young. But sometimes we fail to get an IV. So what are other modalities? As we said, subcutaneous rehydration therapy, and we will, share with you about the also external jugular if we need, before, you go to the last, thing that we think about using, the vascular team or the surgical team to have a central line for the pediatric. So what is subcutaneous rehydration therapy? Is a physiology involving appropriate function of sodium-potassium pumps, and this will allow for an osmotic gradient, to happen, to occur, and the concentration of fluid will gonna move from the greater, area to the lower area, and this will allow fluid to shift from interstitially to the intravascular. Subcutaneous tissue is a dense matrix of hyaluronic acid, or what we call it hyaluronine, and it delays, and this matrix or this tissue, it delays absorption of subcutaneous fluid into the vascular compartment when fluid infiltrated. So in a normal patient, if you have an IV cannula, and this is what happens usually. If you have inotropic, if you have vasopressin, if you have vesicant drugs that might be infiltrated from IV cannula, it does not reach the intravascular. It stays in the extravascular and mainly in the interstitial. And this can cause, as we said, might cause, necrosis, tissue necrosis, gangrenous digits. It depends where is the IV. But again, what to prevent this, medication from going inside the intravascular this is the matrix that we have, the hyaluronic acid. And this is, preventing this fluid from shifting inside to the intravascular. Now, hyaluronidase, naturally occurring enzyme, breaks down the hyaluronan acid and allows a new matrix to form about every 24 hours. So that's one of the things that before we start the subcutaneous rehydration therapy, we're thinking about, giving this enzyme, okay, the hyaluronidase, and this will break the hyaluronic acid and will allow, fluid by injecting small amount of hyaluronidase, okay, 150 to 200, okay, units, 1 ml single dose vial into subcutaneous area. The matrix will be temporarily broken for 24 hours and allow space to develop under the skin, and the fluid can shift to the more easily absorbed to the intravascular. Ultimately, the time of absorption from the infiltrate into the vascular compartment and capillary bed in enhanced when matrix barrier hyaluronan or hyaluronic acid is removed. So removing by giving, as we said, the natural hyaluronidase, and this will break down this matrix and will allow fluid to shift inside the intravascular system. So when do we use subcutaneous, rehydration therapy? When parenteral rehydration or oral hydration therapy is needed for mild to moderate dehydration patient in whom, oral hydration therapy has failed. So you have somebody who needed hydration, pediatric child who needed hydration. Now you have parenteral rehydration therapy in need, and patient, fail to have oral hydration. So you can use the subcutaneous, rehydration therapy. Patient with are not in life-threatening, requiring fluid rehydration. So device access are not in life-threatening. We will use for them. The subcutaneous rehydration therapy. So if you have a patient, as we said, failing the oral hydration therapy, you can use for them this one, the subcutaneous rehydration therapy. Now, contraindication. What are the contraindication? The contraindication for a patient with subcutaneous rehydration therapy: patient with severe electrolyte imbalance, indicating dehydration, emergent situation, shock, circulatory failure, fluid requirement greater than what can be infused by the subcutaneous rehydration therapy. Infusion of area that have cellulitis, infection, and hyponatremia or hypokalemia. This is all can be, contraindicated. Or patient in ICU, patient with bee sting allergy. Just to remember, that one of the component of the venom of bee sting allergy is the hyaluronan that is found in the in our skin. Okay, so that's prevent fluid from shifting inside. So the hyaluronan is found in the bee sting venom. So if you have somebody who is allergic to bee sting, you will not be able to give them the hyaluronidase that can break down the hyaluronan. And these are the contraindication. How to do it? Now, this is, that we have to think about, how to do it. The appropriate selection involve involve essentially any area where the skin and subcutaneously can be pinched. So you need to pinch that, the skin. Optimally between the scapula is the preferred, site for children for several reasons. Why between the scapula? Out of sight, out of mind. The kid cannot see it. The family also, they cannot see it. And it provides more diffuse subcutaneous area than other locations. Parents, they can hug, as we said, we talked about the pain, they can hug their children easier, and they can hold them during insertion as well. There's no need for restraint, okay? The area is less sensitive to pain than the other areas. And you can see in the picture here, they're pinching the skin and they're inserting the IV. They use insertion device of 25 gauge butterfly, or sometimes 26, it depends what you have, or 24, but these are the preferred ones. Connection tubing should be gently flushed, as we said, with 150 or 200 units of hyaluronidase, with the skin and subcutaneous tissue pinched once. One should insert the needle quickly into the pinched skin at 20 to 30 degree angle and check for blood retain. Now, if you do have blood retain, remove your needle right away, and because the direct contact with the blood will inactivate the enzyme. So you need your hyaluronidase to be activated. If it really hit blood, it will get deactivated. That's why you need to remove it if you have any blood retain. As you can see the picture here, primary tubing with subcutaneous needle and order dose 200 hyaluronidase, and prep the skin for needle insertion. As we said also here, skewer, you put skewement. You can see it here, begin. Subacute fluid administration via infusion pump. Bolus of fluid will be normal saline. Continuous IV fluid can be normal saline, can be D5 water, and can be D5 have normal saline as well. Start at 25 order rate. So if you're giving like 100 ml per hour, start at 25%, 25 ml per hour, increase by 25% every 5 minutes till you reach the targeted dose. Expect slightly red, as you can see here, and fist-sized blip and infusion site for first 5 minutes after initiation, painless. Swelling will soften and will go away after approximately, and 3 to 5 inches, and resolve soon after completion. So you can see in the C here, there's completion of the IV fluid, the swelling have, almost totally gone. Document the site Q1 hour, change, site Q 24 hours or 48, as we said, because now you need, the hyaluronidase need to be injected again every 24 hours to make sure that these fluids are shifted to the intravascular. The other thing is obtain vital signs. Obtain vital signs and assess fluid status as baseline after each bolus. Provider will reassess after each bolus or 24 hours for continuous infusion or place subacute or new subacute order if indicated. Now, is it a bridge to the IV therapy? This is studied in 2013. Okay, subcutaneous fluid infusion with intravenous fluid infusion in children with difficult IV access. They found the mean time for order entry subcutaneously fluid infusion to be 20 minutes compared to the failed IV access group with an average infusion rate of 1 to 2.5 hours. So it's a faster. The latter group eventually received subcutaneously fluids. The investigators also found shorter ED length of stay for subcutaneous group. In the same study, subgroup received subcutaneously fluid initially and later an IV. They found a trend of easy ease IV access after subcutaneous fluid. Even if you have, this means, even if you have a difficult IV access kid, and you could not get it like, first, second time, start with your subcutaneous rehydration therapy. This is later on will ease your, process for getting an IV access because the kid will get hydrated. Now, what are the predictors for difficult IV access in children? There are many studies talk about, putting a tool to predict which IV access, or difficult IV access in children. But in general, the most often cited are age less than 3 years, weight less than 5 kg, prematurity, obesity, dark skin, tones, appears to be, one of the difficult or parameters contributing factors to difficult access. 3 main predictors of score validated, in annals of emergency medicine include the most practical universal feature: vein valvability, if you can valve the vein; vein visibility, you can see it or not; or patient age. These are most contributing factor to the difficult access. And one of the, I think once you find that you have a difficult access, you need in your department to minimize the trial and get the most experienced nurse, or the most experienced, skillful nurse for IV to try, because you minimize the trial for such difficult access, you may be able to get from the first or second time. You open and anybody can try. You, especially with poor access kids, you lose the chance and you ended up having, a dilemma to get a central line for those patients. What medication can be given subcutaneously route? Yes, all the medication can be given subcutaneously route, like, antibiotic can be given, pain medication can be given, subcutaneously. Question: what if I don't have the fancy hyaluronidase? As we said, even hypodermoclysis, which is, subcutaneous rehydration therapy, will work without hyaluronidase. The process of subcutaneous rehydration just take longer time. So it would take longer time to absorb fluid if you don't have the, the natural enzyme, which is the hyaluronidase. How long you will leave the subcutaneous line in? The longest time that subcutaneous line has to be reported in the left to be left in the patient is about 48 hours. Reports relieving subcutaneous line in a geriatric patient for longer period. Can a fluid other than normal saline linger lactate be administered? Yes. Fluid, any fluid that contains normal saline linger lactate acceptable. D5, with potassium fluids such as D5 is too hypotonic. So you don't use too much hypotonic, and you prevent, the osmotic, gradient to be happen. So you're gonna use most, isotonic fluids that can be diffused, or diffusion can happen easier. Does it hurt? Nerve ending in the middle layer of the skin, which is pairs. Nerve fibers that run along the blood vessel make intravenous hurt more than the insertion. So when it comes to the IVs, when it comes to the intravenous or to the subcutaneously, it's more painful with you doing with the IVs. With this method, the skin is pierced, but the needle goes into the fat, subcutaneous tissue, where there are a few or no nerve ending. So this is less painful because we use very small needle. The gauge, as we said, 24, 25, 26. It can be a topical anesthetic may be used to take away this pain at all. Also, we can apply, any topical anesthetic. In summary, hyaluronidase augmented subcutaneous rehydration therapy becoming accepted alternative in children with mild moderate dehydration when oral rehydration therapy has failed, or intravenous access is difficult. Okay, while use the nasogastric, or we have a poor access difficult. So the two indication, you have oral rehydration therapy failed because patients vomiting, or you have a difficult access for kids. Those patients we need to use for them, subcutaneously. Especially if you are in an institution where your, surgical, options are limited, or you don't have the options of interventional radiologists to come at night and start, IV for pediatric patient. The use of nasogastric tube is an accepted alternative. However, this technique is very invasive, usually require restraining the child extremities and can lead to complication. The use of oral Zofran has enhanced ORT, but it is not always successful as well. These are some of the references. Let's go to the questions. Now, most EDs nowadays should have ultrasound machine and use IV guided, ultrasound insertion to it. It is very useful. Yes, I agree. It is very useful. But as we said, even the researchers and the data, they think about limited, studies, trials on this in pediatric, especially when they are infant or less than 1 year. Correcting severe hypoglycemia with use of this technique. As we said, first you're going to use dextrose that is really hypertonic, and this can be, not tolerated by the subcutaneously tissue. So this is a way of rehydration, is not a way of correcting, electrolyte or correcting a situation like this. There was a question previously about the compartment syndrome and pain not responding to the compartment syndrome. Now remember, whether the cause of the compartment syndrome is infection or cellulitis or injuries or trauma or fracture, your indication that you assess the pain for the patient, and once your patient triggering for extra pain killers, okay, that means that he start to have compartment syndrome. This is triggering, using of or requiring more pain. More painkiller is one of the scale that you use, especially with compartment syndrome, that your patient start after injury or after cellulitis to develop compartment syndrome, and this is one of the triad for the compartment syndrome. What else? I don't have a video, Iman, to share with you about using this technique, but I will look it up in the in the ANA, and if I do have one, I may share it with the company, and they can you can contact them, for this, if you do have competences in your hospital also. Now, when it comes to the bump, Imad, you can use the usual, bump for this one.